Hello. Okay.
என்னது அனௌன்ஸ்மெண்ட்? எழுதி வச்சவா எனக்கு வராது.
உங்ககிட்ட தான் இது இருக்கா?
The paper presentation will be held in the 4th floor. Those who are presenting are requested to go to the 4th floor. I repeat, the paper presentation will be held in the 4th floor. So those who are presenting are kindly requested to go to the 4th floor and assemble there. Thank you. அக்கா கொஞ்சம் தள்ளுமா. வாசிக்கின்றாரு போல.
Check. Check, 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 check. Check. Check, check, check.
Hello. Hello, check. Hello, check.
Hello, hello, hello. Check, check, check.
Hello. The sign. The scientific session is being held in the fourth floor. The participants are kindly requested to appear on the fourth floor. I repeat, the scientific sessions are being held at the fourth floor. The participants are kindly requested to appear there. Thank you.
Hello, check. Hello, check.
Hello, check. Hello, check. Hello.
Check. Hello. Hello, check. Hello, check. Hello, check. Okay. Hello, check. Hello, check. Hello, check. Hello, check. Hello, check.
The scientific session will be held in the fourth floor. Participants are requested to assemble there. I repeat, the scientific sessions will be held in the fourth floor. Participants are requested to be assembled there. Hello, check. Hello. Hello, check. Hello. Hello, check. Hello, check. The professional category paper presentation will start shortly. The participants are requested to assemble in the fourth floor. I repeat, the professional category paper presentation will start shortly. The participants are requested to assemble in the fourth floor. Thank you. The professional category paper presentation will start shortly. The participants are requested to assemble in the fourth floor. I repeat, the professional category paper presentation will start shortly. The participants are requested to assemble in the fourth floor. scientific session is held in the fourth floor. Participants are requested to assemble there. I repeat, the scientific sessions are held in the fourth floor. Participants are requested to assemble there. Thank you. The measure is how it treats its most vulnerable members. Respected dignitaries, esteemed faculty, and dear students, it is my privilege to extend a very warm welcome to all of you. Today, we have come under a deeply meaningful theme: autism in humanity, every life has value. When we speak of humanity, we speak of compassion, dignity, and respect to every individual, regardless of the differences. And when we say every life has value, we affirm that there is no difference regardless of their communication, behavior, or perception. Nothing diminishes their worth as a human being. Today's program is a step towards strengthening the belief, a step towards building a society that doesn't merely acknowledge differences but respects and embraces them as an essential part of a shared humanity. With that spirit and purpose, let's begin today's program. We begin our session of the day with a clinician who doesn't just see patients, but sees the potential in every child. Dr. Raghuram Swaminathan, MBBS M.D. Pediatrics, has dedicated his career at Sree Abirami Hospital for understanding the delicate milestones of development. We are so fortunate to have his brilliant mind and compassionate heart to start the morning. Sir, the floor is all yours.
Kekida, good morning everyone. Thank you Principal Sir for inviting me for this lecture, and thank you all the faculties of Sree Abirami College of Occupational Therapy. I am privileged to present this topic in front of you, and motive of this lecture would be to make the students understand what is autism. It is like ABC of autism, to understand what is autism. Beyond that, how to treat it is up to the hands of other speakers, and my purpose is to make you all understand that, make you all well equipped to pick up the autistic cases as early as possible. So let's not waste the time and let's begin the topic. Next slide. கேக்குதுல எல்லாத்துக்கும்? ஸோ எதுக்கு இந்த டாபிக் இம்பார்ட்டன்ட்? போஸ் 2019ல இருந்து we are seeing lot of autistic cases OPD. இதுக்கு நிறைய ரீசன்ஸ் சொல்றாங்க. Because of the direct effect of the virus, because of the increased screen time usage during COVID time, because of the increased awareness of autistic diagnosis among the healthcare practitioners. இந்த மாதிரி நிறைய ரீசன்ஸ் சொல்றாங்க. Whatever it is, we are seeing a rise in cases post-COVID. அதுக்கப்புறமேட்டு early identification is very important in autism. என்ன காரணம் அப்படின்னா கிட்டத்தட்ட 80 to 90% of the brain volume is being formed in first 5 years of life. சரிங்களா? ஃபர்ஸ்ட் 5 years of lifeல ஏகப்பட்ட நியூ நியூரோனல் கனெக்ஷன்ஸ் வந்து ஃபார்ம் ஆகுது. ஸோ இந்த நியூரோனல் கனெக்ஷன்ஸை நம்ம யூஸ் பண்ணி அந்த ஆர்டிஸ்டிக் கிட்டுக்கு இந்த சொசைட்டி கூட நார்மலாக மிங்கிள் ஆகிறதுக்கு நம்ம ட்ரைனிங் தரோம். அதனால தான் சீக்கிரம் ஐடென்டிஃபை பண்ணணும், சீக்கிரம் இன்டர்வென்ட் பண்ணணும். அதுதான் early identification and early intervention. ஸோ அதுவும் ரொம்ப முக்கியம் ஆர்டிஸ்டிக்கில். அது போக பீடியாட்ரிஷியன் மட்டும் இதில் எதுவும் பண்ண முடியாது. இட்ஸ் a team work. It is a team work comprising of pediatrist, psychologist, physiotherapist, occupational therapist. Of course, OT plays the very pivotal role in carrying therapy for autism. Next slide. கொஞ்சம் அமைதியாக மட்டும் இருக்கு, நான் half an hourல முடிச்சிருவேன். சரிங்களா? சரி, இதுதான் நான் சொன்னது. ஃபர்ஸ்ட் 5 இயர்ஸ்லாம் கிட்டத்தட்ட 90% ஆஃப் த பிரெயின் ஃபார்ம் ஆகுது. ஸோ ஆட்டிசம்ன்றது பேசிக் ஒரு டிசீஸ் கிடையாது. அது வந்து பிரெயின் ஸ்ட்ரக்சர், அப்நார்மல் பிரெயின் ஸ்ட்ரக்சர் அப்படி கிடையாது. பேசிக்கலி த பிரெயின் இஸ் ஒயர்டு டிஃப்ரெண்ட்லி. சரிங்களா? ஸோ அந்த கனெக்ஷன்ஸ்க்கு ஏற்ற மாதிரி நம்ம தெரப்பி தந்து early ஏஜஸில் இந்த சொசைட்டி அவங்கள நார்மலாக மிங்கிள் ஆக வைக்கிறது தான் நம்மளோட கோல். சரிங்களா? ஸோ அந்த early ஏஜஸ் ஃபர்ஸ்ட் 5 இயர்ஸை நம்ம மிஸ் பண்ணிடவே கூடாது. இந்த கிளாஸ் முடிகிறப்ப ஒரு ஸ்டூடெண்ட்ஸ்க்கும் எவ்வளோ சீக்கிரம் ஆட்டிசமை பிக் பண்ண முடியுமோ அவ்வளோ சீக்கிரம் பிக் பண்ணக்கூடிய ஸ்கில்ஸ் டெவலப் ஆகணும். நல்லா ஒத்துக்கோனீங்க. நெக்ஸ்ட் 20 minutes மட்டும். நெக்ஸ்ட் ஸ்லைட். ஸோ டயக்னாஸ்டிக் ஸ்டாட்டிஸ்டிக் மேனுவல் ஃபார் இந்த DSM கிரைட்டீரியான்றது எல்லா சைக்காட்ரிக் டிசீஸ்க்கும் இருக்கும். அந்த மாதிரி ஆட்டிசம்க்கு முக்கியமாக 2 ப்ராட் கேட்டகரியில் ஆட்டிசம்னை டிஃபைன் பண்ணுறாங்க. ஒரு ஆர்டிஸ்டிக் கிட்டும் இந்த 2 ப்ராட் கேட்டகரியும் ஃபுல்ஃபில் பண்ணணும். என்ன காரணம் அப்படின்னா ஆட்டிசம்க்கு ஏகப்பட்ட டிஃபரன்ஷியல் டயக்னோசிஸ் இருக்குது. சரிங்களா? ADHD இருக்கலாம், சோஷியல் கம்யூனிகேஷன் டிஸார்டர் இருக்கலாம், ஹியரிங் இம்பேர்மெண்ட் இருக்கலாம். இந்த மாதிரி ஆட்டிஸ்டிக்கு டிஃபரன்ஷியல் டயக்னோசிஸ், அதாவது வேற டிசீஸ் இருக்க வாய்ப்பு இருக்குது. ஸோ அதுக்காக இந்த டெஃபினேஷன் நம்ம தெரிஞ்சுக்கிறது ரொம்ப முக்கியம். ஸோ டெஃபினேஷன் நான் உங்களுக்கு சொல்ல போகிறது கிடையாது. ஒரு கேஸ் நிறைய போட்டு காமிச்சு அது கூட ரிலேட் பண்ணி இந்த டெஃபினேஷனை உங்களுக்கு சொல்ல போகிறேன். பட் கேஸினர் ஆரம்பிக்கிறதுக்கு முன்னாடி இந்த ப்ராட் 2 பாயிண்ட்டுக்கு ஒரு சின்ன ஒரு டெஃபினேஷன் சொல்லிடுறேன். ஃபர்ஸ்ட் வந்து சோஷியல் கம்யூனிகேஷன். இப்போ ஒரு எக்ஸாம்பிள் இருக்குது. இப்போ காலேஜில் ஏதோ ஒரு ஸ்டூடெண்ட்டுக்கு வந்து உடம்பு சரிங்களா, நீங்கள் போயிட்டு பிரின்சிபல் சார்கிட்ட லீவ் கேட்குறீங்க. சரிங்களா? பிரின்சிபல் சார் ரூம் போகிறீங்க. அந்த கான்டெக்ஸ்ட், அந்த சோஷியல் ரூல் உங்களுக்கு எல்லாத்துக்குமே தெரியும். நீங்கள் ஸ்டூடெண்ட்டு, சார் பிரின்சிபல், ஸோ எப்படி ரெஸ்பெக்ட் இருக்கணும், அந்த பாடி லாங்குவேஜ் எல்லாமே உங்களுக்கு தெரியும். அதுதான் சோஷியல் ரூல். சரிங்களா? அதுக்கு அடுத்து இது வந்து சோஷியல் ரூல் நம்பர் 1 பாயிண்ட். அதுக்கு அடுத்து சார்கிட்ட போயிட்டு நீங்கள் கொஞ்சம் அமைதியாக இருங்க ப்ளீஸ், கொஞ்சம் அமைதியாக இருங்க. அதுக்கப்புறமேட்டு சார்கிட்ட போயிட்டு நீங்கள் கம்யூனிகேட் பண்ணுறீங்க. கம்யூனிகேட் பண்ணுறப்ப உடம்பு சரியில்லை, ஸோ எப்படி இருக்கும், ஒரு மாதிரி டல்லாக இருக்கும், சார் முடியல சார் அப்படி டல்லாக இருக்கும். ஸோ ஃபேஷியல் எக்ஸ்பிரஷன் அங்கே கொடுக்குறீங்க. அடுத்து ஃபேஷியல் எக்ஸ்பிரஷனுக்கு அடுத்து என்ன கொடுக்குறீங்க? வர்பல் எக்ஸ்பிரஷன். வாயால் சொல்கிறீங்க, சார் 2 நாளாக உடம்பு முடியல, நான் கொஞ்சம் மெடிசன்ஸ் போட்டு ட்ரை பண்ணேன், என்னால் முடியல, கண்டிப்பாக ரெஸ்ட் வேணும். ஸோ இந்த சோஷியல் கான்டெக்ஸ்ட்டை பாருங்கள். உங்களுக்கு தெரியுது நீங்கள் ஒரு ஸ்டூடெண்ட்டு, சார் ஒரு பிரின்சிபல், பாடி லாங்குவேஜ் எப்படி இருக்கணும், வேர்ட்ஸ் எப்படி யூஸ் பண்ணணும், எக்ஸ்பிரஷன்ஸ் எப்படி யூஸ் பண்ணணும், நான் வெர்பல் எக்ஸ்பிரஷன்ஸ் எப்படி யூஸ் பண்ணணும், வேர்பல் எக்ஸ்பிரஷன்ஸ் எப்படி யூஸ் பண்ணணும், இது எல்லாமே உங்களுக்கு தெரியுதுல்ல. இதுதான் சோஷியல் கம்யூனிகேஷன். இது வந்து ஆட்டிஸ்டிக் குழந்தைங்களுக்கு லேக் ஆகும். நெக்ஸ்ட் பாயிண்ட், ரிஜிட் பிஹேவியர், ஃபிக்ஸ்டு இன்ட்ரெஸ்ட். அதாவது என்ன அப்படின்னா ஆட்டிஸ்டிக் கிட்ஸ், ஒரு சின்ன எக்ஸாம்பிள் சொல்கிறேன். வீட்டில் தினைக்கும் ஒரே சோஃபாவில் தான் உட்காருவாங்க, வேற சேர்ல உட்காருவாங்க. தி கீப் ஆன் சிட்டிங் இன் த சேம் சோஃபா. டிவி பார்க்குறப்ப ஒரே படத்தை திருப்பி பார்த்துட்டு இருப்பாங்க, ஒரே பாட்டை திருப்பி கேட்டுட்டு இருப்பாங்க, ஒரே சட்டையை திருப்பி போட்டுட்டு இருப்பாங்க, ஒரே பொம்மையை வச்சு ஒரே மாதிரி விளையாண்டுட்டு இருப்பாங்க. ஸோ ஃபிக்ஸ்டு இன்ட்ரெஸ்ட், ரிஜிட் பிஹேவியர். ஒரே சாப்பாடை தினைக்கும் சாப்பிடணும்னு நினைப்பாங்க, தயிர் சாதம் தான் வேணும், அந்த மாதிரி ஃபிக்ஸ்டு இன்ட்ரெஸ்ட் இருக்கும். அடுத்து 2வது பாயிண்ட், ரிப்பீட்டேட்டிவ் பிஹேவியர். எக்ஸாம்பிள் என்ன அப்படின்னு சொல்லி பார்த்தோம்னா, இது வந்து மோட்டார் மூமெண்ட். சரிங்களா? கையை வச்சு சரிங்களா, ரிப்பீட்டேட்டிவா இந்த மாதிரி ஃபிஜிட்டி பிஹேவியர்ஸ். அதுக்கு நான் ஒரு வீடியோ போட்டு காமிக்கிறேன். ஜஸ்ட் அந்த ஃபோல்டரில் இன்னொரு வீடியோ இருக்கு, அது மட்டும் போட்டு காமிக்கிறேன். ஆட்டிஸ்டிக் லெக்சரில் ஒரு வீடியோ இருக்கு. ஸோ அந்த ரிப்பீட்டேட்டிவ் பிஹேவியர் எப்படி இருக்கும், ரிப்பீட்டேட்டிவ் மோட்டார் மூமெண்ட் பிஹேவியர் எப்படி இருக்கும் இந்த வீடியோ. ஸோ இந்த கிட்ட பாருங்க, இந்த கிட்டோட கையை மட்டும் பாருங்க. தெரியுதா? ஸோ இந்த கிட் வந்து பார்த்தீங்கன்னா கீப்ஸ் ஆன் டூயிங் லைக் திஸ் ஆல் டைம். இதுதான் பேரண்டோட கம்ப்ளைண்ட்டாக இருக்குது. சரிங்களா? வேற ஃபியூ எக்ஸாம்பிள் என்ன அப்படின்னா, தலையை நோண்டிக்கிட்டே இருப்பாங்க. they will touch their private parts repeatedly. இந்த மாதிரி வந்து பண்ணிக்கிட்டே இருப்பாங்க using their hands. Most of the movements are purposeless, which is so awkward and inappropriate to the situation. So மூணு கேட்டகரி பார்த்துருக்கோம். ஒன்று சோஷியல் கம்யூனிகேஷன், இன்னொன்று ஃபிக்ஸ்டு இன்ட்ரெஸ்ட், இன்னொன்று ரிப்பீட்டேட்டிவ் பிஹேவியர். கரெக்டாக இது மூணுத்துக்கு கீழே தான் எல்லா ஆர்டிஸ்டிக் கிட்ஸும் ஃபாலோ ஆவாங்க. இன்னும் இது வந்து ப்ராட் பாயிண்ட்ஸ், இது கீழே நிறைய வந்து சப் பாயிண்ட்ஸ் இருக்குது. அது எல்லாமே நம்ம எப்படி பார்க்க போகிறோம் அப்படின்னா கேஸ் சினாரியோ ஒன்று கொடுத்தா ஸ்லைட்ஸ்க்கு போயிடலாம். இது பேரே வந்து பாருங்க, ஆட்டிசம்னு யாரும் சொல்லக்கூடாது. இன்னையிலிருந்து இது பேர் ஆட்டிசம்னு யாரும் சொல்லக்கூடாது. இது பேர் ஆர்டிஸ்டிக் ஸ்பெக்ட்ரம் டிஸார்டர். ஏன் ஸ்பெக்ட்ரம் அப்படின்னு சொல்கிறோம் அப்படின்னா எல்லா கேஸும் ஒரே மாதிரி இருக்காது. அதுதான் ஆர்டிஸ்டிக் ஸ்பெக்ட்ரம் டிஸார்டர். எல்லா கேஸும் வேற மாதிரி ப்ரெசென்ட் ஆகும். அது ஸ்பெக்ட்ரம்குள்ள ஃபார்ம் ஆகும். அந்த சைல்டு மைல்டாக கூட இருக்கலாம், மாடரேட்டாக கூட இருக்கலாம், இல்லை சிவியர் டிபெண்ட்டாக கூட இருக்கலாம். இட் இஸ் அ ஸ்பெக்ட்ரம். ஒரு சில சைல்டுக்கு வந்து பார்த்தீங்கன்னா அந்த ஃபிக்ஸ்டு இன்ட்ரெஸ்ட்ன்றது ரொம்ப அதிகமாக இருக்கும். சோஷியல் கம்யூனிகேஷனும் ரிப்பீட்டிவ் பிஹேவியரும் ஓரளவுக்கு சப்நார்மலாக இருக்கும். ஒரு சில சைல்டுக்கு சோஷியல் கம்யூனிகேஷன் ரொம்ப மோசமாக இருக்கும். பட் இந்த ஃபிக்ஸ்டு இன்ட்ரெஸ்ட்டும் ரிப்பீட்டட் பிஹேவியரும் கொஞ்சம் கம்மியாக இருக்கும். இந்த ஸ்பெக்ட்ரமில் அவங்க எங்கே வேணாலும் ஃபாலோ ஆகலாம். அதனால தான் இது பேர் ஆர்டிஸ்டிக் ஸ்பெக்ட்ரம் டிஸார்டர். இது நல்லா புரிஞ்சுக்கணும் அப்படின்னா உங்களுக்கு ஒரு 5-6 கேஸ் சினாரியோ, நான் பார்த்த கேஸ் சினாரியோ உங்களுக்கு எக்ஸ்பிளைன் பண்ணுறேன். சரிங்களா? அதை வச்சு நீங்கள் இந்த சைல்டு எந்த கேட்டகரியில் ஃபார்ம் ஆகுதுன்னு நீங்கள் சொல்லணும். சரிங்களா? அடுத்த ஸ்லைட் போங்க. சரி, கேஸ் சினாரியோ போகிறதுக்கு முன்னாடி உங்கள் எல்லாத்துக்குமே நார்மல் டெவலப்மெண்டல் மைல்ஸ்டோன், அதாவது 4 மைல்ஸ்டோன் இருக்குது மொத்தமாக. குழந்தைங்களுக்கு பார்த்தீங்கன்னா கிராஸ் மோட்டர்னா நிற்கிறது, நடக்கிறது, ஓடுறது, அந்த மாதிரி பெரிய மசில்ஸை யூஸ் பண்ணி மூவ்மெண்ட்ஸ் பண்ணுறது தான் கிராஸ் மோட்டர். அடுத்து ஃபைன் மோட்டர்னா சின்ன மசில்ஸை யூஸ் பண்ணி பண்ணுறது. ஃபார் எக்ஸாம்பிள் ரைட்டிங், டிராயிங், அந்த மாதிரி தான் ஃபைன் மோட்டர். அடுத்து 3வது வந்து பார்த்தோன்னா சோஷியல் மைல்ஸ்டோன், அதாவது அந்த குழந்தை இந்த வெளி உலகத்து கூட சோஷியலாக மிங்கிள் ஆகுது, அது 3வது மைல்ஸ்டோன். 4வது வந்து லாங்குவேஜ் மைல்ஸ்டோன், அந்த குழந்தை என்னென்ன வார்த்தைகள் எந்தெந்த வயசில் பேசுது, இதுதான் லாங்குவேஜ் மைல்ஸ்டோன். ஆர்டிஸ்டிக் கிட்ஸ் பொறுத்த வரைக்கும் நம்மளுக்கு தேவையான 2 மைல்ஸ்டோன் என்ன அப்படின்னா சோஷியல் மைல்ஸ்டோன், லாங்குவேஜ் மைல்ஸ்டோன். இந்த 2 மைல்ஸ்டோனுமே 5 இயர்ஸ் வரைக்கும் நீங்கள் எந்த கிட்ஸை பார்த்தாலுமே இந்த 2 மைல்ஸ்டோனும் கண்டிப்பாக செக் பண்ணும் ஆஸ் அ ஓடி ஸ்டூடெண்ட். சரிங்களா? ஓகே, இருக்கிறதுலே ரொம்ப அர்லியஸ்ட் மைல்ஸ்டோன் ஹவு டு பிக் ஆட்டிசம் வெரி early என்ன அப்படின்னா குழந்தைங்க 2 மாதம் ஆனால் தே ஸ்மைல் when they see the persons. நீங்கள் போய் சிரிப்பு காமிங்க 2 மாதத்துக்கு அப்புறமேட்டு, செல்லக்குட்டி சிரிப்பு காமிங்க, சிரிப்பாங்க. முன்னாடி நின்றுட்டு அம்மா அப்பா சொந்தக்காரவங்க யார் முன்னாடி சிரிச்சாலுமே சிரிப்பாங்க, நம்ம மூஞ்சி பார்த்து சிரிப்பாங்க. பார்த்துருக்கீங்களா? யார் பார்த்துருக்கீங்க? கை தூக்குங்க. யார் பார்த்துருக்கீங்க குழந்தைங்க சிரிச்சு? பார்த்துருக்கீங்களா? 2 monthsல சிரிப்பாங்க. ஸோ இந்த கேள்வியை கேளுங்க, குழந்தைங்க உங்கள் முகத்தை பார்த்து சிரிக்கிறாங்களா? ஒரு 3 months ஓல்டு அம்மா வராங்க, குழந்தை வச்சுட்டு அம்மா வராங்க அப்படின்னா இந்த கேள்வி கேளுங்க. ஆமான்னு சொன்னாங்கன்னா கிரீன் லைட்டு. இல்லைங்க என் குழந்தை சிரிக்கிறது இல்லை, ஃபஸ்ட்டு நம்ம என்ன பண்ணோம், விஷனை செக் பண்ணோம். சரிங்களா? அதுக்கப்புறமேட்டு the child can be autistic, ஸோ ஃபாலோஅப்பில் வர சொல்லும், ரெகுலராக ஃபாலோஅப்பில் வர சொல்லும். ஃபர்ஸ்ட் பாயிண்ட் புரிஞ்சிருச்சா? அடுத்து வந்து பார்த்தோன்னா 2 to 4 monthsல ஐ டு ஐ கான்டாக்ட். 2 months முன்னாடி வரைக்கும் ரேண்டமாக எங்கேயாவது பார்த்துட்டு இருப்பாங்க. பட் அது 2 monthsல இருந்து கரெக்டாக நம்ம கண்ணை பார்க்க ஆரம்பிப்பாங்க. இந்த 2 to 4 monthsல ஐ டு ஐ கான்டாக்ட் நடக்கும். ஸோ இதுவும் கேட்கணும், குழந்தை உங்கள் கண்ணை பார்க்குதா? நீங்கள் ஏதாச்சும் பண்ணுறப்ப குழந்தை உங்கள் கண்ணை பார்க்குதா? சரி, நெக்ஸ்ட் 7 to 12 monthsல எக்ஸாம்பிள் என்ன அப்படின்னா, நீங்கள் ரயில்வே ஸ்டேஷனுக்கு குழந்தைய கூட்டிகிட்டு போகிறீங்க, ட்ரெயின் போகுது, இல்லை உங்கள் வீட்டிலேருந்து ரயில்வே ட்ராக் தெரியுது, ட்ரெயின் போகுது, உங்களுக்கு குமிச்சு அம்மா ஊ அப்படின்வாங்க. நாய் போகுது, சரிங்களா, அம்மா ஓ அப்படின்வாங்க. கரெக்டாக காமிச்சிருக்காங்க, பார்த்துருக்கீங்களா இல்லையா? 7 to 12 monthsல பாயிண்டிங் ஃபிங்கர்ஸ் அட் ஆப்ஜெக்ட் விச் தேர் இன்ட்ரெஸ்டட் இன். அது எதை குறிக்குது அப்படின்னா, எதை குறிக்குது? தேர் ட்ரைங் டு கம்யூனிகேட் டு யூ போத் வெர்பலி அண்ட் நான் வெர்பலி எப்படி கையை எப்படி காமிச்சு, வெர்பலி எப்படி அப்படின்னு சொல்றது, புரியுதா? தேர் ட்ரைங் டு கம்யூனிகேட். தீஸ் ஆர் early signs of communication. புரியுதா? நெக்ஸ்ட் பாயிண்ட், பேரை கூப்பிட்டா திரும்புறது. நிக்கலன் அப்படின்னு கூப்பிட்டா, ஏதோ குழந்தைக்கு பேரை சொல்லி கூப்பிட்டா 7 monthsல திரும்ப ஆரம்பிச்சிருவாங்க. அவங்களுக்கு இதுதான் நம்ம பேரு அப்படின்னு புரிஞ்சு திரும்ப ஆரம்பிச்சிருவாங்க. சரிங்களா? அடுத்து லாஸ்ட் என்னன்னா ஒரு வருஷம் முடிகிறதுக்குள்ள மீனிங்ஃபுல் வேர்ட் அட்லீஸ்ட் ஒரு வார்த்தை பேசியிருக்கு. இங்கே 2 வார்த்தை பேசியிருக்காங்க. கொஞ்சம் நீங்கள் ஃப்ளெக்சிபிளாக அட்லீஸ்ட் ஒரு வார்த்தையாச்சும் பேசுகிறாங்களா? ஒரு வயசு முடிஞ்சிருச்சு, அம்மா ஏதாவது ஒரு வார்த்தையாக பேசுகிறாங்களான்னு சொல்லி கேட்குறேன். இல்லைங்க, எந்த வார்த்தையும் பேசுறது இல்லை, அமைதியாக தான் இருக்கா. அது ரெட் ஃப்ளாக். இப்போ என்னென்ன தெரியுது ரெட் ஃப்ளாக்? 7 to 12 months குழந்தை எதுவுமே கம்யூனிகேட் பண்ண மாட்டேன்றான். கை காமிச்சு எதுவுமே சொல்ல மாட்டேன்றான். தாட்டா காமிச்சா திருப்பி தாட்டா காமிக்க மாட்டேன்றாங்க. பேரை கூப்பிட்டா திரும்ப மாட்டேன்றாங்க. 2 மாசத்துல சிரிக்க ஆரம்பிக்கல. சரிங்களா? இதெல்லாமே ரெட் ஃப்ளாக்ஸ். தெரியுதுல? ஐ டு ஐ கான்டாக்ட் இல்லை. சரிங்களா? ஒரு வயசு முடிஞ்சிருச்சு, இன்னும் ஒரு வார்த்தை கூட பேசுது. எது நார்மல் எது அப்நார்மல் டெவலப்மெண்ட் உங்களுக்கு புரிஞ்சிருச்சுல? சீக்கிரம் கண்டுபிடிப்பீங்களா மாட்டீங்களா? கண்டுபிடிப்பீங்களா? சரி, ஓகே, நெக்ஸ்ட் ஸ்லைட். ஓகே, இது எல்லாமே நான் சொன்ன மாதிரி அந்த 2 ப்ராட் கேட்டகரியில் வர சப் ஹெட்டிங்ஸ். சரிங்களா? நான் உங்களுக்கு லெஃப்ட் ஹேண்ட் சைடை மட்டும் சொல்கிறேன், ரைட் ஹேண்ட் சைடை கேஸ் சினாரியோ போட்டு உங்களுக்கு சொல்லித்தரேன். சரிங்களா? லாங்குவேஜ், ரெஸ்பாண்டிங் டு அதர்ஸ், கெஸ்டர் அண்ட் ஐ கான்டாக்ட், ஸ்லைட். Interacting with others, ideas and imagination, rigid and repetitive behavior, sensory activities. ரைட் ஹேண்ட் சைடில் வர அந்த குவாலிட்டிஸ் வந்து ஷேர் ஆகும். ஒரு சில குவாலிட்டிஸ் ஒரு சில கிட்ஸ்ட்டு இருக்கும், ஷேர் ஆகும். இதெல்லாம் தான் வந்து ஆட்டிஸ்டிக் ஸ்பெக்ட்ரம் அப்படின்னு சொல்லி சொல்கிறாங்க. ஸோ இப்போ ஒரு கேஸ் சினாரியோவை காமிச்சு நம்ம கிட்டு எந்த கேட்டகரியில் வரன்றதை நீங்கள் தான் சொல்லணும். சரியா? நான் அடுத்த கேஸ் சினாரியோ போகிறேன், எந்த கேட்டகரியில் வருது நீங்கள் தான் சொல்லணும். சரியா? ஃபர்ஸ்ட் கேஸ் சினாரியோ போங்க. ஓகே, லேட் டாக்கர். சரிங்களா? ஆரம் 2.5 years old child from Chennai, urban nuclear family. urban nuclear family, அம்மா அப்பா வேலைக்கு போகிறாங்க, 3 பேர் தான் இருக்காங்க, தனி குடும்பமாக வாழ்கிறாங்க. சரிங்களா? கூட்டு குடும்பம் கிடையாது. His parents are concerned because he has not started speaking yet. 2.5 years, 2 வயசு ஆயிடுச்சு, இன்னும் பேச ஆரம்பிக்கல. He does not respond when his name is called, which they initially thought அவனுக்கு ஒழுங்காக காது கேட்கலையோ. எல்லா ஆர்டிஸ்டிக் பேரண்ட்ஸ்கிட்டையும் வர டவுட் என்னன்னா, காது ஒழுங்காக கேட்கலையோ. ஆஸ் அ ஹெல்த் கேர் ஸ்டூடெண்ட் நீங்கள் தான் கண்டுபிடிக்கணும், காது ஒழுங்காக கேட்குதா இல்லை இது ஆட்டிசமான்னு நீங்கள் தான் கண்டுபிடிக்கணும். சரிங்களா? அடுத்து கீ அப்சர்வேஷன்ஸ் நான் பார்த்தது என்ன அப்படின்னா, ஆரவ் ஸ்பென்ஸ் ஹவர்ஸ் ஸ்பின்னிங் த வீல்ஸ் ஆஃப் எ டாய் காஸ் ரேதர் தென் டிரைவிங் them. ஒரு கார் இருக்குது, அதை இப்படி பின்னாடி இழுத்துட்டா முன்னாடி போகும், அப்படி தான் எல்லா குழந்தையும் விளையாடுவாங்க. ஆரவ் என்ன பண்ணுறாப்புல அப்படின்னா, அந்த கார் எடுத்து வீல் இப்படி பண்ணிக்கிட்டு இருக்காங்க. சரிங்களா? காரை ஓட்ட மாட்டாங்க. இட் இஸ் அப்நார்மல் யூஸ் ஆஃப் த டாய். இது வந்து என்னது? ரிஜிட் பிஹேவியர், ரிப்பீட்டேட்டிவ் பிஹேவியர். சரிங்களா? he avoids eye contact and shows no interest in playing with his cousins during Sunday lunch. சண்டே ஆனால் அவங்க வீட்டில் அவங்க சொந்தக்காரங்களாம் வருவாங்க, அவங்க பாட்டுக்கே தனியாக விளையாண்டுட்டு இருப்பாங்க, இந்த பையன் பாட்டுக்கே தனியாக விளையாண்டுட்டு இருப்பாங்க. ஸோ இப்போ இதில் நமக்கு தேவையான பாயிண்ட் என்ன அப்படின்னா, நாட் ஸ்பீக்கிங் இட். நம்பர் 1 பாயிண்ட்டு. பேரை கூப்பிட்டா திரும்புறது இல்லை, ஐ டு ஐ கான்டாக்ட் இல்லை, யாரு கூட மிங்கிள் ஆக மாட்டேங்கிறாங்க. இப்போ அந்த முன்னாடி இருக்க ஸ்லைட்ஸ்க்கு போங்க. ஸோ ஸ்போக்கன் லாங்குவேஜ் ஃபர்ஸ்ட் பாயிண்ட் இந்த பையனுக்கு மேட்ச் ஆகுதா? டிலே இன் வேர்ட்ஸ் இருக்குதா? அடுத்து 2வது ஹெட்டிங் பாருங்க, ரெஸ்பாண்டிங் டு அதர்ஸ், ஆப்சென்ட் ஆர் டிலேட் ரெஸ்பான்ஸ் டு இருக்குதா? சரி, ஓகே. அடுத்து இங்க பாருங்க, புவர்லி இன்டகிரேட்டட் ஐ கான்டாக்ட், இந்த பையனுக்கு இருக்குதா? சரிங்களா? ஓகே, நெக்ஸ்ட் ஸ்லைட் போங்க. இன்டராக்டிங் வித் அதர்ஸ், ரெடியூஸ்டு இன்ட்ரெஸ்ட் இன் பியர்ஸ், மே பிளே அலோன் ஆர் அப்ரோச் அதர்ஸ் இன்அப்ராப்ரியேட்லி. தெரியுதா உங்களுக்கு? புரியுதுல உங்களுக்கு? இந்த பையன் எப்படி ஆட்டிசம் கீழே வருவான்றது உங்களுக்கு புரியுதுல? சரியா? ஸோ இந்த பையனில் இப்போ அந்த டிஎஸ்எம் கிரைட்டீரியாவில் வரும். இந்த பையனுக்கு சோஷியல் கம்யூனிகேஷன் லேக் ஆகுதா? நம்பர் 1 பாயிண்ட் இருக்குதா? ஓகே. 2வது பாயிண்ட் என்ன அப்படின்னா, ஃபிக்ஸ்டு இன்ட்ரெஸ்ட். அந்த காரில் ஃபிக்ஸ்டு இன்ட்ரெஸ்ட்டாக இருக்கான், அந்த காரை யூஸ் பண்ணுறதுலேயும் வந்து பார்த்தீங்கன்னா ரிப்பீட்டேட்டிவ் பிஹேவியர், வீல ஒரு மாதிரி சுற்றுறான். 3மே ஃபுல்ஃபில் ஆகுதா இந்த பையனுக்கு? சரி, ஓகே. இப்போ நெக்ஸ்ட் கேஸ் சினாரியோ. அடுத்த கேஸ், செகண்ட் கேஸுக்கு போயிடுங்க. ஓகே, இதானா செகண்ட் கேஸு? இதானா? ஓகே. ஸோ இந்த 2 பேர் கிளாஸ்க்கு வாங்க ப்ளீஸ். ஓகே. ஹலோ, கேக்குதா? என்னாச்சு? ஹலோ போகிறாங்க. ரெண்டாவது கேஸ் பார்ப்போம். இந்த பையன் வந்து லேட் டாக்கர். இந்த பையன் யார் அப்படின்னா லிட்டில் ப்ரொஃபஸர். ஏன் லிட்டில் ப்ரொஃபஸர் சொல்றது கேஸ் பாருங்க. செல்வம் 7 years old child from Madurai is a primary school student studying 4th standard. Selvam is academically gifted in maths. 4th standard தான் படிக்கிறான். 12 டேபிள் வரைக்கும் கரெக்டாக சொல்லுவான். பேசுகிற தமிழ் வந்து பார்த்தோன்னா பக்காவாக இருக்கும். கிராமர் மிஸ்டேக் எதுவுமே இருக்காது. ஒரு கவிஞர் எப்படி பேசுவாரோ அதே மாதிரியே தமிழ் பேசுவான். அடுத்து ஃபிக்ஸ்டு இன்ட்ரெஸ்ட் நான் எதை சொல்கிறேன் அப்படின்னா, எந்த ட்ரெயின் நம்பர், எந்த ட்ரெயின் பேர் சொன்னாலுமே அந்த ட்ரெயின் நம்பர் சொல்லுவான். அந்த ட்ரெயின் எங்கே ஸ்டார்ட் ஆகுது, எங்கே முடியுது, நடுவில் எந்தெந்த ஸ்டேஷனில் நிற்பாங்க, எவ்வளோ நேரம் நிற்பாங்க, இது எல்லாமே கரெக்டாக சொல்லுவாங்க. இது என்னது? ஃபிக்ஸ்டு இன்ட்ரெஸ்ட். சரிங்களா? ஓகே. இது வந்து இப்போ இந்த லாஸ்ட் லைன் பாருங்க. He gets bullied because he doesn't understand jokes or sarcasm and often corrects the teacher's minor error. அதாவது என்ன அப்படின்னா, இது என்ன எக்ஸாம்பிள் அப்படின்னா, நம்ம ஒரு சில வார்த்தைகளை ஜோக்ஸாக யூஸ் பண்ணுவோம். சரிங்களா? சர்க்கசமாக யூஸ் பண்ணுவோம். ஆனால் அவங்க அதை லிட்ரலி உண்மையாக எடுத்துப்பாங்க. சரிங்களா? ஒரு எக்ஸாம்பிளுக்கு என்ன அப்படின்னா, எனக்கு அப்படியே தலை சுத்துற மாதிரி இருக்குது, நமக்கு சுற்றி நடக்கிறது பிடிக்கல அப்படின்றப்ப நம்ம என்ன யூஸ் பண்ணுவோம்? எனக்கு அப்படியே தலை சுத்துற மாதிரி இருக்குது. ஆர்டிஸ்டிக் நமக்கு அது தெரியும், அவங்களுக்கு ஒரு மாதிரி டயர்டாக இருக்குது அப்படின்றது நமக்கு தெரியும். பட் ஆர்டிஸ்டிக் கிட்ஸ் வில் டேக் தட் லிட்ரலி. ஐயோ உண்மையிலே அவங்களுக்கு தலை தான் சுத்துதா அப்படின்னு சொல்லிட்டு எடுத்துப்பாங்க. ரெண்டாவது என்ன அப்படின்னா, ஒரு பிடிக்காத சாப்பாடு சாப்பிட்டுட்டு கேட்குறாங்க சாப்பாடு எப்படி இருந்துச்சு, நம்ம சர்க்காஸ்டிக்காக சூப்பராக இருந்துச்சு அப்படின்னு சொல்லி சொல்கிறோம். ஆர்டிஸ்டிக் கிட்ஸ் வில் லிட்ரலி டேக் தட் மீனிங், உண்மையாலே நல்லா இருக்குது. இதுதான் வந்து சோஷியல் கான்டெக்ட் கூட அந்த ஸ்பீச்சை ரிலேட் பண்ணி பார்க்கறது அவங்களுக்கு லேக் ஆகும். சொல்றது புரியுதா? இந்த சைல்டில் நம்ம என்னென்ன ஃபீச்சர்ஸ்லாம் ஆர்டிஸ்டிக் ஃபீச்சர்ஸ் பார்த்துருக்கோம்? ஃபிக்ஸ்டு இன்ட்ரெஸ்ட் பார்த்துருக்கோமா இல்லையா? ஃபிக்ஸ்டு இன்ட்ரெஸ்ட் எதில் இருக்குது? அந்த ரயில்வே டைம் டேபிளில் ஃபிக்ஸ்டு இன்ட்ரெஸ்ட். சரிங்களா? இது ஹை ஃபங்க்ஷனல் ஆர்டிஸ்ட். இந்த பையனால் நல்லா படிக்க முடியும், நல்லா பேச முடியும். பட் வந்து என்ன அப்படின்னா சோஷியல் கம்யூனிகேஷன் லேக் ஆகுது. ஜோக்ஸை அண்டர்ஸ்டாண்ட் பண்ணிக்க முடியாது. சரிங்களா? லிட்ரலி அதை அப்படியே சீரியஸாக எடுத்துப்பாங்க. இதனால என்ன ஆகும் அப்படின்னா, தே ஆர் நாட் ஏபிள் டு மிங்கிள் வித் அதர்ஸ். என்னடா நம்ம அவங்க சொன்னதுக்கு தானே ரியாக்ட் பண்ணுறோம், ஏன் சிரிக்கிறாங்க, இந்த கன்ஃபியூஷன் அவங்களுக்குள்ள போயிட்டே இருக்கும். இதுதான் நாட் ஏபிள் டு மிங்கிள் வித் அதர்ஸ். இந்த 2 பாயிண்ட்டும் இவங்களுக்கு இருக்குது. சரிங்களா? இப்போ அடுத்த கேஸ் நிறைய போகும். அடுத்த கேஸ் போங்க. ஸோ இந்த பொண்ணு பாருங்க, இந்த பொண்ணு தான் இந்த மாதிரி கேஸை பிக்கப் பண்ணுறது தான் கொஞ்சம் கஷ்டம். இந்த பொண்ணோட கேஸ் பாருங்க. Quiet dreamer. இந்த பொண்ணு என்ன பண்றாங்க அப்படின்னா, she is 9 years old, Ananya from Trichy. She is studying middle school, often missed because she is not disruptive. Ananya mimics her peers to fit in, but she finds social interaction exhausting. என்ன கேஸ் அப்படின்னா, இந்த பொண்ணை அவுட்ரைட்டாக கண்டுபிடிக்க முடியாது. அதாவது இந்த பொண்ணு ஆர்டிஸ்டிக் கேஸ் தான்றது அவுட்ரைட்டாக கண்டுபிடிக்க முடியாது. பட் எப்படி கண்டுபிடிச்சோம் அப்படின்னு சொல்லி பார்த்தோன்னா, இந்த பொண்ணு வந்து அடிக்கடி கதவை சாத்திட்டு அழ ஆரம்பிச்சிடுறாங்க. சரிங்களா? அடிக்கடி கதவை சாத்திட்டு அழ ஆரம்பிச்சிடுறாங்க. அந்த பொண்ணுகிட்ட டீப்பாக கேட்க போகிறப்ப என்ன சொல்கிறாங்க அப்படின்னா, நான் வந்து என் ஃப்ரெண்ட்ஸ் எப்பப்போலாம் கேங்காக பேசுகிறாங்களோ, இல்லை ஒன்றா விளையாடுறாங்களோ, இல்லை ஒன்றா வெளியே போகிறாங்களோ, அப்போல்லாம் நான் என்னை ஃபோர்ஸ் பண்ணிவிட்டு அவங்களோட இருக்கேன். ஆனால் ஒரு செகண்டும் எனக்கு அவங்களோட இருந்தது பிடிக்கிறதே இல்லை. எனக்கு எப்படா திருப்பி நம்ம தனியாக வருவோன்னு இருக்குது. எனக்கு அது பிடிக்கவே இல்லை. அவங்களோட இருக்கிற டைம் எனக்கு ரொம்ப ப்ரெஷரைசிங்காக இருக்குது. ஏன் அப்படின்னா, அவங்க மைண்டை போட்டு ரொம்ப கஷ்டப்படுத்திக்கிறாங்க. எப்படி நம்ம கம்யூனிகேட் பண்ணுறது, எப்படி நம்ம அந்த சோஷியல் கான்டெக்ட்டை கரெக்டாக எடுத்துக்கிறது. ஏன்னா எனக்கு தான் அந்த பிரச்சனை இருக்குது, சோஷியல் சுச்சுவேஷனுக்கு ஏற்ற மாதிரி எனக்கு பழக தெரியாது. ஸோ அவங்களே ஃபோர்ஸ் பண்ணி ஃபிட் பண்ணிக்க ட்ரை பண்ணிக்கிட்டே இருக்காங்க ஒரு சர்க்கிள்குள். சொல்கிறது புரியுதா அவங்களுக்கு? ஃபிட் பண்ண ட்ரை பண்ணிட்டே இருக்கிறப்ப ஒரு கட்டத்தில் எக்ஸாஸ்ட் ஆகிடுறாங்க. என்னடா ரொம்ப டயர்டாக இருக்கிறதுனால முடியல, சீரியஸாக அந்த கரெக்டான அந்த ஃப்ரெண்ட்ஸ் ரூல்ஸ்குள்ளே செட் ஆகிறதுக்கு எனக்கு முடியல. அதனால அடிக்கடி பிரேக் டவுன் ஆகிடுறாங்க. சரிங்களா? ஓகே. அட் ஹோம் ஷி இஸ் ப்ரோன் டு ஷட் டவுன்ஸ் ஆஃப்டர் ஸ்கூல். ஷி ஹஸ் அ டீப் இன்ட்ரெஸ்ட் பேஷன் ஃபார் ட்ராயிங் ஸ்பெசிஃபிக் பேட்டர்ன்ஸ் ஆஃப் கோலம். ஸோ இதுதான் வந்து பார்த்தோன்னா, அந்த பொண்ணு கேட்டால் என்ன படிக்க போகிறேன்னு கேட்டால் ஆர்கிடெக்சர் படிக்க போகிறேன் அப்படின்னு சொல்லி சொல்லுது. சரிங்களா? வீட்டில் ஏதாச்சும் ஃபங்க்ஷன் அப்போ வெளியே வீட்டு கோலத்தை பார்த்தா நம்பவே மாட்டாங்க, அது அந்த பொண்ணு தான் போட்டுச்சு அப்படின்னு சொல்லிட்டு சூப்பராக கோலம் போடும். சரிங்களா? இது என்ன தெரியுது? ஷி இஸ் ஹேவிங் ஃபிக்ஸ்டு இன்ட்ரெஸ்ட் டுவர்ட்ஸ் கோலம். அவளுக்கு ஒரு இன்ஸ்டா பேஜும் இருக்குது, கோலம் போட்டு இன்ஸ்டா பேஜும் ஃபாலோ பண்ணுறாங்க. ஸோ ஃபிக்ஸ்டு இன்ட்ரெஸ்ட் இருக்குது, சோஷியல் கம்யூனிகேஷன் எக்ஸாஸ்டிங்காக இருக்குது. நெக்ஸ்ட் லைன். ஓகே. ஒரு கேஸ் மிஸ் ஆகிடுச்சுன்னு நினைக்கிறேன். பாருங்களேன், செகண்ட் கேஸ் முன்னாடி போங்க. முன்னாடி போங்க. இது நீங்கள் போடல. ரிஜிட் ரொட்டீன் சரிங்களா? இது பாருங்க ரிஜிட் ரொட்டீன். இது முக்கியமான கேஸ் சினாரியோ, நல்லா கவனிங்க சரிங்களா? 4 years old child Kavya, which I saw last month in Coimbatore. She attends a local play school and the teacher reports Kavya lives in her own world. அதாவது என்ன அப்படின்னா தினைக்கும் அவங்க ஸ்கூலில் கதை நேரம் அப்படின்னு சொல்லிட்டு ஒன்று வைக்கிறாங்க. எல்லாமே சர்க்கிளாக ஃபார்ம் பண்ணி கதை படித்து காமிப்பாங்க. எல்லா கிட்ஸும் அந்த கதை நேரத்துக்கு ரொம்ப ஆவலாக இருப்பாங்க. போய் உட்காருவாங்க, ஆஹா கதை சொல்லு. அந்த நேரம் தான் எல்லா கிட்ஸுக்கும் பிடிச்ச நேரமாமா. எப்படா நம்ம இந்த காலத்தில் யார் கதை சொல்லி தரா? கையில் ஃபோன் கொடுத்துட்டு போய்டுறோம்ல. ஆனால் ஸோ இந்த கதைகள்லாம் நம்ம அப்போ நம்ம நிறையா டேக் இட் ஃபார் கிராண்டடாக எடுத்துக்கணும். நிறைய கதைகள் கிடச்சிச்சு. இப்போ இருக்க கதைகள் இப்போ இருக்க ஸ்டூடெண்ட்ஸுக்கு அந்த கதைகள் கிடைக்கிறது. அதனால ஸ்கூலில் அந்த கதைகள் நேரம் அவங்களுக்கு ரொம்ப பிடிச்சிருக்கு. அதில் இன்ட்ரெஸ்டடாக உட்காராங்க. இந்த பொண்ணு மட்டும் வந்து பார்த்தோன்னா அந்த கதைகள் நேரத்தில் அந்த பொண்ணுக்கு இன்ட்ரெஸ்டடாக இல்லை. அந்த பொண்ணு தினைக்குமே ஸ்கூலில் ஒரு பொம்மை அது கூட தான் உட்காந்துக்கும், அது கூட தான் விளையாடும், அதில் மட்டும் தான் இன்ட்ரெஸ்ட் காமிக்கும். இந்த கதைகள் நேரத்தில் அந்த பொண்ணுக்கு இன்ட்ரெஸ்டே இல்லை. She has a meltdown if the school bus takes a different route to avoid traffic. அதாவது என்ன அப்படின்னா ஒரே ரூட்டில் தான் அந்த ஸ்கூல் பஸ் எப்பொழுது போகும். ஒரு சில நேரத்தில் டிராஃபிக் ஆகிறப்ப அந்த ஸ்கூல் பஸ்ஸு வேறு ரூட்டை ஃபாலோ பண்ணும். எப்போல்லாம் வேறு ரூட்டில் போகிறன்றது அந்த பொண்ணுக்கு தெரிஞ்சிருச்சோ அப்போல்லாம் அந்த பொண்ணு வேன்லேயே உட்காந்து ஒவ்வொன்று அழ ஆரம்பிச்சு. இது பேர் என்னது? ஃபிக்ஸ்டு பிஹேவியர், ரிஜிட் பிஹேவியர். புரியுதா? அந்த ரொட்டீன்லேருந்து அவங்க வெளியே வந்தாங்க அப்படின்னா அது அவங்களுக்கு ரொம்ப ஸ்ட்ரெஸ்ஃபுல்லாக இருக்கும், ரொம்ப எக்ஸாஸ்டிங்காக இருக்கும். ஸோ ஒரே போகிறப்ப வேற ரூட்டில் போனால் அந்த பொண்ணு அழ ஆரம்பிச்சிடுறாங்க சரிங்களா? அடுத்து ஷீஸ் எக்ஸ்ட்ரீம்லி நிறைய ஆர்டிஸ்டிக் கிட்ஸ் வந்து பார்த்தோன்னா மால் நியூட்ரிஷன். என்ன காரணம் அப்படின்னா ஃபுட் அகெயின் அண்ட் அகெயின். இந்த பொண்ணு திருப்பி வந்து பார்த்தோன்னா தயிர் சாதம் தான் சாப்பிடுமாமா, ஒரே துணி தான் போட்டுக்கணும் சரிங்களா? ஸோ இது புரிஞ்சிருச்சா? ஃபிக்ஸ்டு இன்ட்ரெஸ்ட் புரிஞ்சிருச்சா? ரெடியூஸ்டு இன்ட்ராக்ஷன் வித் அதர் சரிங்களா? ரிஜிட் பிஹேவியர் சரிங்களா? அடுத்து முன்னாடி ஸ்லைடுக்கு போங்க. முன்னாடி ஸ்லைடு அந்த டேபிள் இருங்க அப்படியே வைங்க சரிங்களா? இல்லை நெக்ஸ்ட் ஸ்லைட். ஓகே, இங்கே பாருங்க இந்த லாஸ்ட் பாயிண்ட் பாருங்க, தெரியுதா? இது ரொம்ப முக்கியம் சரிங்களா? சென்சரி சென்சிட்டிவிட்டிஸ். அதாவது என்ன அப்படின்னா ஓவர் ரியாக்ஷன் ஆர் அண்டர் ரியாக்ஷன் டு த சென்சரி ஸ்டிமுலை. நீங்கள் பார்த்தீங்கன்னா நிறைய ஆர்டிஸ்டிக் கிட்ஸுக்கு புதுசாக அவங்களுக்கு பிடிக்காத ஒரு ஸ்மெல்லு, சத்தம் சரிங்களா? இதெல்லாம் வந்து பார்த்தீங்கன்னா ஓவர் சென்சிட்டிவாக இருப்பாங்க சரிங்களா? நீங்கள் நிறைய ஆர்டிஸ்டிக் கிட்ஸ் பார்த்தீங்கன்னா சின்னதாக சவுண்டு கேட்டாலும் காதை மூடிப்பாங்க. தே ஆர் நாட் ஏபிள் டு டாலரேட் த நாய்ஸ். அவங்களுக்கு பிடிக்காத ஸ்மெல்லு எதாவது வருது. நான் பார்த்த வரைக்கும் இந்த மார்க்கர் ஸ்மெல் இருக்குது பார்த்தீங்களா? அந்த மாதிரி பெயிண்ட் ஸ்மெல்லு, மார்க்கர் ஸ்மெல்லு, இதெல்லாம் வந்து அவங்களுக்கு பிடிக்காது. திடீர்னு அவங்க அம்மா சொல்லுவாங்க வீட்டில் பெயிண்ட் அடிக்க ஆரம்பிச்சாங்க, திடீர்னு ரொம்ப கத்த ஆரம்பிச்சிட்டான், அந்த இடத்துக்கு போன ரொம்ப கத்த ஆரம்பிச்சிட்டான், ரொம்ப அழ ஆரம்பிச்சிட்டான். நமக்கு அந்த ஸ்மெல்லு பிடிக்கலாட்டி நம்மளால சொல்ல தெரியும், அம்மா இந்த ஸ்மெல்லு பிடிக்கல எனக்கு அப்படின்னு சொல்லிட்டு. அவங்களுக்கு அது சொல்ல தெரியாது. நிறைய நாய்ஸ் வந்துச்சுன்னா நமக்கு அது எஸ்கேப் ஆக தெரியும், அவங்களுக்கு எஸ்கேப் ஆக தெரியாது, அதை கம்யூனிகேட் பண்ண தெரியாது. அதனால என்ன பண்ணுவாங்க, அதை மாஸ்க் பண்ணுறதுக்காக they will show over reaction, கத்துறது, அழுறது சரிங்களா? இங்கே தான் பிஹேவியர் ப்ராப்ளம் ஸ்டார்ட் ஆகும் சரிங்களா? என்னதான் ஆர்டிஸ்டிக் கிட்ஸ் டிஃப்ரெண்டாக பிஹேவியர் பண்ணாலும் அதுக்கு கீழே அதுக்கு முன்னாடி என்ன நடந்துச்சுன்றத ஹிஸ்ட்ரி நமக்கு ரொம்ப முக்கியம். ஒரு குழந்தை அழுறாங்க அப்படின்னா அந்த இன்சிடென்ட் நடக்கிறதுக்கு முன்னாடி ஜஸ்ட் பிஃபோர் த இன்சிடென்ட் வாட் ஹேப்பன், அந்த ஹிஸ்ட்ரியை நம்ம கரெக்டாக எடுக்கணும் சரிங்களா? அடுத்து ரிஜிட் அண்ட் ரிப்பீட்டேட்டிவ் பிஹேவியர்ஸில் தேர்ட் பாயிண்ட் பாருங்க, எக்ஸ்ட்ரீம் டிஸ்ட்ரெஸ் அட் சேஞ்ச். இதுதான் அந்த கிட்ட பார்த்தோம், காவியான்ற பொண்ணை பார்த்தோம். எக்ஸ்ட்ரீம் சேஞ்ச், அதாவது ஸ்கூல் பஸ்ஸு வேற ரூட்டை போகிறப்ப அவங்களுக்கு ரொம்ப டிஸ்ட்ரெஸ்ஸிங்காக இருக்குது அந்த சுச்சுவேஷன் சரிங்களா? சரி ஓகே, நெக்ஸ்ட் ஸ்லைட் போங்க. நெக்ஸ்ட் ஸ்லைட் போங்க. இல்லை ஃப்ரண்ட்டு வாங்க. ஓகே இருங்க பாருங்க. நெக்ஸ்ட் ஸ்லைட் போங்க, மெதுவாக போங்க. நெக்ஸ்ட் ஸ்லைட். இந்த கேஸ் பாருங்க. ஸோ ரிக்ரெஷன்னா என்னன்றது உங்களுக்கு தெரியணும் ஃபஸ்ட்டு சரிங்களா? ரிக்ரெஷன்னா என்ன அப்படின்னா அந்த டெவலப்மெண்டல் மைல்ஸ்டோன்ஸ்லாம் சொன்னல நான் சரிங்களா? நிறைய ஆர்டிஸ்டிக் பேரண்ட்ஸ் வந்து என்ன சொல்லுவாங்க அப்படின்னா, சார் இவன் 2 வயசு வரைக்கும் நல்லா பேசினான், டாட்டா காமிச்சான், மற்றவங்களோட நல்லா இன்ட்ராக்ட் ஆனான், 2 வயசுக்கு அப்புறம் அவன் இதுக்கு முன்னாடி என்னென்ன பேசிட்டு இருந்தானோ அந்த பேசுறதெல்லாம் கம்மி பண்ணிட்டான் சரிங்களா? இதுக்கு முன்னாடி என்னென்னலாம் பண்ணிட்டானோ அதெல்லாம் இப்போ பண்ணுறதில்ல. ஸோ ஒரு மைல்ஸ்டோன் வந்து அந்த கிட்டு ஏற்கனவே அட்டைன் பண்ணியிருக்காங்க, அதை இப்போ இழந்திருக்காங்க. அந்த டேர்ம் பேர் தான் என்னது? ரெக்ரெஷன். இதுக்கு ஒரு எக்ஸாம்பிள் பார்க்குறோம். Arjun, 3 years old child from Vellore, his home is in an urban area, had about 10 words. ஒரு 10 வார்த்தை அவருக்கு தெரியும் at 18 months of age, but suddenly stopped using the mom. நம்மளால புரிஞ்சுக்கவே முடியல. எல்லாமே யூஸ் பண்றதா சார். ஒரு 2 வயசு ஆயிடுச்சு, பேர் கூப்பிட்டா திரும்ப மாட்டேன்றான், முன்னாடி பேசின வார்த்தையெல்லாம் பேச மாட்டேன்றான், திடீர் சிரிக்க மாட்டேன்றான், நம்ம சிரிச்சா சிரிக்க மாட்டேன்றான், திடீர்னு அழுறான், திடீர்னு கத்துறான், எங்களுக்கு என்னன்னே புரியல அப்படின்னு அம்மா சொன்னாங்க. கீ அப்சர்வேஷன்ஸ் என்ன அப்படின்னா, he lost the ability to wave bye bye. வீட்டில் சொந்தக்காரங்க வந்தா விட்டுட்டு போறப்ப தாட்டா காமிப்பாங்க, டாக்டரை பார்த்துட்டு கேபின் விட்டு வெளியே போறப்ப தாட்டா காமிப்பாங்க. அந்த தாட்டா காமிக்கிற தன்மையை இழந்துட்டாங்க. நம்ம தாட்டா காமிச்சா எல்லா தாட்டா காமிப்பாங்க. நீங்க எது பண்றீங்களோ இல்லையோ தாட்டா மட்டும் நல்லா காமிப்பாங்க. ஏன் எனக்கு உனக்கு பிடிக்கல தாட்டா, அது மட்டும் தாட்டா மட்டும் நல்லா காமிப்பாங்க. அந்த குழந்தை தாட்டா காமிக்கிறது நின்றுச்சு. ஸ்டாப் பாயிண்டிங் அட் ஆப்ஜெக்ட்ஸ் டு ஷோ இன்ட்ரெஸ்ட். நான் சொன்ன மாதிரி அந்த நாய் பாருங்க, பவு அந்த ட்ரெயின் பாருங்க, அதெல்லாம் காமிக்கிறத நிப்பாட்டிட்டாங்க. சரிங்களா? he now leads his mother by hand to the fridge when he wants milk instead of using gestures and sounds. புரியுதா? பால் வேணும்னா அம்மா கையை பிடிச்சிட்டு போய் ஃப்ரிட்ஜில் விட்டுரும், கேட்கலாம் மாட்டான். பால் வேணும், பசிக்குது, எந்த எக்ஸ்பிரஷனும் கொடுக்க மாட்டான், வாயாடி எதுவும் சொல்ல மாட்டாங்க, கையை பிடிச்சிட்டு போய் ஃப்ரிட்ஜ் பக்கத்தில் விட்டுருவாங்க. இப்படி பண்ணால் என்ன அர்த்தம்? அம்மாவை புரிஞ்சுக்கணும், பால் வேணும், பையனுக்கு பசிக்குதுன்னு புரிஞ்சுக்கணும். ஸோ எந்தெந்த ஸ்கில்ஸ்லாம் இதுக்கு முன்னாடி பண்ணிக்கிட்டு இருந்தாரோ அதெல்லாம் he lost it. புரியுதா? இது பேர் தான் ரெக்ரெஷன் அப்படின்னு சொல்லி சொல்கிறோம். இப்போ வரைக்கும் ஒரு 5 கேஸ் நிறைய பார்த்துருக்கோமா? இந்த 5 கேஸ் நிறைய வச்சு ஒரு அளவுக்கு ஆட்டிஸ்டிக் கிட்ஸ் எப்படி ப்ரெசென்ட் ஆவாங்க உங்களுக்கு புரியுதா இல்லையா? யாருக்கெல்லாம் புரிஞ்சு கை தூக்குங்க. சரி, ஓகே, நெக்ஸ்ட் ஸ்லைட் போங்க. அடுத்த சோஷியல் கம்யூனிகேஷன். இந்த கேஸ் பாருங்க, இந்த பையன் வந்து டீச்சர்கிட்ட அடி வாங்கிட்டே இருப்பான். சரிங்களா? திருப்பி அடி வாங்கிட்டே இருப்பான். அதுக்கு என்ன காரணம் அப்படின்னா, அந்த டீச்சருக்கு அந்த பையனுக்கு என்ன நடந்துகிட்டு இருக்குன்ற புரிதல் இல்லை. அந்த டீச்சர் என்ன நினைச்சிட்டு இருக்காரு அப்படின்னா, அவன் வந்து ரூடா பிஹேவ் பண்றான். நான் சொன்ன மாதிரி ஸ்டார்டிங்ல ஒரு எக்ஸாம்பிள் சொன்னேன். நீங்க பிரின்சிபல்கிட்ட பேசுறீங்க அப்படின்றப்ப உங்களுக்கு அந்த சோஷியல் கான்டெக்ட் புரிஞ்சிருக்குது. நீங்க ஒரு ஸ்டூடெண்ட், இவர் ஒரு பிரின்சிபல், அந்த சோஷியல் ரூல் உங்களுக்கு புரிஞ்சிருக்குது. உடம்பு சரியில்லைன்றப்ப எப்படி எக்ஸ்பிரஷன் கொடுக்கணும்னு புரிஞ்சிருக்குது, எப்படி வாயால சொல்லணும்னு புரிஞ்சிருக்குது. இந்த பையனுக்கு அந்த சோஷியல் ரூல் தெரியாது, சோஷியல் கான்டெக்ட் தெரியாது, எப்படி கம்யூனிகேட் பண்ணணும்னு தெரியாது. அதனால அந்த டீச்சர் என்ன நினைச்சுக்கிறாரு அப்படின்னா, இவன் ரொம்ப ரூடு, ஒழுங்காவே பிஹேவ் பண்ண மாட்டேன்றான், அவன் இஷ்டத்து தான் இருக்கான், என்னை கண்ணு கூட நேரில் பார்க்க மாட்டேன்றான், அவன் படிக்க திரும்பிக்கிறான் இப்படி ஏதாவது சொல்லிட்டு அப்படின்னு அடிச்சுக்கிட்டே இருப்பார். இது புரியுதா? இந்த கேஸ் புரியுதுல? சரி, நெக்ஸ்ட் கேஸ். ஓகே, இது வந்து சம்மரி ஆஃப் த கேசஸ். நம்ம பார்த்த கேசஸ்ல எது மேஜர் ஹைலைட்ன்றத சம்மரி. ஃபர்ஸ்ட் கேஸ் பார்த்தோம், அந்த ஆரவன்ற பையன், அவங்க அம்மா அப்பா என்ன சொன்னாங்க, சார் அவன் பேசவே இல்லை அப்படின்னு சொன்னாங்க. அடுத்த நெக்ஸ்ட் கேஸ் பார்த்தோம், காவியா என்னது, ஒரே ரூட்ல தான் போவாங்க, அந்த ரூட்டை வச்சு பார்க்குறப்ப ரொம்ப அழுவாங்க. சரிங்களா? அதான் எக்ஸ்ட்ரீம் ரிஜிடிட்டி. தேர்ட் பாயிண்ட் செல்வம். இந்த பையனுக்கு ரொம்ப அறிவு இருக்குது, ட்ரெயின் அந்த ஸ்டேஷன்லாம் கரெக்டாக சொன்னாப்புல, பட் ஹி இஸ் நாட் ஏபிள் டு மிங்கிள் வித் த பியர்ஸ். அவனுக்கு ஜோக்ஸ் எல்லாம் வந்து ஜோக்ஸாக புரிஞ்சுக்க தெரியாது, லிட்ரலி அதோட மீனிங்கை அப்படியே புரிஞ்சுப்பாங்க. சரிங்களா? ஃபோர்த் கேஸ் வந்து அனன்யா. நான் சொன்ன மாதிரி அந்த பொண்ணுக்கு ஃப்ரெண்ட்ஸோட மிங்கிள் ஆகுறதே ரொம்ப கஷ்டமாக இருக்குது, பட் அதை மாஸ் பண்ணிக்கிட்டு எப்படியாச்சும் மிங்கிள் ஆகணும்னு ட்ரை பண்ணுறாங்க. பட் எப்போலாம் அந்த மாதிரி ட்ரை பண்ணுறாங்களோ ரொம்ப எக்ஸாஸ்டிங்காக இருக்குது, அதனால ஷட் டவுன் ஆகிடுறாங்க. அடுத்த கேஸ் வந்து அர்ஜுன். இந்த பையன் முன்னாடி கற்றுக்கிட்டு இருந்த விஷயம் எல்லாமே 2 வயசுல இழந்துட்டான், அதுதான் ரிக்ரெஷன். அடுத்த கேஸ் வந்து கார்த்திக்கு. இந்த பையனுக்கு எப்படி வந்து அந்த சோஷியல் கான்டெக்ஸ்ட்டுக்கு ஏற்ற மாதிரி பிஹேவ் பண்ணுறதுன்னு தெரியல. ஒரு டீச்சர்கிட்ட எப்படி பிஹேவ் பண்ணுறது, ஒரு ஸ்ட்ரேஞ்சர்கிட்ட எப்படி பிஹேவ் பண்ணுறது, ஒரு ஃப்ரெண்டுக்கிட்ட எப்படி பிஹேவ் பண்ணுறது, இந்த சோஷியல் கான்டெக்ட் தெரியல. ஸோ புரிஞ்சிருச்சுல உங்களுக்கு ஓரளவுக்கு? நெக்ஸ்ட் ஸ்லைட். ஓகே, ஸோ இந்த பாயிண்ட்டை நல்லா எடுத்துக்கோங்க. ஒரு கேஸை நீங்கள் ஆட்டிசம்னு டயக்னோஸ் பண்ணுறீங்க அப்படின்னா, ஃபஸ்ட்டு விஷயம் நீங்கள் டயக்னோஸ் பண்ணுறதுக்கு முன்னாடி பண்ண வேண்டியது என்ன அப்படின்னா, அவங்களோட காதை செக் பண்ணுறது, ஹியரிங் அசஸ்மெண்ட். இதை நான் ஏன் சொல்கிறேன் அப்படின்னா, நிறைய டாக்டர்ஸ் என்ன நினைப்பாங்க அப்படின்னா, பேர் கொடுத்தா திரும்ப மாட்டேன்றாப்புல, அப்படின்னா இந்த பையனுக்கு ஆட்டிசம். காதெல்லாம் நல்லா தான் இருக்கும், அம்மா காது தான் பிரச்சனைன்னு உங்கள் அம்மா கேட்பாங்க. இல்லைம்மா காதெல்லாம் நல்லா தான் இருக்குது, அந்த பையனுக்கு ஆட்டிசம் டிசார்டர் இருக்கிற மாதிரி தெரியுது, அதான் ஐ டு ஐ கான்டாக்ட் வைக்க மாட்டேன்றாப்புல, பேர் கூப்பிட்டா திரும்ப மாட்டேன்றாப்புல, காதெல்லாம் ஒன்றும் பிரச்சனை இல்லை, அது தப்பு. Even though the child is autistic spectrum disorder, it is our duty to rule out the hearing loss first. இதை நான் ஏன் சொல்கிறேன் அப்படின்னா, நிறைய ஆட்டிஸ்டிக் கிட்ஸுக்கு even though they have autism, they can have also concurrent hearing issues. நம்ம அந்த ஹியரிங் இஷ்யூவை கரெக்ட் பண்ணாமல் ஆட்டிசம்க்கு தெரப்பியே கொடுக்க முடியாது. ஏன்? நீங்கள் கொடுக்குற ஸ்டிமுலை எப்படி போகுது? கண்ணு வழியாகவும் காது வழியாகவும் தான் போகுது. கரெக்டாக? இது ரெண்டுமே பிரச்சனையாக இருக்கிறப்ப அந்த பையனுக்கும் அந்த பொண்ணுக்கும் நீங்கள் தெரப்பியே கொடுக்க முடியாது. ஸோ ஆட்டிஸ்டிக் கிட்ஸ் பேருக்கு திருவிழா அப்படின்றதுக்காக ஆட்டிசம் அப்படி தான் இருக்குன்னு அசியூம் பண்ணிக்காம அவங்க ஹியரிங் இஷ்யூவை செக் பண்ணுறது நம்மளோட கடமை. ஸோ இப்போ எப்படி சார் செக் பண்ணுறது? அதுதான் என்ன பண்ணாலும் அவங்க திரும்ப மாட்டேங்கிறாங்களே. எப்படி செக் பண்ணுறதுனா அங்கே தான் அப்ஜெக்டிவ் டெஸ்ட். அப்ஜெக்டிவ் டெஸ்ட்னா என்ன அப்படின்னு சொல்லி பார்த்தோன்னா அந்த சைல்டோட கோஆப்ரேஷன் நமக்கு தேவையில்லை. த டெஸ்ட் வில் ஃபைண்ட் அவுட் வெதர் த ears ஆர் ஃபங்க்ஷனிங் ஆர் நாட். அடுத்த ஸ்லைட். அதுதான் அந்த டெஸ்ட் பேர் என்ன அப்படின்னா ஓட்டோ அக்வஸ்டிக் எமிஷன் டெஸ்ட் ஆடிட்டரி பிரெயின் சிஸ்டம் ரெஸ்பான்ஸ், OAE பேரான் அப்படின்னு சொல்லுவாங்க. நீங்கள் கிளினிக்கல் ப்ராக்டிஸில் இறங்கின பிறகு இதை நிறைய நீங்கள் பார்க்கலாம். சரிங்களா? இதுக்கு அந்த சைல்டோட கோஆப்ரேஷன் தேவையில்லை. சரிங்களா? ஓகே, நெக்ஸ்ட் ஸ்லைட். சரி, இப்போ ஓகே, நீங்கள் சார் எனக்கு நீங்கள் இதெல்லாம் சொல்லிட்டீங்க, இருந்தாலும் எனக்கு கஷ்டமாக இருக்குது, ஓரளவுக்கு புரியல எனக்கு எப்படி ஆட்டிசம் பிக் பண்ணுறது. ஆனால் டவுட்டாக இருக்குது சார், ஆட்டிசமாக இருக்குமோ எனக்கு ஆனால் டவுட்டாக இருக்குது, ஆனால் எனக்கு அந்த கான்ஃபிடன்ஸ் வர மாட்டேங்குது, கரெக்டாக இது ஆட்டிசம் தானான்னு சொல்கிறாங்க. அதுக்கு தான் வந்து உங்களுக்கு இந்த கிட் பேர் என்ன அப்படின்னா ஸ்க்ரீனிங் டெஸ்ட், MCHAT ஸ்க்ரீனிங் டெஸ்ட். சரிங்களா? இந்த ஸ்க்ரீனிங் டெஸ்ட்டை யூஸ் பண்ணி அந்த கிட்டு ஆட்டிசம் ரிஸ்க்கு லோவாக இருக்குதா, மீடியமாக ஹையாக இருக்குதான்றதை நீங்கள் கேட்டகரைஸ் பண்ணிடலாம். நீங்கள் யோசிக்கவே தேவையில்லை. சரிங்களா? அந்த கிட்டில் அந்த ஸ்க்ரீனிங் டெஸ்ட்டில் நீங்கள் டவுன்லோட் பண்ணாலே ஒரு PDF மாதிரி வந்துடும். மொத்தம் 20 கொஸ்டின் இருக்கும். அந்த 20 கொஸ்டினும் நீங்கள் அம்மாட்ட கேட்குறீங்க. எக்ஸ்பிளனேஷன்லாம் தேவையில்லை. எஸ் ஆர் நோ, எஸ் ஆர் நோ. ஓகேங்களா? ஓகே, அதுக்கு எக்ஸாம்பிள் சொல்கிறேன். அடுத்த ஸ்லைட் போங்க. இதான் சாம்பிளுக்கு உங்களுக்கு நான் 20 கொஸ்டினும் போடலை. சரிங்களா? சாம்பிளுக்கு ஒரு 5 கொஸ்டின் மட்டும் போடுறேன். அதை மட்டும் டக்குன்னு படிச்சு காமிக்கிறேன். கொஞ்சம் நல்லா கவனிங்க. First question, if you point at something across the room, does your child look at it? அங்கே பாரு அப்படின்னு சொல்லி பார்க்குறாங்களா? எல்லா குழந்தைங்களும் பார்க்குறாங்களா இல்லையா? அதான் உங்கள் குழந்தை பண்ணுறாங்களா இல்லையா? நெக்ஸ்ட் பாயிண்ட், அதுக்கு 2 ஆன்சர் தான், எஸ் ஆர் நோ. சரிங்களா? 2 ஆன்சர் தான், எஸ் ஆர் நோ. எஸ்ன்னு சொல்லிட்டாங்க அப்படின்னா பாசிட்டிவ் ரெஸ்பான்ஸ் சொன்னால் காமிக்கிறாங்க, அப்புறம் பாசிட்டிவ் ரெஸ்பான்ஸ்னா 0 போடுங்க. 0 இல்லைங்க கையை காமிச்சா திரும்ப மாட்டேன்றாங்க அப்படின்னா நெகட்டிவ் ரெஸ்பான்ஸ். நெகட்டிவ் ரெஸ்பான்ஸ்னா ஸ்கோர் 1 போடுங்க. 0 1. சரிங்களா? பாசிட்டிவ் ரெஸ்பான்ஸ்னா 0, நெகட்டிவ் ரெஸ்பான்ஸ்னா 1. சரிங்களா? நெக்ஸ்ட் பாயிண்ட், நெக்ஸ்ட் ஸ்லைடு இல்லை. நெக்ஸ்ட் கொஸ்டின் என்ன அப்படின்னா, ஹேவ் யூ எவர் வண்டர்ட் இஃப் யுவர் சைல்ட் மைட் பி டெஃப்? எல்லா ஆர்டிஸ்டிக் பேரண்ட்ஸுக்கும், குழந்தைங்க இருக்கிற பேரண்ட்ஸுக்குமே ஒரு டவுட் இருக்கும், என் குழந்தைக்கு காது சரியாக கேட்குதா இல்லையா? அந்த மாதிரி உங்களுக்கு சந்தேகம் ஏற்பட்டுருந்தா இல்லையா? எஸ் ஆர் நோ. ஓகே, அடுத்து, does your child play pretend or make believe? இது என்ன அப்படின்னா சொப்பு சாமான் பார்த்துருக்கீங்களா? சொப்பு சாமான் கேள்விப்பட்டிருக்கீங்களா? வீட்டில் எல்லா குழந்தைகளும் என்ன பண்ணுவாங்க? சொப்பு ஜாமான்ல தோசை சுட்டு, அம்மா இந்த தோசை, சொப்பு ஜாமான்ல தண்ணி பிடிச்சி இந்த தண்ணி விளையாண்டு பார்த்துருக்கீங்களா? நீங்களும் சாப்பிட்டுப்பீங்களா? அதை இதுதான் இல்லாத ஒரு விஷயத்தை இருக்குன்னு நினச்சி ப்ரிட்டன் பண்ணி விளையாடுறது. இது நார்மல், இது இல்லாட்டி இது அப்நார்மல். ப்ரிட்டன் பிளே. உங்கள் சைல்டு இந்த மாதிரி ப்ரிட்டன் பிளே பண்ணுறாங்களா இல்லையா? 4th கொஸ்டின், does your child climbing on things? சரிங்களா? ஸோ இது வந்து பாசிட்டிவ் ரெஸ்பான்ஸ். அது ஒழுங்காக கிளைம் பண்ணுறாங்க அப்படின்னு சொல்லி பார்த்தா எல்லா குழந்தைங்களும் பண்ணுற ஒரு நார்மல் மோட்டார் மூமெண்ட்ஸ், இது பண்ணுறாங்களா இல்லையா? அடுத்து 5th, does your child make unusual finger movements near his or her eyes? இந்த ஃபர்ஸ்ட் வீடியோ காமிச்சோம்ல, அதுதான் unusual finger movements. இது வந்து repetitive unusual awkward behavior. சரிங்களா? which is not having any purpose. அந்த மாதிரி கண்ணு பக்கத்தில் ஏதோ பண்ணுறாங்களா? இது நம்ம கேட்கணும். இது வந்து சாம்பிள் 5 கொஸ்டின்ஸு. இந்த மாதிரி 20 கொஸ்டின்ஸ் இருக்குது. இந்த 20 கொஸ்டின்ஸுக்கு பாசிட்டிவ் ரெஸ்பான்ஸ் அப்படின்னு, அதாவது ஆர்டிஸ்டிக் சைடில் இல்லை அப்படின்னா 0 கொடுங்க, ஆர்டிஸ்டிக் சைடு இருக்குது அப்படின்னா 1 கொடுங்க. ஸோ நீங்கள் டோட்டலாக இப்போ இந்த 20 கொஸ்டின் கேட்டு முடிச்சிட்டீங்க. முன்னாடி ஸ்லைட் போங்க. இது நான் சொன்ன மாதிரி நெக்ஸ்ட் ஸ்லைட் போங்க. நெக்ஸ்ட் ஸ்லைட் போங்க. இல்லை நெக்ஸ்ட் ஸ்லைட். ஓகே, இப்போ ஸ்கோரிங் பண்ணிட்டீங்க. ஸ்கோரிங் பண்ணப்ப 0 to 2 வருது அப்படின்னா பயப்பட தேவை நீங்கள். ஆனால் நீங்கள் கேட்குற கொஸ்டின்ஸ் வந்து கரெக்டாக பேரண்ட்ஸ்க்கு புரிகிற மாதிரி கேட்கும். என்ன அப்படின்னா மோஸ்ட் ஆஃப் த ஆர்டிஸ்டிக் பேரண்ட்ஸ் ஹேவ் திஸ் டெண்டன்சி டு டினை திங்ஸ். இல்லை அதெல்லாம் பண்ணுவாங்க, they won't accept it actually. They have first thing they do is denial. இல்லை என் சைல்டு நார்மல் தான் அப்படின்னு சொல்லிட்டு. ஸோ நீங்கள் ப்ராப்பராக அந்த ரேப்பை எஸ்டாப்ளிஷ் பண்ணி நீங்கள் ப்ராப்பராக அந்த கொஸ்டின்ஸ் எடுத்து ஸ்க்ரீனிங் எடுத்து அவங்க சொல்கிறது ரிலையபிள் இன்ஃபர்மேஷன் செக் பண்ணி ஸ்கோரிங் பண்ணிட்டீங்க. 0 to 2 இருக்குன்னா வெரி லோ சான்ஸ் ஆஃப் ஹேவிங் ஆட்டிசம். அடுத்து 3 to 7 இருக்கு அப்படின்னா moderate chance of having autism. இந்த கிட்டுக்கு தான் நீங்க என்ன பண்றீங்க, tell them to come for review. திருப்பி ரிவ்யூ சொல்லணும், சரிங்களா? பட் ரிவ்யூக்கு வரப்ப don't waste your time, don't tell them to wait at home. You just instruct them. Most of them will not come for therapy. They don't have the sense of coming to therapy, and also sometimes this therapy is pricey also actually. So autistic வந்து பணக்கார குழந்தைகளுக்கு மட்டும் வரதில்லை, தெரியாதனமா நிறைய ஏழை குழந்தைகளுக்கு வருது, அவங்களால தெரப்பி அஃபோர்ட் பண்ண முடியாது. ஸோ நீங்கள் சொல்லி அனுப்புங்க, அம்மா ஒரு 2 மாதம் கழிச்சுவாங்க. ஆனால் அந்த 2 மாதத்துல நீங்கள் என்னென்ன பண்ணுங்க அப்படின்னா, குழந்தையோட நிறையா நேரம் செலவழிக்க பாருங்க, நிறைய பேசுங்க, கதை படிச்சு காமிங்க, ஒரு வார்த்தையை சொல்லி கொடுங்க, கண்ணத்தை திருப்பி ஐ டு ஐ கான்டாக்ட் வச்சுக்கிறதுக்கு ட்ரைனிங் கொடுங்க. இதுக்கெல்லாம் வந்து தெரப்பி படிச்சுக்கணும்னு அவசியம், நீங்களே இதெல்லாம் பண்ணலாம், சரிங்களா? நிறையா வந்து புது ஸ்டிமுலேஷன் கொடுங்க, தினைக்கு 1 மணி நேரம் வெளியே கூட்டிகிட்டு போங்க, சன்லைட்டை ஃபேஸ் பண்ண வைங்க, சரிங்களா? குழந்தைங்களோட விளையாட வைங்க. இந்த மாதிரி இந்த 2 மாதத்தை அடிக்கட்டாக யூட்டிலைஸ் பண்ணிக்கணும். இப்போ திருப்பி 2 மாதம் கழிச்சு வரப்ப ஸ்கோர் வந்து இப்போ நீங்கள் கேட்குறப்ப <2 no chance of autism. இல்லை அதே 3 to 7 தான் இருக்குது அப்படின்னா you refer the child to pediatrician so that he can diagnose the autism and he can send the child for therapy. இல்லை சார், நான் ஃபர்ஸ்ட் டைம் ஸ்க்ரீன் பண்ணும்போதே எனக்கு 7க்கு மேலே தான் ஸ்கோர் வருதுன்னா don't wait, it's a clear cut case of autism. Send the child to the pediatrician, let him diagnose and label the child as ASD and let him find the co-occurring conditions also, medical conditions also in the child, and put the child in the proper therapy. சரிங்களா? நெக்ஸ்ட் பாயிண்ட். ஓகே, ஸோ இது வரைக்கும் நம்ம நடத்தினது தான் ஆட்டிசமோட அண்டர்ஸ்டாண்டிங். உங்களுக்கு புரிஞ்சிருச்சுல? இனிமேட்டு நடத்த போகிறது கொஞ்சம் தியரி, அதனால் அது தியரி ரொம்ப நடத்தலை, சும்மா பேசிக் ஆட்டிசம் பற்றி இவ்வளோ தெரிஞ்சிருக்கு, எப்படி கண்டுபிடிக்க தெரிஞ்சிருக்கு. ஆனால் அது எதனால வரல, ஒரு ஆட்டிஸ்டிக் கிட்ஸுக்கு வேற என்னென்னலாம் இருக்க வாய்ப்பு இருக்குது, அது தெரியலாட்டி நீங்கள் அது சரியாக இருக்காது. அதனால இந்த இதையும் நல்லா கவனிங்க. 5 பாயிண்ட் தான். ஃபர்ஸ்ட் பாயிண்ட் என்ன அப்படின்னா ஜெனட்டிக் டிட்டர்மினன்ட்ஸ். ஸோ ஜெனட்டிக்னா அப்பா அம்மாட்ட இருக்கணும்னு அவசியம் இல்லை, அந்த பாயிண்ட்டை ஃபஸ்ட்டு புரிஞ்சுக்கோங்க. அது பேர் தான் டினோவா மியூட்டேஷன்ஸ் அப்படின்வாங்க. இன்ஹெரிட்டட் மியூட்டேஷன்ஸ்னா பேரண்ட்ஸ்லேருந்து வருது, சரிங்களா? டினோவா மியூட்டேஷன்ஸ் அப்படின்னா ஃப்ரெஷ் மியூட்டேஷன்ஸ், பேரண்ட்ஸ்க்கு இருக்காது ஆனால் அந்த குழந்தைகிட்ட இருக்கு. ஸோ மோஸ்ட்லி வந்து பார்த்தீங்கன்னா ஜெனட்டிக் ப்ரிடாமினன்ஸ். There are thousands of genes involved in autism which is still undergoing research only. So genetic predominance தான் மேஜரான காம்பனன்ட். இந்த ஜீன்ஸ்லாம் ரோல் என்ன அப்படின்னா, their role is to make the neural network in the brain which is responsible for social communication. நம்ம பிரெயின்ல ஒரு ஏரியாவுக்கும் ஒரு ஃபங்க்ஷன் இருக்கும். சென்சரி கார்டெக்ஸ் பார்த்துருப்போம், மோட்டார் கார்டெக்ஸ் பார்த்துருப்போம். அதே மாதிரி சோஷியலாக எப்படி பழகிறதுக்கு ஒரு பார்ட் ஆஃப் பிரெயின் இருக்குது. கரெக்டாக இது அந்த பார்ட்டை தான் அஃபெக்ட் பண்ணுது. அப்புறமேட்டு நம்ம பிறந்த உடனே பேஸ்ட் ஆன் அவர் எக்ஸ்பீரியன்சஸ் நியூரல் கனெக்ஷன்ஸ் ஆர் ஃபார்ம், சரிங்களா? ஒரு அம்மா போயிட்டு குழந்தை அழுறப்ப ஹக் பண்ணும் போது நம்ம அழுதா நம்மளை அரவணைக்க ஒரு ஆள் இருக்காங்கன்னு சொல்லிட்டு ஒரு புது நியூரல் கனெக்ஷன் ஃபார்ம் ஆகுது, சரிங்களா? நம்மளை நிக்கல்னு பேர் சொல்லி கூப்பிடுறாங்க திருப்பி அப்படின்னா நம்ம திரும்பணும் அப்படின்ற நியூரல் கனெக்ஷன் ஃபார்ம் ஆகுது. இப்படி கிளாஸை எடுத்து நான் கமுத்தேன் அப்படின்னா தண்ணி வெளியே வருது, இந்த புரிதலுக்கு ஒரு நியூரல் கனெக்ஷன்ஸ் ஃபார்ம் ஆகும், சரிங்களா? இந்த மாதிரி மேக்கிங் நியூரல் கனெக்ஷன்ஸ்க்கு எந்த ஜீன் ரெஸ்பான்சிபிளா இருக்குதோ அந்த ஜீன் அஃபெக்ட் ஆகுது. அதனால தான் they have this rigid behavior, they are not able to adapt to it. அதான் they have rigid behavior. ஓகே, இது வந்து ஜெனட்டிக் காம்பனன்ட், எந்த பார்ட் ஆஃப் த பிரெயின் அதை அஃபெக்ட் பண்ணுது அந்த ஜீன்ஸ்ன்றதை படிச்சோம். மூணாவது வந்து பார்த்தா அப்படின்னா அவுட்ரைட் ஜெனட்டிக் சிண்ட்ரோம்ஸ். பார்த்தோன்னா அதாவது என்ன பண்ணால் டவுன் சிண்ட்ரோம் கேள்விப்பட்டிருப்பீங்க, சரிங்களா? இந்த மாதிரி ஒரு நிறைய சிண்ட்ரோம்ஸில் ஆட்டிஸ்டிக் ஸ்பெக்ட்ரம் டிஸார்டர் இஸ் அ காம்பனன்ட். இருக்கலாம், எல்லாமே இருக்கலாம், சரிங்களா? அதுக்கெல்லாம் வந்து பார்த்தீங்கன்னா ஆல்ரெடி என்ன ஜீன்ஸ் அஃபெக்ட் ஆகிருக்குன்றது நமக்கு கிளியர் கட்டாக ஸ்டடீஸ் இருக்குது, எவிடன்ஸ் இருக்குது, சரிங்களா? 4th ஒன் தான் என்விரான்மெண்டல் ரிஸ்க் ஃபேக்டர்ஸ். அதாவது இந்த என்விரான்மெண்டல் ரிஸ்க் ஃபேக்டர்ஸ் இஸ் நாட் த பிரைமரி காஸ். எப்படி அப்படின்னா ஆல்ரெடி அந்த குழந்தைக்கு ஜெனட்டிக் காம்பனன்ட் இருக்குது, the kid is prone to become autistic, but this environmental components just aggravated it. அதாவது எரியிற தீயில என்ன ஊத்திருச்சு இந்த என்விரான்மெண்டல் ஃபேக்டர்ஸ். அதுதான் என்ன அப்படின்னா அட்வான்ஸ்டு பேரண்டல் ஏஜ், ப்ரீமெச்சூரிட்டி, ஷார்ட் இன்டர் பிரெக்னன்சி இன்டர்வல், மெட்டர்னல் ஒபிசிட்டி, prenatal infections like rubella, CMV, environmental toxins like pesticides and air pollution. நல்லா நோட் பண்ணிக்கோங்க, வேக்சின்ஸ் இஸ் நாட் த காஸ் ஃபார் ஆட்டிசம். நிறையா அம்மா அப்பாக்கள் இது வந்து ஒரு பொய்யான கான்செப்ட். நிறைய அம்மா அப்பா வேக்சின் போகிறதுக்கு பயப்படுறதுக்கு காரணமே என்னன்னா போட்ட ஆட்டிசம் வருமாட்டு. அந்த மாதிரி எந்த ஸ்டடீஸுமே இது வரைக்கும் இல்லை, சரிங்களா? இது வந்து கிளப்பி விட்ட கதை தான், எந்த ஸ்டடீஸுமே அந்த மாதிரி இல்லை. முக்கியமாக சொல்ல போனால் MMR வேக்சின் சொல்கிறாங்க பார்த்தீங்களா, அது போட்டால் ஆட்டிசம் வருது அப்படின்ட்டு நிறைய அம்மாக்கள் நம்புகிறாங்க. இது ஏன் நடக்குதுன்றதுக்கு ஒரு சிம்பிள் லாஜிக் சொல்கிறேன். ஏன் நடக்குது அப்படின்றதுக்கு நம்ம ஆட்டிசம் எப்போ கண்டுபிடிப்போம்? நம்ம சொல்லிட்டோம் 2 மாசத்துல சோஷியல் ஸ்மைலாட்டி கண்டுபிடிக்கலாம். பட் அது எல்லா இடத்துல நடக்கிறது கிடையாது. அதை மிஸ் பண்ணிடுவாங்க. மோஸ்ட்லி எப்போ கண்டுபிடிக்கிறாங்க அப்படின்னா, 1 வயசு முடிஞ்சிருச்சு, இன்னும் 1 வாரத்தை கூட பேசல, சிரிக்க மாட்டேன்றான், கண்ணுக்கு கண்ணு பார்க்க மாட்டேன்றான், பேர் கூப்பிட்டா திரும்ப மாட்டேன்றான். 1 வயசு முடிகிறப்ப தான் ஏதோ ஒரு பிரச்சனை இருக்குன்றது நமக்கு புரியும். இந்த வேக்சின் எப்போ போட்டிருப்பாங்க? 9 monthsல போட்டிருப்பாங்க. கரெக்டா? ஸோ மதர் எது கூட ரிலேட் பண்ணிப்பாங்க? அது வரைக்கும் நல்லா இருந்தான், வேக்சின் போட்ட பிறகு தான் இப்படி ஆச்சு. ஸோ இதுதான் கிடையாது. எந்த ஸ்டடீஸுமே அப்படி இல்லை. சரிங்களா? சரி, ஓகே. நெக்ஸ்ட் ஸ்லைட். ஸோ இது வந்து co-occurring conditions. பார்த்தீங்கன்னா இந்த ஆட்டிஸ்டிக் கிட்ஸ்க்கு வந்து பார்த்தோன்னா தேர் சென்சரி சிஸ்டம் இஸ் பேசிக்கலி டிஸ்ரப்டட். அதனால கொஞ்சம் co-occurring இன்டெலெக்சுவல் டிசபிலிட்டியும் அவங்களுக்கு இருக்கும். தே ஹேவ் எபிலெப்சி ஆல்சோ. நிறைய ஆட்டிஸ்டிக் கிட்ஸ்க்கு வந்து பார்த்தோன்னா வலிப்பு பிரச்சனை இருக்கும். அண்ட் தே ஹேவ் GARD பிரச்சனை. எனக்கு ஒரு குழந்தை வந்தாங்க, அம்மா சொன்னாங்க என்ன அப்படின்னா, சாப்பிட்ட சாப்பாடை வெளியே எடுத்து வாய்க்குள்ளே வச்சுட்டு திருப்பி முழுங்கிட்டோம். இதையே திருப்பி திருப்பி பண்ணிட்டு இருக்கோம். இதுக்கு 2 காரணம் இருக்குது, வாய்ப்பு இருக்குது. கேஸ்ட்ரோஇசோஃபேகல் ரிஃப்ளெக்ஸ் டிஸார்டர் இருக்கும் வாய்ப்பு இருக்குது. ஆனால் ஆல்சோ என்னது, ரிப்பீட்டேட்டிவ் பிஹேவியர், அப்நார்மல் பிஹேவியர், ரிப்பீட்டேட்டிவ் பிஹேவியர், அதுவும் இருக்க வாய்ப்பு இருக்குது. வாமிட்டிங், சரிங்களா, கான்ஸ்டிபேஷன். முக்கியமானது என்ன அப்படின்னா, ஸ்லீப் இஷ்யூஸ் இருக்கும். நைட்டு தூங்கவே மாட்டேன்றான் அப்படின்னு சொல்லிட்டு அங்கே தான் ஸ்லீப் ஹைஜீன் ஒரு பாயிண்ட் இருக்குது. அதை நான் அப்புறமேட்டு சொல்லித்தரேன். மெலட்டோனின் ஒரு மெடிக்கல் தெரப்பி என்னன்னா, மெலட்டோனின்ற ஒரு சிறப்பு இருக்குது. சரிங்களா? அடுத்து பிஹேவியரல் இஷ்யூஸ். நிறைய ஆட்டிஸ்டிக் கிட்ஸு சஃபர் ஆகிறது இந்த பிஹேவியரல் இஷ்யூஸ்னால தான். ஒன்று புரிஞ்சுக்கோங்க, பிஹேவியரல் இஷ்யூஸ் ஆர் நாட் த டைரக்ட் அவுட்கம் ஆஃப் த ஆட்டிசம் டிசீஸ். நான் சொன்ன மாதிரி ஆட்டிஸ்டிக் கிட்ஸு நம்ம ஹாஸ்பிட்டலில் கூட ஒரு பையன் வந்து தெரப்பி எடுத்துகிட்டு இருப்பான், கற்றுக்கிட்டே இருப்பான், பேசிக்கிட்டே இருப்பான். ஏதாச்சும் அதை பார்க்குறவங்க என்ன நினைப்பாங்க, சரியான அராத்து பேசிக்கிட்டே இருக்குன்னு நினைப்பாங்க. Their behavioral issues is not the direct outcome of autism. Rather என்ன அப்படின்னா, மற்ற அவுட் சைடு சத்தத்தை கேட்குறத மாஸ்க் பண்ணுறதுக்காக கத்திக்கிட்டே இருப்பாங்க. ஏதாச்சும் ஒரு சத்தம் உங்களுக்கு நல்லா சத்தம் இருக்கிறப்ப நீங்கள் ஏதாவது கத்த ஆரம்பிங்க, உங்களுக்கு வெளியே இருக்க சத்தம் கேட்காது. சரிங்களா? அதை மாஸ்க் பண்ணுறதுக்காக keeps on crying or shouting. சரிங்களா? ஸோ இந்த மாதிரி ஒரு பிஹேவியர் அண்டர்லைங் காஸ் இருக்கும். அது என்ன நம்ம கண்டுபிடிக்கணும். நெக்ஸ்ட் ஸ்லைட். நான் சொன்ன மாதிரி ஸ்லீப் அண்ட் ஃபீடிங் ப்ராப்ளம்ஸ் இருக்கும். ஃபீடிங் மோஸ்ட் ஆஃப் த ஆட்டிசம் இருக்கும் பிகாஸ் ஆஃப் தேர் செலக்டிவ் ஃபுட் ஹேபிட்ஸ். நான் இந்த காய் சாப்பிட மாட்டேன், இந்த நான்வெஜ் சாப்பிட மாட்டேன், எனக்கு தயிர் சாதம் தான் திருப்பி திருப்பி கேட்கணும் அப்படின்றப்ப என்ன ஆகும், மைக்ரோ அண்ட் மேக்ரோ நியூட்ரியன் டெஃபிஷியன்சி ஏற்படும், நியூட்ரிஷனல் டிசார்டர்ஸ் ஏற்படும். சரிங்களா? ஓகே. சேஃப்டி அண்ட் இன்ஜுரி இஷ்யூஸ் நிறையா இருக்கும் ஆட்டிஸ்டிக் கிட்ஸுக்கு. they don't understand basically இன்டெலெக்சுவல் டிசபிலிட்டியும் கன்கரண்டாக இருக்குன்ற பட்சத்தில் எது ரிஸ்க்கு அந்த பேசிக்கான புரிதல் அவங்களுக்கு இருக்காது. இன்ஜுரி சான்சஸ் நிறையா இருக்குது. நெக்ஸ்ட் ஸ்லைட். ஸோ இது லாஸ்ட் ஸ்லைட் இருக்குது, நல்லா பார்த்துக்கோங்க. எதெல்லாம் அவங்களுக்கு எதனால அவங்களுக்கு ரொம்ப ஸ்ட்ரெஸ் ஆகுது அப்படின்னா, புவர் கான்செப்ட் ஆஃப் டைம். இதனால தான் வந்து ஸ்லீப் இஷ்யூஸ் வருது. டிஃபிகல்ட்டிஸ் இன் மேக்கிங் சென்ஸ் ஆஃப் த ரூல்ஸ். நான் சொன்ன மாதிரி அந்த சோஷியல் ரூல்ஸ்க்கு அவங்களால தக்க வச்சுக்க முடியாது. அதர் எமோஷன்ஸ் இருக்கும். சென்சரி டிஃபிகல்ட்டிஸ், எக்ஸ்ட்ரீம் சென்சிட்டிவ் டு வாட் நாய்ஸ், ஸ்மெல், அந்த மாதிரி. சில டைம் வந்து பார்த்தோன்னா சென்ஸே இருக்காது, என்னதான் சத்தம் போட்டாலும் அப்படியே இருப்பாங்க. ஹைப்பர் ரியாக்டிவிட்டி அண்ட் ஹைப்பர் ரியாக்டிவிட்டி. லிட்ரல் இன்டர்பிரிட்டேஷன் ஆஃப் த சிச்சுவேஷன். நான் சொன்ன மாதிரி சாப்பாடு சூப்பராக இருந்துச்சு அப்போ நம்ம கிண்டல் பண்ணவும், இது லிட்ரலி டேக் சாப்பாடு உண்மையிலே நல்லா இருந்துச்சு தான் அப்படின்னு சொல்லி நீ தானே பண்ணிட்டு தான் மறுவேளை பார்ப்பேன் அப்படின்னு சொன்ன கிண்டலுக்கு சொன்னோம் அப்படின்னா, தே வில் லிட்ரலி டேக் நம்மளை அப்ரிஷியேட் பண்ணுறாங்க. லிட்ரல் இன்டர்பிரிட்டேஷன் ஆஃப் த வேர்ட்ஸ். டிஃபிகல்ட்டிஸ் வித் கம்யூனிகேஷன். நான் சொன்ன மாதிரி அந்த காவியான்ற பொண்ணு ஃபிட்டாக ட்ரை பண்ணதில்ல, சர்க்கிளோட ஃபிட்டாக ட்ரை பண்ணதில்ல. டிஃபிகல்ட்டிஸ் வித் கம்யூனிகேஷன். அன்சர்டனிட்டி அரௌண்ட் வாட் இஸ் கோயிங் டு ஹேப்பன். நம்ம இந்த சுச்சுவேஷனுக்கு எப்படி ரியாக்ட் பண்ணுறதுன்னு தெரியாது, நம்ம பண்ணால் அடுத்து என்ன நடக்குன்றதும் தெரியாது. இப்போ உங்களுக்கு ஓரளவுக்கு அந்த புரிதல் இருக்குது. நம்ம போய் சார்கிட்ட கேட்டால் சார் ரெண்டு இதுதான் இருக்குது. ஒன்று லீவ் எடுத்துக்கோப்பான்னு சொல்லுவாங்க, இல்லாட்டி இங்கே ஸ்கூலுக்கு வந்து தூங்கிக்கோப்பான்னு சொல்லுவாங்க. இந்த 2 தான் இருக்குது. பட் அவங்களுக்கு அது தெரியாது. ஏன் தெரியாது? நம்மளுக்கு தான் எப்படி பேச தெரியாது, நம்ம போய் எப்படி ரியாக்ட், இந்த அன்சர்டனிட்டி அவங்களுக்கு இருக்கும். சரிங்களா? இது எல்லாமே என்ன பண்ணும், will cause increased stress in the autistic kids. ஸோ அதை வந்து அக்ரவேட் ஆகிட்டே. ஸோ இதுக்கு என்ன பண்ணும் அப்படின்னா, சுற்றி இருக்கிற அந்த ப்ரைமரி கேர் கிவர்ஸ், இந்த மதர், டீச்சர்ஸ், ரிலேட்டிவ்ஸ், நெய்பர்ஸ், ஹெல்த் கேர் ஒர்க்கர்ஸ், இவங்க எல்லாத்துக்குமே வந்து பார்த்தோன்னா ஒரு ஆட்டிஸ்டிக் கிட்டு ஒரு மாதிரி பிஹேவியர் பண்ணுறாங்க அப்படின்னா அதுக்கு அண்டர்லைங் ரீசன் என்னன்னு நம்ம புரிஞ்சுக்கணும். சரிங்களா? we should not label them, we should not mock them, rather understand the disease pathology by itself. ரெண்டாவது லாஸ்ட் லைஃப். ஸோ இங்கே பாருங்கள், நம்ம கண்ணுக்கு தெரியறது எல்லாமே என்ன அப்படின்னா சைல்டு புஷிங், சைல்டு ஹிட்டிங் இட் அதர்ஸ், சைல்டு த்ரோயிங் சம்திங், சைல்டு பைட்டிங், சைல்டு ஸ்பிட்டிங். பட் இது எல்லாமே inability to express themselves both verbally and non-verbally. அந்த கடுப்பு, அந்த விரக்தி தான் வந்து பார்த்தோன்னா இந்த மாதிரி பிஹேவியர்ஸ் வருது. ஸோ எது காரணமோ அதை நம்ம பார்க்கணுமே தவிர எது அவுட்கமோ அதை நம்ம பார்க்க என்ன அப்படின்னா டிஃபிகல்டிஸ் இன் மேக்கிங் சென்ஸ் ஆஃப் த சோஷியல் ரூல்ஸ், கன்ஃபியூஷன் அரௌண்ட் அதர்ஸ் ஃபீலிங்ஸ், அவங்க என்ன நினைக்கிறாங்க, சென்சிட்டிவிட்டிஸ் டு த நாய்ஸ், ஃப்ரஸ்ட்ரேஷன் த்ரூ இன்னபிலிட்டி டு கம்யூனிகேட் அப்ராப்ரியேட்லி. இந்த காரணங்களால தான் மேலே இருக்கிற தண்ணிக்கு மேலே இருக்கிற ஐஸ்பர்க் நமக்கு தெரியுது, பட் தண்ணிக்கு கீழே இருக்கிறது என்ன அப்படின்னா இந்த கஷ்டங்கள் தான். சரிங்களா? ஏதாவது டவுட்ஸ் இருந்தால் கேளுங்க, நம்ம செஷன் அவ்வளோதான். உங்களுக்கு ஓரளவுக்கு ஏஎஸ்டியோட புரிதல் இருந்திருக்கும்னு நான் நம்புகிறேன். ஏதாவது டவுட்ஸ் இருந்தால் கேளுங்க.
It was a wonderful presentation, and
Thank
you
you.
actually went down to the level of the students and have explained it really well.
Thank you,
I'm
ma'am.
sure many of them would have understood quite well what autism is. I just have a question, how do you differentiate between a typical autism and children with autistic traits?
Okay, ma'am.
So
Yes,
we
ma'am.
come back
That is the
yeah.
thing actually. So we are going to the DSM manual slide. ஒரு மூணாவது ஸ்லைடுக்கு போங்க. மூணாவது ஸ்லைடுக்கு போங்க. நெக்ஸ்ட் ஓகே. ஸோ இந்த ஸ்லைட்ஸில் பார்த்தீங்க அப்படின்னா மேம் கேட்ட கொஸ்டின் என்ன அப்படின்னு சொல்லி பார்த்தோன்னா, ஃபார் எக்ஸாம்பிள் ஒரு சில குழந்தைகளுக்கெல்லாம் வந்து பார்த்தோன்னா வீட்டில் நல்லா பழக்குவாங்க. சரிங்களா? வெளியே வந்துட்டாங்க அப்படின்னா தே டோன்ட் லுக் அட் அதர் சைஸ். வெளியே வந்து யார்ட்டையும் கண்ணு பார்க்க மாட்டாங்க. தே டோன்ட் இன்ட்ராக்ட் வித் அதர்ஸ். பட் அம்மா சொல்லுவாங்க, வெளியே தான் சார் இவன் இப்படி இருக்கான், வீட்டுக்குள்ளே வந்தால் நார்மலாக பேசுகிறான். இது பேர் என்ன அப்படின்னா சோஷியல் கம்யூனிகேஷன் டிஸார்டர். இதை நான் எப்படி கண்டுபிடிச்சேன் அப்படின்னு சொல்லி பார்த்தேன் அப்படின்னா, சைல்ட் இஸ் நாட் ஹேவிங் ஃபிக்ஸ்டு இன்ட்ரெஸ்ட். ஆட்டிஸ்டிக் கிட்ஸ் சினாரியோஸ்லாம் பார்த்துருக்கோம், கேஸ் சினாரியோஸ்லாம் பார்த்தோம். அந்த கிட்ஸுக்கு ஃபிக்ஸ்டு இன்ட்ரெஸ்ட் இருக்கும், ரிப்பீட்டேட்டிவ் மோட்டார் மூமெண்ட்ஸ் இருக்கும், அந்த ஹேண்ட்ஸை யூஸ் பண்ணி ஃபைன் மோட்டார் மூமெண்ட்ஸ் ரிப்பீட்டேட்டிவாக இருக்கும். ஸோ இதெல்லாம் அந்த கிட்ஸில் இருக்காது. ஸோ ஆட்டிசம், டிப்பிக்கல் ஆட்டிசம் ப்ரெசென்ட் ஆகிறப்ப சோஷியல் கம்யூனிகேஷன் டிஸார்டரும் இருக்கும், ஃபிக்ஸ்டு இன்ட்ரெஸ்ட்டும் இருக்கும், ரிப்பீட்டேட்டிவ் மோட்டார் பிஹேவியர்ஸும் இருக்கும். மற்றபடி ஆட்டிஸ்டிக் லைக் ஃபீச்சர்ஸில் எப்படி இருக்கும் அப்படின்னு சொல்லி பார்த்தோன்னா, இதில் ஏதாவது ஒன்று தான் இருக்குமே தவிர எல்லாமே ஃபுல்ஃபில் ஆகாது. அதுக்கு இன்னொரு கிளியர் கட் எக்ஸாம்பிள் என்ன அப்படின்னா, நீங்கள் ஃபோன் யூஸ் பண்ணுறீங்க. சரிங்களா? ஃபோன் யூஸ் பண்ணுறப்ப குழந்தைங்க ஃபோன் யூஸ் பண்ணுறப்ப கூப்பிட்டா திரும்ப மாட்டாங்களா? திரும்ப மாட்டாங்க. ஐ டு ஐ கான்டாக்ட் வைப்பாங்களா? வைக்க மாட்டாங்க. ஃபிக்ஸ்டு இன்ட்ரெஸ்ட் இன் ஃபோன், நாட் சீயிங் ஐ டு ஐ, நாட் கம்யூனிகேட்டிங். இது பேர் என்னது? வர்ச்சுவல் ஆட்டிசம், ஆட்டிஸ்டிக் லைக் ஃபீச்சர். பட் அது ஆட்டிசம் கிடையாது. ஸோ ஹவு டு டிஃபரன்ஷியேட் இட் அப்படின்னு சொல்லி பார்த்தோன்னா, say the child is having social communication problem at every scenarios, be it home, be it school, be it at ground, be it in friends home, and the child is having fixed interest towards something, and the child is having repetitive behaviors. இது எல்லாமே fulfill ஆனதா we can label the child as autism. For example, the child is having ADHD. சரிங்களா? The child is jumping and the child is doing something again and again. That is also resembling autism. But what is missing in the child is communicating socially well. சரிங்களா? So we have to check every point is matching or not. சரிங்களா? அதுக்கு தான் நம்ம ஈஸியாக நமக்கு MChat ஸ்க்ரீனிங் சிஸ்டம்னு ஒன்று கொடுத்துருக்கோம். அதை ஓப்பன் பண்ணி 20 கொஸ்டின்ஸ் கேட்டுரும் நம்ம. Explain it. That rigid behavior will be missing and the repetitive motor movements will be missing in autistic like kids. Mostly they will be falling under the awkward social communication. So we will think them they are autistic.
So one more question. Yes, I have on MChat RF.
Yes, ma'am.
2, 5 and 12. Is it compulsory that one of that has to be an yes answer to say that they are at a risk for autism?
I'm not getting it. Okay.
Question number 2, 5 and 12.
Okay, ma'am.
Compulsorily at least one of that question.
Okay.
Does it have to be an yes?
Okay.
Or there should be a score of 1 for either of these three?
Okay. Yeah.
to come to a conclusion about the risk factor,
Okay.
or its general score of 2, I mean 0
Question
to 2.
number 2, 5,
Yeah,
12.
yeah.
Ma'am, for exclusively that question number 2, 5, 12, that MChat PDF, we are finding how it can be divided further. Since it is already creating confusion, there is a established tabular column explaining the scenarios like how it can fall, and it is அதுவே வந்து கரெக்டாக பிரித்து கொடுத்துருக்கோம். ஆக்சுவலாக இந்த மாதிரி சொன்னால் அடுத்து எப்படி ப்ரொசீட் பண்ணுறது, அந்த கொஸ்டின்ஸ்க்கு மட்டும் தனி அப்ரோச் நம்ம இருக்கோம் ஆக்சுவலாக.
Thank you, sir.
தேங்க்யூ.
Good morning, sir. I think just for the students' benefits as well, as you said about the MMR vaccination,
Yes, sir.
I think more conceptions, and even in Seattle, many people, many parents for suicidal things. So I just want to have one more doubt in that MMR vaccination, is that MMR vaccination is not the problem, as you said,
Yes, sir.
and there is no studies based on that. But the preservation of MMR vaccination on mercury, making a lead poisoning in the child,
Okay.
without following the World Health Organization's guidelines, can be a risk for having this?
It's a controversy. Generally, pediatricians don't support that actually.
Yeah.
It's a controversy. So I think it's inappropriate to assume like that actually. But as a pediatrician, I will encourage all parents to take MMR, sir, actually.
No, we support the vaccination because it's necessary, because it's a life-threatening, and MMR vaccination has to be done. The process of preserving the syringe or the MMR vaccine in the mercury instead of preserving in the refrigerator, so that might have a leakage of causing
In what, sir?
in a syringe.
Syringe. Okay.
So syringe has been kept it in the mercury to make it in the freezing point,
Okay,
rather than kept it in the freezer.
Okay,
So that makes some kind of a lead poisoning to create some brain damage. Is it true or not?
Sir, I'm not actually aware of that. I need to go and study that.
Sure,
actually.
sure.
Yes, sir.
Thank you.
Yes, ma'am. Yes, ma'am.
One more last question.
Yes, ma'am.
Since you said the cause is genetic for certain people,
Yes, ma'am.
is there a thing that by doing genetic editing, can there be a cure?
Ma'am,
Can there be a cure for autism?
that is actually ongoing research, ma'am. How to identify antenatally autism through amniotic fluid testing, through sampling, and how to introduce the gene CRISPR technology to modify those genes. Those are all under research, ma'am. Probably with the introduction of artificial intelligence in next 5 or 10 years, we'll be able to get those solutions. Right now, there is no scope for gene editing right now, ma'am. Only scope is occupational therapy, early identification, and early intervention. These 3 things are the only scope, and it is not a single specialty intervention. It is like multiple specialties should concurrently come here. Be it ENT, ophthalmologist, occupational therapist, physiotherapist, they all play these things together actually. This single man can't find solutions for a OT. That's why it is better for the kids to go to a place where every specialist are there.
Sir, I'm a speech therapist. I'm
yes,
Arya.
ma'am. Yes, ma'am.
So, as we were discussing about lead poisoning in MMR, I have come across certain cases where we are not much aware about it, but parents coming and telling us that we did a blood test for a child, and we saw he is having some levels of aluminium more in the blood.
Even I saw those reports, yeah.
Copper more in the blood.
Yeah.
And then there are certain other cases where I think most of the cases where vitamin D is literally very low than what is prescribed.
Okay.
And some parents come to us claiming that when the vitamin D levels are supplemented with some tablets or some injections, we have seen lot of the sensory issues or things vanishing. So,
Vanishing.
Yeah. So, what is your take
First
on
of
this?
all,
And as a therapist,
Okay, ma'am.
should we always refer the patients to a pediatrician or for the blood test?
Okay.
Is it mandatory
Okay.
or how can we deal this?
Okay. First thing, ma'am, autism பொறுத்த வரைக்கும் there is no need for any blood test. I can say it 100% confidently. Any blood test not needed. நீங்கள் சொன்ன மாதிரி அந்த டாக்ஸிக் எலமெண்ட்ஸோட பிளட் லெவல்ஸ்லாம் எப்படி பார்த்தாலும் எல்லாத்துக்குமே இருக்கும். பிகாஸ் we are contaminated on daily basis. பார்த்தோன்னா through the water we are drinking, through the food we are eating, we are going around through the air we are breathing. Anyhow, we are contaminated. So it doesn't mean that the body levels are correlating to the autism. Not like that. Even normal children will have traceable amounts of arsenium, aluminum, whatever toxic elements in our body because of the water, food and the soil we are living in. So it is not related to autism at all. The second point is there is no studies related to the vitamin D installation and autism, nothing like that. Universally, all infants up to the age 1 should take vitamin D supplementation because vitamin D is a very vital role in bone formation and also epithelial cell formation and immunity. And since less than 1 year kids are not exposed to the direct sunlight, which is the 90% source of the vitamin D, we are giving it supplementation till 1 year of age. Not only in India, universally all countries are following vitamin D supplementation for infants till 1 year of age. Okay, thank you.
Sir, last question.
Yes, ma'am.
Just for their identification.
Yes, sir.
About you said about the comorbidity of having a fix.
Yes, sir.
Abnormal EEG patterns.
Yes, sir.
Most of the children with autism.
Okay.
But before I think before 1999, it was actually one of the protocol to identify the children with having autism or not. But later on, it has been removed because not all abnormal EEG children will be affected with autism. But most of the children with ASD will have some form of epilepsy. So why pediatricians are not ready to send for the referral for identifying through EEG test? Because it was been mandatory, like they have to send the children for identifying it. But most of the pediatricians are not ready, even in Manipal and many places. Even I checked in Jipmer, I requested many of them. But later on, after 6 years or 7 years, even though before 4 years, they might not be identified with any abnormal EEG. EEG patterns will not be showing. But I can able to read some of the eyeball rotations and their stiffness, or if it some kind of a fixation. But we can able to see that there is some changes in their maybe sleep disturbances, which will give a cue that they have some abnormal patterns, which might not be identified in EEG test. But later, after 7 years, they've been identified as severe abnormal EEG. And even they are getting the fits later on, which has not been addressed at the earlier stages. It has missed a lot, but whether it is a myth or a real true, if it is, can be helpful.
Okay. சரி சார், நான் அது ஒரு பெரிய காம்ப்ளெக்ஸான கொஸ்டின் நான் முடிஞ்ச அளவுக்கு என்னன்னு சொல்ல பார்க்குறேன். ஃபர்ஸ்ட் வந்து எதுக்கு ஒரு கிட்டை நம்ம ஈஸியாக எபிலெப்டிக் கிட்டுன்னு லேபிள் பண்ணக்கூடாது until we confirm it. என்ன அப்படின்னா 2 டைப் ஆஃப் சீசர் இருக்குது. ஒன்று ப்ரொவோக்டு சீசர், இன்னொன்று அன்ப்ரொவோக்டு சீசர். Provoked seizure na we have some underlying cause like fever, like brain injury, electrolyte imbalances. Some underlying causes we know, meningitis. So the kid is developing seizure. So that is provoked seizure. Another category is unprovoked seizure. We couldn't identify any cause of that. So that unprovoked seizure, if it is happening again and again, then the child is maybe labeled as epilepsy. Even in the first episode of unprovoked seizure, we should not label the child as epilepsy. Why? Because if we are going to add anti-epileptic drugs like Levipil, sodium valproate, phenytoin, which carries a lot of toxicity with them, we should weigh the risk-benefit balance. If the risk is more than the benefit, better to withhold anti-epileptic drugs. If the risk is less than the benefits, it means benefits is more, then we can start anti-epileptic drugs. It's all depends upon that how the child is prone to get again epilepsy. Number 1 point. Number 2 point, all the EEGs we are doing right now, even in a normal kid, it can be abnormal. So what we should do is, we should correlate the EEG with the activity of the child. That is why we are advocating video EEG. Means even at the home or in any video EEG center, make the child to attach the wires and be there for few hours. Let's take 24 hours. Some child develop epilepsies in the night time. So whenever we note the abnormal EEG pattern, we should correlate with the motor activities and the change in the eyeball movements, as you said, change in the any motor activities. If that is matching, then the child may be epileptic child. So all we do, we should advance the investigations and நமக்கு அந்த புரிதல் இருக்கணும். The child is prone to get again another epilepsy. கண்ணை மூடிட்டு நம்ம AED ஸ்டார்ட் பண்ணலாம்.
நான் எதுக்காக அதை கேட்குறேன்னா சார், மோஸ்ட் ஆஃப் த டைம் ஐ திங்க் யூ மைட் பி செட் தேர் இஸ் அ டாக்ஸிசிட்டி இன் சோடியம் வால்ப்ரேட் ஆர் எனிதிங். பட் சோடியம் வால்ப்ரேட் சில குழந்தைங்களுக்கு நம்ம அந்த முன்னாடியே கொடுக்கும் இது. ஈவன் தோ சம்டைம்ஸ் த டாக்டர் பீடியாட்ரிஷியன்ஸ் have a doubt that the child might have a epilepsy, but the parents are not ready to go for the EEG test because they have to go through with anesthesia and other things. That procedure they want to follow it. But even giving a small amount of sodium valproate creates a lot amount of changes in their speech as well as in the social communication sometimes. But why I was insisting it, if we have not identified that priorly or not giving this anti-epileptic drugs which has a less amount of toxicity at present, I'm feeling it, rather than going for a Ritalin or Attentia or any kind of a anti-psychiatric drugs. அதை கொடுக்கறதுக்கு பதிலா இதை கொடுத்தா நம்ம நிறைய சேஞ்சஸ் பார்க்கலாம். ஏன்னா அந்த குழந்தைங்க அதுல செடியூஸ் ஆயிடுவாங்க, ரொம்பவும் அட்டாச் ஆயிடுவாங்க. அது இல்லாத நாட்கள் பேரண்ட்ஸ்க்கு ரொம்ப கஷ்டமா இருக்கும். ஸோ அதை வந்து அட்லீஸ்ட் கோயிங் ஃபார் ஆன்டிசைக்காட்ரிக் ட்ரக்ஸ் விச் இஸ் நாட் கோயிங் டு பி ரிலேட்டட் ஆர் செலேட்டட். ஸோ பெட்டர் டு கோ ஃபார் ஆன்டிஎபிலிட்டிக் விச் இஸ் வெரி ஃபியூ. ஐ திங்க் நாலு மருந்து தான் இருக்கு, கேட்டகரிஸ் தான் நிறைய இருக்கு. ஸோ அதை சொல்லலாம்ன்றது.
கண்டிப்பா சார், கண்டிப்பா சீக்கிரம் கண்டுபிடிக்கணும், சீக்கிரம் ஸ்டார்ட் பண்ணணும், அதில் எந்த டவுட்டும் இல்லை. கண்டிப்பாக அது பண்ணணும் சார்.
I have one more question.
Yes, ma'am.
It's about leucovorin, which is everybody are asking whether they can start taking leucovorin.
Okay.
So many of the parents are going for FRAC test nowadays.
Okay.
And what is your take on that? I would like to have.
As of now, it is not a proven therapy, ma'am. As of now, leucovorin is not a proven therapy actually.
Because the kids who come to us have already started taking.
Okay.
And yeah, so I just wanted to know. Have you come across any kids or have you any time seen anybody who started on that, and is it really effective or not? Because many parents do come and ask us, should we take those medicines or should we not take it?
No. Autism medical therapy is only for the concurrent conditions like epilepsy, GERD problems, psychiatric issues, sleep disorders. There is no drug which is going to directly help autism. ஏதாச்சும் கன்கரண்ட் மெடிக்கல் கண்டிஷன்ஸ் இருந்தால் அதுக்கு அந்த ட்ரக் ஹெல்ப் ஆகும். அந்த கன்கரண்ட் மெடிக்கல் கண்டிஷன்ஸ் நல்லா ஆனதுனால the child is going to behave better. அதுதாமே தவிர no drug till now proven directly useful for the autism except therapy. Therapy is the only proven treatment as of now, nothing else.
Thank you, sir.
Okay.
We thank Dr. Raghuram Saminathan sir for his valuable insights. I request Dr. K. Naresh Babu sir to present the memento as token of love. I request Dr. K. Naresh Babu sir to present the memento as token of love. Begin in 5 minutes. The students are requested to. Inaugural function will. Students are in decorum until then.
Along but I request everyone to raise for
நீராலும் கடலொடுத்த நிலமடர்ந்த கெழிலொழுகும் சீராரும் வதனமென திகழ்பர தெக்கணமும் அதிசிறந்த திராவிடன திருநாடும் தக்க சிறு பெருநுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல உலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனகே தமிழனகே உன் சீரிழமை திறமே எந்த செயல் வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
Please be seated.
Light has always been a symbol of knowledge, which signifies the removal of darkness and beginning of a path guided by understanding. I now request a forward and lighting the lamp.
Will the respect for all the people who are gathering here, and thankful for everybody to reaching to this national level seminar. I would like to have this chief patron, our chairman sir, Dr. Periyaswamy sir, and our directors who have contributed this and who have guided us to this particular national level seminar. So I'd like to introduce our chairman, Dr. Giving a great applause for him. Our board of directors, Dr. SenthilKumar sir, and our director, Dr. P. Balamurugan sir, and all the speakers, guest speakers, we are welcoming them to accept our invitation and giving an expert lecture. I think you have witnessed our Dr. Raghuram sir's speech very well. I think we are going to have other speakers as well as their expertise. Thank you.
Light has always been a symbol of knowledge, wisdom, and hope. It signifies as the removal of darkness and beginning of a path guided by understanding. I now request dignitaries to kindly come forward and grace this occasion by lighting the lamp.
The dignitaries are requested to be seated in the dais. The dignitaries are requested to be seated in the dais. I request Dr. Vishnu, Executive Member of TN IOTA, to please come to the dais. I request Dr. Ilavanjagan sir to please join us in the dais. I request Dr. SenthilKumar sir, Principal of Sree Devi College of Occupational Therapy, to join us in the dais.
The beauty of a gathering lies in the warmth with which it begins. I now invite our esteemed principal, Dr. K. Naresh Babu sir, to deliver the welcome address.
Good morning to all. It was a great pleasure to meet you all with the students as well as other colleges students from KMCH, PPG College, Venkateshwara College, as well as our nearby colleges who have supported us, and I think many professionals from Mail Parvati sir, Muthuraman sir, and many have reached to us for this great conference. It is our distinguished Chief Patron, Dr. P. Periyaswamy sir, our Chairman Sree Abirami Institutions, and our directors, Dr. SenthilKumar sir, Dr. Balamurugan sir, Dr. Sucharitha ma'am, Dr. Umadevi ma'am, and all has guided us to do this national level seminar for autism awareness. Our purpose, actually we are gathered here today for the Autism Month 2026, celebrating differences national level seminar. Our mission at Sree Abirami College of Occupational Therapy is to bridge interdisciplinary perspectives, including pediatrics, psychiatry, occupational therapy, and speech-language pathology, to provide comprehensive support for children and individuals on the autism spectrum disorder. Today's program is packed with value in addition to our core CME program, which is simultaneously happening. The lectures covering topics from early identification to emerging therapeutic areas. We are also hosting a scientific paper presentation and e-poster presentations. This academic initiatives provides a platform for interns, PG students, and professionals to share their research, fostering a spirit of inquiry and innovation in line with our seminar's theme. So this program is more than just a series of lectures. It is a commitment to believe that every life has a value. I have encouraged each of you to engage deeply with our speakers and participate actively in both the CME sessions and the scientific presentations. Thank you for being part of this important journey, and I'm very grateful for our management to happen this a wonderful event. Thank you.
Thank you, sir. The greatest leader is not necessarily the one who does the greatest things. He is the one that gets the people to do the greatest things. It is my privilege to welcome our chairman, Dr. P. Periyaswamy sir, to deliver the presidential address.
Good morning to our distinguished guests, expert speakers, dedicated faculty members, enthusiastic students, and all the delegates joining us here today at Sree Abirami College of Occupational Therapy. It's my profound privilege to welcome you all to our national level seminar, Autism and Humanity, Every Life Has Value. As we observe Autism Month, this gathering is not merely a professional obligation. It is a testament to our institution, unwavering commitment to fostering a society where neurodiversity is celebrated, not just tolerated. Today we have brought together a remarkable assembly of minds from pediatrics and psychiatry to speech, language, pathology, and occupational therapy to bridge the critical gaps in our interdisciplinary care models. As healthcare professionals, our mission is clear. We must move beyond diagnosis towards holistic, human-centric support that empowers every individual on the autism spectrum to lead a life of dignity and purpose. Throughout this seminar, we will explore the latest clinical advancements, emerging therapeutic areas, and the essential role of government support schemes. I encourage each of you to approach today's sessions with an open mind to challenge existing problems and to collaborate across disciplines. I extend my heartfelt gratitude to our organizing committee led by Dr. Naresh Babu, Mr. John Sagaran for their tireless efforts in assembling such a comprehensive program. Most importantly, I thank all of you for being here. Your dedication is the catalyst for the change we wish to see in our communities. With that, I am honored to officially inaugurate the national level seminar on autism and humanity. Every life has value. May today be a day of inspiration, learning, and meaningful connection. Thank you.
Thank you, sir. True leadership inspires changes, empowers people, and leaves a lasting impact. It is my honor to invite our esteemed director, Dr. SenthilKumar sir, to deliver the special address.
Can you switch this on? Am I audible? Yeah? Can you switch on this mic? Yeah. Is this okay? No, I don't think the mic is. Hello?
Hello.
Which one is on? This one or? Good morning one and all. இந்த கான்ஃபரன்ஸ்ல எது தெரியுமா ரொம்ப போர் அடிக்கிறது? இந்த இனாகுரேஷன் தான் இல்ல? எல்லாரும் உட்கார்ந்துட்டு இருப்பாங்க, எல்லாரும் பேசிட்டு இருப்பாங்க, கான்ஃபரன்ஸ் அட்டெண்ட் பண்றது விட்டுட்டு இதெல்லாம் கேட்கணும். This again is காலையில் எந்திரிச்சு எப்படி நம்ம routine பண்றோம், சாமி கும்பிடுறோம், அந்த மாதிரி this is customary. We should invoke the God. We should all come together. First of all, I'd like to thank all the speakers who had come here with their experience to share about the views on autism. This is really good, a very great conference which has been organized by our principal, Dr. Naresh Babu and his team. More than the principal, he is the board of studies also for the entire Tamil Nadu MGR University. I think this program has been organized well right from the birth. Usually, autism, almost they say it is 1 in 100 children have autism. Occupational therapy, it is one of the bouncing, it is leaping forward like anything. And the profession, around 50 to 60% is child development, autism related, ADHD, all these things come into picture. Idhila pathana, like right from birth, in the talk I was just impressed, right from birth ஆனதுக்கு அப்புறம் இனிஷியலா ஒன்றும் ப்ராப்ளம் ஒன்று இருக்காது. 1 or 2 years the child does not have any contact, then slowly parents wake up, they show the pediatrician, they have their own set of assessment which has been, I think, dealt very well with by Dr. Raghuram. He's our full-time pediatrician. Like Madam Sonanga, Dr. Sucharitha Sonanga, Dr. Raghuram had spoken very well. Thank you. I think he cleared a lot of doubts for Madam Sonanga. Like this conference or this thing, it should not be a one-way monotonous talk. முடிஞ்ச வரைக்கும் டவுட்ஸ் கேளுங்க. டவுட்ஸ் கேட்டிங்கன்னா தான் இது இல்லை சும்மாவே உட்காந்துட்டு அப்படியே இது பண்ணிட்டு போயிட்டோம்னா, if there are no doubts, either you have understood everything or else what is the other one? I don't think you go in that other pathway. So அதே மாதிரி மற்ற இதுவும் next they come to the school பத்தி Dr. Sucharitha, she is one of the senior most faculty over the entire Tamil Nadu, I believe. Yes, madam. Madam has become a Coimbatore itself. When did you come to Coimbatore, madam? 95. It's almost 35 years. So she knows the place in and out. She is a very good friend of ours. So she is talking about the school, how the child develops in the school and what are the problems that are facing. Like that, all the speakers, Dr. Jagdish Tangraj, Dr. Vincent Dr. Abhisha, Mrs. Arya, everybody has played their role. It is a clearly ஒரு நல்ல ஒரு முடிஞ்ச வரைக்கும் நீங்க இதை வந்து யூஸ் பண்ணிக்கணும். Ask lot of questions. அப்பதான் you will get answers. I thank all the colleges, Venkateshwara, Revati, எல்லா காலேஜஸும் வந்திருக்கீங்க. எல்லாருமே you get the most out of it. எல்லாமே இப்போ teaching, see the conferences or the places where you get recent thoughts. The books, publications, all those things are always around 10 or 15, maybe around 5 to 6 years old. On the last concepts, they get peer reviewed, they go through publications. Adukapram varumbodhu it is already 5 or 6 years old. Whereas conferences, the real advances are being discussed. I would like all the students, initially first year, second year, initially it will be little tough talking about the subject from morning till evening. That sometimes it is tough, but please go through this, ask a lot of questions, then only you get points. It will be useful not only for your exam preparation, because most of the things will be applicable in your life. So I would like to congratulate all the faculty who have organized this, and I would also like to thank all the faculty who have come forward to deliver the speeches. Thank you once again. Have a very good day. Thank you.
Thank you, sir. Visionary leadership creates paths of progress and purpose. I request Dr. Balamurugan, sir, to deliver the felicitation address.
Good morning, all. அன்பில்லார் எல்லாம் தமக்குரியர் அன்புடையர் என்பும் உரியர் பிறர்க்கு அனைவருக்கும் எனது அன்பான வணக்கங்கள். Respected chief guest, distinguished speakers and esteemed dignitaries, beloved faculty members and dear students and all gathered here. A very warm and heartfelt good morning to everyone. So every life has its value, and grateful on this meaningful occasion of national level seminar on autism and humanity, which is organized as part of the Autism Acceptance Month. ஒவ்வொரு உயிரும் மதிப்பு மிக்கது. This powerful theme reminds us that every individual deserves dignity, acceptance and equal opportunity. Autism is not merely a condition, it is to be understood. It is a unique way of experiencing the world. வித்தியாசம் குறையல்ல, அது ஒரு தனித்திறன். I would like to extend my heartfelt appreciation to our esteemed speakers for gracing this occasion by your presence, which adds immense value and inspiration to this platform. I also sincerely congratulate the organizing team of Sree Abirami College of Occupational Therapy for their dedication and commitment in organizing such a meaningful seminar. To all the participants, கற்றது கைமண் அளவு கல்லாத உலகளவு என்பதை மனதில் கொண்டு இன்று என்ன முடியுமோ மேக்ஸிமம் லேர்ன் பண்ணுங்க. We reflect the today's theme, ஒற்றுமையில் பலம், இணைப்பில் மனிதம். Let us move forward with empathy, inclusion and strong commitment to making a difference in the lives of individuals with autism. Once again, I extend my warm regards to everyone present here, and with this seminar a grand success. And not only this is a seminar, there is also a paper presentation and poster presentation for the students happening. That's a good thing that we have started. I wish you all a great day today. Thank you.
Thank you, sir. Now, I request our respected principal, Dr. K. Naresh Babu, sir, to felicitate Dr. P. Periyaswamy, sir, with a shawl as a token of love.
I request our respected principal, Dr. K. Naresh Babu, sir, to felicitate Dr. SenthilKumar, sir, with this shawl as a token of love.
I request our respected principal, Dr. K. Naresh Babu, sir, to felicitate Dr. Balamurugan, sir, with a shawl as a token of love.
I request our respected Chairman, Dr. P. Periyaswamy, sir, to felicitate Dr. Sucharitha ma'am with the bouquet as a token of love.
I request our respected Dr. Periyaswamy, sir, to felicitate Dr. Jagadish Thangarajan, sir, with a bouquet and shawl as a token of love. I request our respected Dr. SenthilKumar, sir, to felicitate Dr. Raghuram Saminathan, sir, with a bouquet and shawl as a token of love. I request our respected Dr. SenthilKumar, sir, to felicitate Dr. Vincent Jairaj, sir, with a bouquet and a token of love. I request our respected Dr. Balamurugan sir to felicitate Dr. Abibsha Bishwal ma'am with a bouquet and shawl as a token of love.
I request our respected Dr. Balamurugan sir to felicitate Mrs. Sree SenthilKumar ma'am with the bouquet and shawl as a token of love.
I request our respected Balamurugan sir I request our respected Balamurugan sir to felicitate Dr. L. Vishnu sir, Executive Member of TN IOTA with a shawl as a token of love. I request the dignitaries to be present for a group photo session.
We will now take a short tea break to refresh ourselves. I request everyone to kindly proceed for tea and reassemble here shortly for the next session. Thank you, dignitaries. Students, please be seated. We will now take a short tea break to refresh ourselves. I request everyone to kindly proceed for tea and reassemble here shortly for the next section in 10 minutes.
ஹலோ கேக்குதா? ஹலோ ஓகே.
Hello. Hello, check. Hello.
Hello?
Hello, check.
Hello, hello.
Hello. Hello, check.
Hello. Hello. Hello.
Hello, check, check, കേക്കുണ്ടോ? Hello, mic check, mic check. Hello. 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 Huh? സുബാന സുബൈദ കേൾക്കുന്നുണ്ടോ?
Hello, check. Hello, check.
Hello, check. அப்படியா?
The session will begin shortly. All students are requested to assemble in the auditorium. The session will begin shortly. All delegates are requested to assemble again in the auditorium. The session will begin shortly. All delegates are requested to assemble the auditorium. The next session will begin shortly. All delegates are requested to assemble in the auditorium. I repeat, the next session will begin shortly. All delegates are requested to assemble in the auditorium. Next session will begin shortly. All delegates are requested to assemble in the auditorium. I repeat, our next session will start shortly. All delegates are requested to assemble in the auditorium.
It is said that education is a key to a child's life, but for many, it is the occupational therapist who unlocks the door. Dr. Sujata Michelle, BOT, MSc OT, PhD in OT. She is a true pillar of the occupational therapy community. Her leadership at KMCH and her devotion to helping children transition into the school world is nothing short of inspiring. Please join me in showing our deep appreciation for esteemed speaker. The stage is all yours, ma'am.
Good morning to all of you. I'm sure you had a good refreshment. Am I audible backside? Yes or no? Am I audible? Can you please raise your hand? Okay. Backside. Okay. First of all, I would like to thank the chairman of Abirami College as well as the directors as well as Dr. Naresh for giving me this opportunity. And it's really a good arrangement that they have made. I can see a lot of participants today here. Nice that, and congratulations also to the scientific committee as well as other committee members who have made such good arrangements for today's conference. And today I'm going to take on the topic. Next slide, please. My topic is importance of school readiness in children with autism spectrum disorder. Now, why this is so important is as occupational therapists, when we work with children, in my day-to-day practice, what is most of the parents, the first question after they know that the child has autism, the first question is, can my child go to a normal school or not? Every parent will ask that. I don't know how many practitioners are there. They would definitely agree with me. This will be the first question. Next question. First is, will my child become okay or not? Will he become normal or not? Second question that comes always is, can my child go to a normal school? That is a very common question that comes. And this I have been hearing past many years. And that is why I thought I should take it up as an topic for my PhD research also. So I developed also a tool which is called as the School Readiness Inventory for Preschoolers with Autism Spectrum Disorder. And I will tell you also briefly about that tool also today. So coming, next slide please. So next slide. Coming to the prevalence, if we see previously. Coming to the prevalence, if we see, in Western countries it is 1:36 nowadays. And in India, the estimate is 1:68. And the studies in 2023, they found it is 1:36. And in India, 2020 study says 1:68. That means approximately 1% to 1.5. It can vary from 1:68 to 1:100 also.
So 1 to 1.5% of the children, among the children are affected with autism spectrum disorder. So day by day we see it is increasing, and why the increase is coming is because of lot of awareness among the parents, as well as maybe people start knowing why isn't my child talking, why is he not looking at my face. This is the first thing the parents start noticing. So that is why it has increased. But when we compare to the Western countries, ours is still less, because in spite of some people, that means persons from the higher socioeconomic status are more aware, they come to us at the most earliest phase, whereas other people, there is still a stigma and they don't want to come to the doctors and find out whether the child has autism or not. So that is why still in India we have not come to that. Maybe some cases are undiagnosed, but globally if we see, it has come to 1 in 36, which is a high rate of prevalence of autism. And male-female ratio, we already know there is a 4:1. Some studies say also nowadays it is 3:1. Next. So coming to what is school readiness? School readiness is any developmental skill that the child should have, as well as other than the developmental skill, there are other skills that the child should have to be able to enter into a school and study appropriately without any problems. Okay, so as per the definition given by National Education Goals Panel in 1995, as well as No et al. In 2006, it says that school readiness refers to a child's capacity across developmental domains, that is your cognitive skills, social emotional skills, communicative skills, adaptive behavior, motor skills, which enable successful participation in a formal educational setting. Okay, and it involves three things. One is it is multidimensional. Why we say it is multidimensional? Because it involves all your developmental areas of functioning, and then it is transactional. That is that there should be a transaction between the child, a child being ready for school. For a child to be ready for school, a school has to be ready to take in the child. Okay, the family or the community also has to be ready to take a child for schooling. So that is why it's called as a transaction between the child and the school, between the school and the family members, or between the school as well as the community or other people in the community. Okay, and then it is also contextual. We say it is contextual because culturally mediated. When we see for rural areas, the schooling pattern, the way they are taught, everything may be different. But when you come to the urban setup, that way of teaching or whatever is taught may be different. So that is why we say it is culturally mediated, and expectation differs also when it is Indian context as well as Western context. Next, please. So according to UNICEF, in 2012, UNICEF has given a conceptual framework about school readiness. They say that it is based on 2 dimensions primarily, or 2 characteristic features which rely on 3 dimensions. The 2 dimensions are transition and gaining competencies, and the 3 dimensions are child's readiness for school, school's readiness for the child, and family and community's readiness for school. Okay, so OTs are therapists who operationalize the readiness in children based on the capacity of the child. So when we do an assessment, we get to know what are the capacity the child has in different areas of functioning, that is his cognitive ability, his motor skills, are they sufficient enough to go, conduct himself or herself in a school in an appropriate manner. That means he's sitting appropriately. Can he use a pencil? Can he open a tiffin box? Can he use a water bottle, etc. So all these are the motor skills that are required for school readiness. So an OT does a basic capacity testing for the child, and then he finds or she finds whether it fits in that capacity which the child has or ability which the child has. Can he or she fulfill his or her own occupational roles? What are the occupational roles of a child? Can anyone tell me what is the occupational role? Yes? Playing is one. Anything else? Learning is one of the occupational roles. Okay? And also engaging and socializing with peer group. Okay? So these are some of the occupational roles that they have. So OTs do this assessment to find out whether he has the capacity or he has the ability or the skills required to perform the occupational roles. Next. So the concept of school readiness, as I told, was given by UNICEF in 2012, and it includes 4 things. One is child readiness, second is school readiness for children, third is family readiness, fourth is community readiness. Next. So the National Education Goals Panel, they also determined that school readiness includes a wide range of developmental skill and in addition to it, academic skills. Always all of us think that only when we say school readiness, it's only the academic part. Does a child have concept of numbers, color, shape, size, etc.? That's not only the concept also includes whether the child can socialize with others, whether the child can play with others, does he have appropriate social, emotional skills? Those are very, very important also in addition to the academic skills or concept that the child has. So the 5 areas or dimensions that NEGP has told about is, one is physical well-being and development, second one is social emotional development, third one is approaches to learning. Approaches to learning is, does the child have enthusiasm to learn, to listen to ask questions, to participate in a classroom activity? So how is it approach to the learning? Does the child ask questions? Does the child ask doubts? So that is what is meant by the approach to learning. Language development, that is receptive and expressive communication, and cognitive and general knowledge, which is the basic concept a child should have before going to the school. Next. So why school readiness is very, very important? 2 main reasons is, one is transition vulnerability. It is very, very difficult even for neurotypical children when they are at home and suddenly you put them in a play group. They start crying, they cannot adapt themselves to the environment very easily. But similarly, how much more will it be for a child with autism? It is much more because they have a lot of challenges. The challenges would be the sensory issues primarily, okay, not adapting to a new environment, finding it very difficult, because sir already explained you about previous session, he was telling you about their repetitive rigid behaviors or their fixed interest. Because of this, because of sensory issues also, the child cannot transition himself or herself from an home environment to a school environment very easily. So even though a neurotypical child has issues, but more than that, a child with autism problem can have issues in transition. Next thing is academic outcomes. Basically, these children have poor school readiness because what happens is, as we know that their brain function does not take place normally like other children, so they learn very poorly, and because they are not learning the concepts or they do not know, say for example, a 2-year-old child should know what is the difference between big and small, or he should also know what is more or less. But if a child who has autism has not learned all these things and goes to a school directly, he will have difficulty in grasping and learning. There may be a gap in his learning abilities. Okay? So a child who is neurotypical 2-year-old child will do much better than a child who has autism spectrum. Next please. Can I have some water? So why school readiness is important? One is, thank you. One is, it is a foundation for lifelong learning. So it is said by authors or by certain people who have done research, they have found that a child who is ready to enter school does much better later on in his academic performance. So unless and until we prepare a child with autism to be competent enough with neurotypical children, definitely they will find it very difficult when they start going into higher classes. So that is why it is said, being a child who enters school with adequate school readiness demonstrates better long-term academic and social outcome. Second thing is, it helps to reduce challenging behaviors. Because what happens is, if they are already prepared and if they are knowing that they have to enter into a play group or they have to go to a kindergarten, if the child is already mentally prepared, then he transitions himself very easily and he may not have meltdowns. He may not have other behavioral issues because of the sensory problems that they have. So it is very important in helping to reduce the challenging behaviors. Next is supports inclusion. According to the Persons with Disability Act 2016, it says that it is mandated for all children with special needs to be educated in a mainstream school. But this is never being followed. Most of the parents who come to us, they say, I went to this school, that school, and they say no, they keep a child for maybe 6 months. After 6 months, they come and tell, no, it's not possible for us to manage your child, you can take him elsewhere. And I have come across so many parents who come back to me and tell, what will I do next? Which school should I choose for my child? Should I go for a special school or can I go for a mainstream school? Very commonly they come up with these kind of issues. So to support inclusion, it is very essential that we do a school readiness assessment so that the parent or the school is aware what level the child is at school readiness, and then we can advocate for the child and the parent saying he has adequate skills, but he may need little bit of help. The help could be in terms of maybe somebody guiding the child. Some other child can become a co-mate with the child and help him during the classes to take out his book or to take out his color box, which he may not understand all the instructions, but the child has adequate cognitive skills. When the child has adequate cognitive skills, he or she should not be refused to enter a school. Okay? And next is how do OTs, what is our role justification? Because we are already people who work or we have learned in our education field about the normal developmental patterns, etc. We know what is abnormal, what is not normal, what is normal. So we are the right judges who can make an assessment and identify the deficit areas and start training the child at a very early age. Next, please. So what are the core domains in school readiness? One is, as I already mentioned, cognition and pre-academic skills, communication, sensory motor aspects, social emotional aspects, and adaptive behavior aspects. Adaptive behavior aspects, when I talk here about school readiness, is very, very related to the school part I'm telling about. Now when I say it is school part, it is like the child will have to learn how to maybe open a tiffin box, remove a bottle cap. This may be very, very difficult for a child with autism. Why? Because they may have certain praxis disorders, or they may have problem because of sensory issues, where they do not know how much of pressure I should apply to open the bottle cap or to open the tiffin box. Okay, so because of these also they can have problems in adaptive behavior, or they have not learned how to undress self and use the toilet. So then they require help for all these things. So these kind of school-related adaptive behavior may be effective for the child. Next. So there are a lot of school readiness assessment scales which are already developed in the Western countries. But if you see, most of them are for typically developing children rather than children with autism spectrum disorder. Even if they have developed some for children with special needs, it has been developed more for other kind of disabilities. And that is, I would say, intellectual disability or learning disability population, ADHD kids, they have developed those for those children. Very less scales have been developed for children with autism spectrum disorder. So if you can see, Bracken School Readiness Assessment, it is a Western scale. It only assesses the academic skills. It does not assess the other areas of school readiness, which was highlighted by the National Education Goals Panel. Okay, there were five areas or domains of school readiness, and it does not cover all the 5 domains. It only covers one part, that is a cognitive and general knowledge. Okay, so and as well as Bracken School is not used for ASD, it is only used for neurotypical children. The next scale, if you see, PEP 3, I'm not telling about all the scales. PEP 3 is a psychoeducation profile. It is again a Western population for, developed for Western population. Here again they see cognitive, verbal, adaptive behavior, maladaptive behaviors. But they are not assessing gross motor, fine motor skills, which is very, very essential. They are not assessing the social emotional part also, which is very essential in for school readiness. So that is missing. And yes, it is definitely designed for ASD, but it is having missing components like these areas which I have mentioned. Next slide, please. So there are a few more scales which I can mention here. School readiness inventory, kindergarten readiness inventory. It has 5 subscales. That was also developed in USA. Abel's R, it was also developed in USA. Then school readiness module. This is one scale which is developed in India, and one scale which I showed you first, which is the Sree scale, school readiness inventory for preschoolers. These are the 2 school readiness scales which are developed in India as of now till date. That was developed in 2022 by Sujita Mukri from Pondicherry University, and mine was developed by 2018-19 I developed, but I have published it in 2024. Next. Next, please. Before this one. Next. Okay, so I'll just tell briefly about my scale, which is called as School Readiness Inventory for Preschoolers with Autism Spectrum Disorder. This I have developed it for children between 3 to 6. Basically, are the kids ready to enter kindergarten? Okay, for that purpose only it is developed. So, because most of the kids that come to us get diagnosed only by the age of 3. We don't give them a formal diagnosis before the age of 3 unless and until we administer ADOS. ADOS, not everybody of us are trained in India. Very few people are trained in ADOS to diagnose a child before 2 years of age. Inclin diagnostic tool is also there which diagnoses a child before 2 years of age, but they are all not still aligning with DSM-5 criteria. Okay, so the basic idea was, can the child enter into a kindergarten school? Keeping that in mind, I took children between 3 to 6 years, developed the tool, did content validity, everything the tool consists of totally 93 items. Okay, in this 93 items, we have developed the norms for 310 children with autism spectrum disorder, and we have done the comparison with 100 neurotypical children, which were also from the kindergarten. So then we have developed the cutoff scores based on that. Next. So these are the areas which I have taken. One item from here is missing. According to National Education Goals Panel, approach to learning is missing. I have not used approach to learning because most of the kids in this age group find it difficult to communicate regarding approach to learning. When I say approach to learning, it is, as I said, asking questions, asking doubts, clearing facts, etc. This is the children with autism spectrum disorder who are of this age group have difficulty unless and until they are very high functioning kids. Okay, then only they do this question answering in the classroom or other means of approach to learning they will have. But kids who are with this age group, they do not have that skill. That is why I have not included that. Except that I have included cognition, which includes 3 subdomains, language, which includes 2 subdomains, social emotional skills is just one component and a domain by itself, but it has certain areas of self-awareness, emotional regulation, independence in classroom, which I have assessed for them. Physical development and motor skills, wherein I have included gross motor, fine motor, and self-care skills related to school. Next, please. And the cutoff score for this scale is not ready if the child scores 0 to 325. It is a raw score, and if the child is scoring 0 to 325, that means the total score for this particular scale is 465. 0 is the least, 465 is the highest score that a child can score, and we are scoring it from 0 to 5. Each item is scored from 0 to 5, but for each domain the 0 to 5 would vary based on what component is being assessed. 0 means the child does not have the skill at all. 5 is the child can do the skill appropriately and also can generalize the skill to other contextual areas or other contexts. Then it is given a score of 5, which is a maximum score. Okay? So when a child gets a score of 0 to 325, we say the child is not ready, and 326 to 378, child is ready with assistance. The assistance could be in terms of the class teacher helping, or if the school allows the parent helping, it could be also a shadow accompanying the child. It could be verbal prompts or physical prompts also. This kind of assistance is included in this. And ready means 379 to 465. And it is a tool which is norm reference. That means we have compared with normal kids and then found out the score. And another thing what I want to say here is it's both an observational as well as parent reported tool, because every skill the child will not demonstrate in front of us in one sitting. So certain things we have to ask the parents whether the child has that skill or not. Maybe the child is adapted to you, he may cooperate. If he is new to you, he will not cooperate for all the tasks. Okay? And this scale has a manual also. The manual describes how do you administer the test and how do you score the test. For each component, it is described what tools you should be using and how do you administer it. It has a manual also. Next, please. So these are some of the components of attention and memory, like shows, actions, or sings songs or at least one or two rhymes, repeats forward sentences, recalls or shows through gestures one or two elements of a story, repeat sequence. Next. For general knowledge, identifies round and square, identifies pictures of common fruits. So it goes on from level of simple task to complexity. Okay. The last would be like handling book, holding a book or upside down or beginning to end, and he turn the pages, ability to understand that he is holding the book in the right manner. Next, please. In maths, again, understands concept of more and less, identifies 1 to 10, counts 1 to 5. These are the things. Next, please. Next. Expressive skills, names most of the pictures which are familiar, objects, identifies or requests permission, says please, or points to the object, speaks in complete sentences most of the time, or uses the word because, myself. Again, these are sometimes, you can only find this in high functioning kids, not in the low functioning kids. Okay, next please. Receptive skills like answers appropriately to why questions, whose questions, understands and follows commands of 2 steps. Next, please. Next. Social emotional skills. Is the child able to identify himself as a boy or a girl, and he knows his own name, parents' name, plays simple games with other children with supervision initially, and later on maybe without supervision. Is the child able to make his needs known to another person, and does he use terminologies like thank you, please, etc. So all these come under the social emotional skills. Can he identify special friends? In terms of, if I ask who's your best friend, some children are able to. Those who are verbal, they would be able to answer. Those who are non-verbal, maybe they point to the picture. If there is a picture of their friends, if the parent is having, we can ask. Or we can also ask the parent, does he or she at any time tell who is his best friend? Next, please. Fine motor skills like stringing beads, using pencil and crayons, how the child does it. Copies figures such as a circle, traces on alphabets, numbers, etc. Gross motor, running, jumping off floor, etc. Next, please. I have not put here on self-care skills related to school. Self-care skills related to school would be, is the child able to go to the restroom by himself or herself? Can the child undress himself? Can the child flush a toilet? Can he seat himself in the toilet seat? So these are some of the components other than eating, drinking, using a spoon. If the child doesn't, he has a lot of sensory issues, can he use a spoon to eat by himself, etc. So these are some of the school-related self-care activities which are also evaluated. Next, please. Sorry. Previous slide. So coming to OT intervention framework, when we do an assessment based on the tools that I have mentioned, we'll come to find out where the deficit area is. The child can have a deficit in the cognitive function, he can have a deficit in the gross motor or fine motor, or self-care related to ADL skills. The child can have a problem either in expressive or receptive skills, or he may have issues in social emotional skills. Once we identify these problems, we have to plan and set up the goals. And once the goals are set up, we decide on which kind of framework to use. Now, when it comes to autism, we cannot go directly to school readiness training program for the children, because they have other comorbid issues also. Like as I said, stereotypical behaviors would be very high. The child will have also sensory issues. The child may not be responding to name call. The child will not be maintaining eye contact. He or she may not even know who I am or what. So first of all, we have to do a general occupational therapy intervention, which includes all these frameworks, and then only we go for the specific school-related things. So our first aim is to do assessment using the scales, whatever is applicable for that particular child. Okay. If your school readiness tool that you are using does not have all the components, you can use other tools. Like for gross motor skill, we can use BOTMP, or we can generally do our conventional gross motor skill assessment that we do in our regular clinic, or day-to-day clinical assessment that we do. Or we can use the sensory profiles also. Like we use the most easiest is the short sensory profile to find out whether the child has sensory issues or not. So other than the school readiness part, we also have to do additionally all these things. Then after that, planning, intervention, and then work on transition. So once we give a school readiness intervention for the child, we we start working with the parent, with the family members, how to transition the child from home to the new school that the child has to enter. Next, please. So what are the frames of reference that we use? We already know that we have to use sensory integration if they have sensory issues, okay, or if the child is again very hyperactive, is not paying attention, he's not responding to name call. We work on sensory integration framework to develop all these skills for the child initially. Then we may use NDT frame of reference if the child is having very, very low tones. Most of the children with ASD, if you find, they will have low tone, very low tone. In those cases also we can use neurodevelopmental frame of reference. We can use developmental or biomechanical frame of reference for children. And some children, if you see, they have TA tightness also. In that case, we have to work on maybe a stretching program, which can be an active as well as a passive stretching program for them, or we may have to give again AFOs, etc. Those kind of things can be given. Sometimes I also use what is kinesiotaping for children. If they have a lot of TA tightness, it works out. If the child does not have tactile hypersensitivity on the sole of the foot, then I can do a taping also to reduce the TA tightness for the children. Then MOHO can be applied again for the children to get them into a particular routine, day-to-day routine, because most of some kids love to follow a routine, whereas some kids do not like a routine, they are very rigid. Those kind of children who are very rigid, we can use a activity schedule for them, and we can use a particular task. If we schedule it for them properly, these children are very good in following the schedule also. And then person, environment, occupation model can also be used, because the child has to work in an environment or a context which is the school, the family, play area, etc. Okay, so person, environment, occupation model. The occupation is, as I said, play, studies, and again sleep is also part of the occupation. Doing his school work is a part of the occupation of the child. So there should be an interaction between all these three to bring about a change in the child. Next, please. So coming to, as I already said, we should do a core therapy first, tackling the sensory issues. Next. Next. Then other techniques like fine motor and handwriting skills. If it is a preschool child, we start working at writing skills rather than going directly for handwriting. If the child has already come to the UKG, then we can start working even with the handwriting. Okay, so we start working with pre-writing skills as we do it for other kids. Even in ASD, we start working in the similar manner. Maybe the number of repetitions would be more number of repetitions. We have to again consider about the sensory issues. We also have to consider about the biomechanical issues that the child has in gripping the crayon or the pencil. Correcting those issues also for the children, that will also be required. So before that, we build up the prerequisite skills, which is proximal joint strengthening. We work on hand functions, we work on tripod pinch, we work on pulp to pulp, tip to tip, etc. So working on all the fine motor skills, and then we start with pre-writing, tracing, dot joining, coloring, etc. All these are taught to the children. Next, visual supports and stories. Visual supports and stories are very, very important for children with autism, especially when they are not verbal and they cannot understand your instructions very well. Then if visually everything is shown to them, then it is good. So we collaborate with the class, with the school, asking them to put up a timetable in a picture format. Okay, or with the mother to explain the child what he or she is supposed to do throughout the day. What time the child wakes up, what time the child will, after waking up, what the child is supposed to do. After going to the restroom, suppose a picture of the restroom can be shown. Next, after restroom picture, there can be a picture of a brush where the child understands, after finishing my restroom task, I go for brushing my teeth. Next would be a picture of the bathroom. So like this, we work with the parent also to formulate a visual schedule for the child. So it becomes easy for the child to understand what task I will do at home and what task I am supposed to do in the class. Okay, so visual supports, then aerial training. Aerial training again is started first at home so that it can be generalized into the school activities. And social skills group. Social skills group, here we work more on the joint attention first with the child. So why do we not need to work with joint attention? Because when a child goes to a school, he has to communicate with another person at least. So initially to start with, we would tell a parent that sit at 2 feet distance from the child and just pass ball, call out to the name of the child. Just 1 feet or 2 feet different distance. Or show the most favorite toy of the child very close to your face. So the child looks at your face and then wait for the child to look and then pass the ball. And once the child only looks at you, responds to your name call, you pass it on to him. So within a 1 feet distance or maximum of 2 feet distance, if you start interacting and playing with the child in this manner, the child will have a good joint attention. Another way to develop a joint attention is, or eye contact is, just putting the child on the bed and tell the mother or the father, tickling the child. That's a very good response. Many of the children are very hypersensitive. So immediately they start looking at the face. In the therapy sessions, what we have observed is, when we put the child into a neutral warm and then start interacting, talking, singing a rhyme to the child, what happens is the child starts focusing better and you have a good eye contact with the child and the child looks at your face much better at that particular time. Some children do not like neutral warm. So if they don't like it, please don't force them. But if the child is ready for it, you can use that. Otherwise, you can use other methods to develop the joint attention skills for the children. So when we see social skills, we conduct groups in our department especially to bring about a social behavior among the children. So I will show you 1 or 2 videos regarding that. Next, please. So this is the video. Click panningana varum nenikiren. So this is again, we are just giving brain gym activity. The child is not able to do it. So this would help for coordination, bilateral integration. It will definitely help. It will also help the child to follow instructions, praxis, because he's copying what the therapist is doing. Okay. So this we can start even for children with ASD if they are able to follow our instructions to a minimal extent. If not, also you can start holding the hand of the child and telling to start tapping on the knee by guiding the child. Initially, we start with demonstration and guidance, and later on, once the child learns, we can start weaning off our guidance and demonstration from the child. Next one. This child again is going through a cross-motor training, wherein we have increased the complexity. Initially, when he started, he was just asked to walk without holding an object. Later on, we asked him to hold an object so that he could do this task. He was not stepping or going one after the other in the thing. So we started this. This also helped him to improve his skill of attention span, following instructions. So that way this task would help the child. Next one, if you can see, is a fine motor task. The same child, he was a higher functioning child, he could talk. Okay, so we also started with prerequisite skills of writing. So scissor skills were also taught to the child. Next, please. So school readiness groups is another very important task which we do once in a week in our department. And we teach the child school self-care activity is one thing. Second thing that we teach is simulate a classroom in our department. So as soon as the kids come, we'll tell them to make a line, enter the group therapy room, and once they enter, they all sing a prayer. So somebody would lead and they sing a prayer, and then after that they are all asked to sit down. After sitting down, a roll call is done. So the child has to respond to the name call. If they don't, therapist or an intern stands nearby, helps the child to attend to the roll call, that either by raising the hand. If they are verbal, they say yes ma'am. Okay. So after this roll call is done, we give them certain learning activities wherein the child may be called out by name, and when the child is called out by name, we teach them how to raise the hand to come up to the front and then do the task on the board. If the child cannot do, again the child is helped, or it is given by a therapist. He is led to the board and he finishes or completes the task. Initially again, as I say, with assistance, and later on once he learns on repetition, the assistance is stopped for the child. So these are the things we train, simulating the classroom. Sometimes we tell them to get food also, so we give a break hour and they share the food among themselves. And we also teach them how to ask to go to a restroom. So they are supposed to raise their hand and say like they want to go to a restroom. If the child is not non-verbal, then they have to use a picture card for restroom. Okay, so these are some of the things. And top, if you see, I have already mentioned about those activities which are taught to the children for using their own personal belongings or using a restroom during lunch break, etc. So these skills are also taught during the therapy sessions. Next, please. The video, the switch on. The first one is a group session which is going on for the children. Audio irko nanikre check paniko. So like the name is called, the therapist is helping him to raise his hand. So he has to go to the front and he has to complete a task and come. Okay. So this kid was also a higher functioning kid. So when his name was called out, he took a little bit of time, but he raised his hand by himself. But if the child cannot, then the therapist helps him physically also. Okay, the next video is again a fine motor task. So including whatever I said, SI we do everything in coordination with all those things. We also include brain gym, bilateral motor coordination task, handwriting speed also in higher functioning kids, reflex integration, which is one more very important thing. Third video, third video. This is again we working on the core muscle strength of the child. Okay, most of the kids, as I said, they will have a poor low tone. So when they have a generalized low tone, they are very, you see the postural control will be poor. They are very hyperactive, very fidgety. They don't sit in a proper posture in the classroom. So when we work on these core muscles, that is your abdominal strengthening as well as your back muscle strengthening, the postural control improves for the child, and thereby their hyperactivity may reduce to a certain extent, and their postural control is better, and they may be able to cooperate in a classroom much better. Okay? And we also do evaluation of visual motor integration, visual perceptual skills, motor coordination skills. Berry's VMI tool is there. We also use that tool to assess if a child is cooperative. We do it. It can be used for children 4 years and above. Okay. So if the child knows how to do pre-writing, we can start giving the VMI itself, and if they know how to cross out, then we start giving them the visual perceptual task also. And motor coordination is dot joining or drawing lines between the two lines. So it is very easy task. Some of the children who have already been trained for pre-writing could cooperate for VMI also. And then we also work side by side on the behavioral issues. The behavioral issues primarily again using a lot of positive reinforcements, which would be, first it could be maybe initially starting off with tangible rewards for the child. The tangible rewards would be something like, say for example, it is chocolate, or it would be a biscuit, or it could be any toy that the child likes a lot, and later on we go on for other verbal praises or prompts or giving a high five for the child. So we gradually change from tangible rewards to the social rewards for the child. Next, please. So some of the classroom accommodations can be told. This is basically we collaborate with the school teacher and advise them what kind of classroom setup should be there for a child who is entering into their school. So in Coimbatore, some of the schools do approach us and ask us how can we help this child. For example, I would say Indian Public School is a school which takes in kids. There is another school called as I think Prodigy School, which is a Montessori-based school. They take in a lot of kids with special needs in Coimbatore city. And so these kind of schools, they come and approach us. What can we do for the child to help them so that they can cooperate better in the classroom? So we collaborate with the schools and we tell them what kind of a school environment, classroom environment they should have, especially for children with autism. The less number of pictures on the walls would help them more better so that they get less distracted. Another thing is noise is another thing. If the children are very hypersensitive to noise, if the school can provide a noise, noise-free classroom, that is also good. And otherwise, we tell them to use sound cancellation headphones if the school allows. Not all school will allow, but some schools allow when they have an inclusive classroom, which they would have some few hours only with the neurotypical, and rest of the hours the children are having a section for themselves. In those kind of schools, some of the schools are also allowing noise cancellation headphones and fidget tools or toys. Sometimes these children are very fidgety. In that case, they can hold a toy which is in their hand to reduce the fidgety behavior, or they can have a weighted lap pad on their lap. They can have a weighted pad over the shoulders. They can wear a weighted vest also. These things generally help to reduce the thing. But not all schools allow this. Some of the schools would allow all these kind of accommodations. Another thing about structure and routine, as I already told you, having the timetable in a pictorial format for the child is always very, very good. Then the child will understand what to expect. For children with autism, predictability is very, very important. When they know once what is going to come next, they will cooperate very well with the teacher or with any person. But when they do not know what is going to come next, they become very overwhelmed and they may show behavioral issues or temper tantrums and all these things. So it's always best to make the class or the whole school session very predictable for the child. And this can be made predictable through picture formats or visual supports for the children. So clear daily schedule can be put, visual reminders for transitions. Transitions again is very, very difficult. For example, they have one classroom where they have to learn writing, etc., etc. Sometimes they may have to go to another class just to learn about computers. Because most of the school now in LKG have started teaching about computer. They have to go to the computer room to learn about it. For children with autism, it's very difficult to shift from this particular classroom which they are used to go to another new classroom. So again, training the children about these transitions through visual reminders that after this class, maths class is over, you have a computer class and we have to go to the classroom which is on the top floor, which can be showed in a picture format to the child if he is not verbal or cannot understand what is being told to the child. Another very important part is individualized educational program for the children. Okay, that is very important, and this is done as a teamwork by the occupational therapist, speech therapist, a physiotherapist in the school, the psychologist, even a social worker. All of them sit together and plan for the child. OT would plan based on the gross motor or fine motor or sensory issues, etc., pre-writing skills, etc. A speech therapist would work on the receptive and expressive skills and set up the goals based on that. So each team works and puts up their goal and they formulate these goals and work for the child. Maybe at the end of 3 months, again they meet and find out whether the IEPs were met or not. If not, what was the problem and how to work out those IEPs again. They formulate a plan, replan again. Okay. So these are some of the classroom accommodations that can be done for children. Next. Sensory diet is an important thing. Like we say eating is very important for our health. The same way sensation is very important for our brain functioning. So how much of sensory input we get, that much of neuronal connectivity takes place. Any learning, whatever we do, I'm touching this, I can feel it is hard. Okay, I learn from this, or if I'm going near the fire, or if I touch a hot object, I know it is hot, I should not touch further. So all these gives us input. By this input, we come to know this sensory input builds up lot of neuronal connectivity and helps us to know that
E-posters session will be conducted downstairs in 4th floor now at 12:30. People who will be participating, please, you can leave for 4th floor.
So, sensory diet is something which is given to the child right from the child gets up from bed till he goes to sleep, which is incorporated in the daily schedule of the child. And it is like small sensory inputs that are given, which could be brushing, which could be joint compression, which could be deep pressure, etc. So these are something which is given even in school sessions. If they have a resource room, it can be given in the school, or the child can be given small tasks in terms of just take the register, go and keep it. If the child loves a lot of movement, the child can be instructed, take the register, go and keep it in the teacher's table and come back. Or collect all the notebooks from the students and come and give it to me. So teacher can incorporate the movement craving of the child in these kind of productive activities, which gives the sensory diet also to the child during the class sessions also. Okay, and environmental modifications also, as I already told you, dim light is always better for children rather than very bright lights. Noise dampening classrooms, designated quiet areas for children. Some children don't like to sit in a circle with other kids. They can have a separate space. They don't like to sit together with 3-4 children in one table. They can be given a separate table to sit. Next, please. So executive function and cognitive readiness is another important thing. So task analysis has to be done to find out for day-to-day tasks, how do they perform day-to-day tasks. For example, packing the bag. Most of the children with ASD will not know how to pack the bag. It can be given again in a picture form in the pencil box, or it can be stuck onto the bag. The child will know, I have to put my pencil box, I have to put my tiffin box, I have to put my water bottle, I have to put my drawing book into the bag, and then I can go to the school. So all this can be placed either on the back side of the bag, or it can be stuck on the pencil box of the child, wherein the child follows first again with help of the mother, and later on he can be weaned off of the mother's help. Again, routine building I have already explained. Cognitive scaffolding. How do we do a cognitive scaffolding? First we do a prompt. The prompt could be physical prompt or verbal prompt. From the prompt we go for a gesture. From gesture we can go for independency, and then building cognitive independence. And another most important thing for children with autism is play-based learning. Next. So based on Indian and Western context, if we see for Western population, entry into school is 5 to 6 years. But for us it is now 3 years. Even before 3 years, we are sending the kids to play group. So that is the difference between what is school readiness practice in Western countries and our Indian country, India. Assessment tools, again, in Western population, lot of tools have been developed. They have systems where they start early intervention right from 2-year-old child. They start early intervention programs in school itself. They need not go to a center. The school itself provides. And OT service delivery, again, is in India, it's more clinic-based, limited to school, which is embedded. But if you see in Western countries, it is more school-based, is integrated into the school system. For us, it is more clinic-based rather than integrated into school system. Very few OTs are working in the school system. Even though there are a lot of vacancies, not many people are willing to work in a school setup. Cultural expectations, again, for us it would be like we are more family centric. For them it is more of nuclear families. So we have a lot of interaction that is good for the development of a child with autism spectrum, wherein they learn skills much better, much faster, more than when we say in Western population where there is a nuclear family. Other policies for us, we have Persons with Disability Act, we have Also, National Education Policy, which has come up in the year 2020. All these are into place, but not actually functioning appropriately. But in Western countries, whatever policies have come up for the children with special needs, they are actually following it very, very perfectly. Okay, and we have few evidence-based studies, whereas in the Western population, they use extensive RCTs and they are doing lot of practice on that also. Next. So this is what they do in the Western population, early start Denver model, wherein they start teaching 5 readiness domains. Whatever 5 readiness domains I said, it is taught right from an early age. Next, please. So role of an OT in school transition. First is pre-transition assessment. Then next is goal setting. After goal setting, you do a intervention phase. And the last one is school transition support. Next. So these are some of the evidence base which I have taken for my presentation. Next, please. So key takeaways for today's thing is, first is early assessment, and after doing an assessment, make sure your child starts intervention program. It can be anywhere, it's not necessary they should come only to you. So intervention, speech therapy, occupational therapy, anything, they have to start at the earliest level, because it is said that the first 1,000 days of life for a child is very, very crucial, and if the therapy is given during the first 1,000 days, it gives you much better results than a child who comes to us at 5 years of age or 6 years of age. Second thing is, target all 5 readiness domains, embed evidence-based frames of reference during your practice, collaborate and advocate both for the child as well as for the family as occupational therapists. Next. Thank you. So, if you have any questions, you can ask me. I know it took a long time. If you have any questions, you can ask. Everybody are hungry, I think. Okay. Okay, thank you.
Now, we thank Dr. Sucharitha ma'am for sharing her knowledge and insight. I request Dr. K. Naresh Babu sir to present the memento as a token of gratitude.
I request Dr. Sucharitha ma'am to felicitate Dr. SenthilKumar sir, Principal of Revadi College of Occupational Therapy, with the Academic Excellence Award and a memento to show our deepest appreciation for the active participation of Revadi College of Occupational Therapy.
Hello. The transition into adolescence can be a stormy time, and it takes a steady hand to through it. Dr. Jagadishan Tangra sir, BOT, MOT, MSc Psychiatry, PhD, Principal of JKKM MRF College of Occupational Therapy, brings years of wisdom, and a gentle spirit to this complex stage of life. As a mentor, he has shaped countless careers in life. We are honored to learn from your vast experience today. The stage is all yours, sir.
Respected dignitaries, Dr. Naresh, Principal, Abirami College, and the faculties, all organizing team, thank you for providing this opportunity to present my topic in this national conference. So actually I have prepared 55 slides. It may take 1 hour or more, but now the time is for lunch. Everybody there any strategies or any model, any frame of references to address this? Is there any frame of references helps to manage cognitive rigidity? Is there any scale to assess the cognitive rigidity and emotional flexibility? So dear friends, think in this aspect, conduct more research on this area because lot of scopes are there in adolescent and adult psychiatry. Right? These are all the challenges we are going to face. Right? Autistic adolescents facing social, sensory and academic and self-management. Right? Particularly the ADL skill what ma'am discussed now. Right now they are entering. People are in school. People are in society. If you are taking an adolescent into the hotel or if you are taking the adolescent through public transportation, how to address all these behavioral issues? So these are all the questions we are going to discuss. Next slide, please. So in this discussion, we are going to discuss in 4 different components. Section 1, discuss about the major issues. Section 2, assessment part. Section 3 is the intervention part. Then social aspect. Right. Next slide. As I said, core autistic features are continuous in adolescence also. The major features, puberty. Puberty is creating different sensory issue. What we are seeing here, no? Proprioceptive, hyperactive, tactile hyperactive, right? Apart from that, puberty create different sensory issues. Then, functional performance. Adolescents are expected to perform more roles, socially acceptable roles. That is a major challenge. Next one. Most of the schedules are adult directed. Now the parents is taking care of the need of all these autistic children. They are holding the hand, guiding them. At the age of 15 also they are doing the same. Are they independent? What are all the adaptive strategies or teaching strategies we have? Right? Nowadays they are dealing with verbal prompt and physical prompt. Without prompt, are they able to manage in a public place? Right? Imagine if the adolescent with autistic child is sitting in a hotel. They are not having the choice because they are rigid with that routine. They'll always like only ghee roast, puri. They don't want more than that. But this is not a normal thing. Society is expecting something different. So what are the strategies we are going to train them to select the menu? Right, this is one aspect. Now we adolescents are able to identify where the restroom is by asking somebody. But these autistic children, autistic adolescents are having problem in interacting with others. So they are having difficulty in identifying this public, so toilets or restrooms in public place. These are all the skills to be trained. So what to do? Early support. So if we are training the children in this age, it is possible to minimize the problem. Next slide, please. There are performance barriers I have listed here. Sensory over and under responsiveness, executive dysfunctions, and poor routine management, motor planning and coordination difficulties, anxiety, rigidity and stress. Anxiety, rigidity and stress. People are not ready to interact with others. People are not ready to move to the public place because of their anxiety. We need to take care of anxiety. They have fixed routine. They are not able to come. Adolescent with autism, they won't come out of the room. Even if they are in that public place, they will be preoccupied. Like we people are doing with our mobile. Similarly, they will engage with mobile or some other tab. So this is not socially acceptable. Then stress. If you compel them, they'll feel the stress. Stress create a lot of performance related issues. Right? So occupational therapists should focus on all these areas. Then participation effects. So due to that, people won't attend school. School refusal is most common. They'll depend on ADL, particularly in IADL aspects. Then peer isolation and limited leisure choices. So they don't have leisure like us. So we need to plan more leisure activities according to the features of autistic children. It's not too easy. Just recommending 1 or 2 leisures, you go and play. It is not easy because people are not ready to participate. So we need to find more leisure activities according to their autistic trait. Next. What are the strengths? Many autistic adolescents show honesty, persistence, and strong special interest. They are the strengths. The strengths. Visual learners, memory for routines, and preference for predictability can be a therapeutic asset. So we need to understand these are all the strength of all autistic children. We need to understand all that, encourage them with that strength. OT uses strengths as gateways to motivate self-esteem and skill generalization. So these are all the core aspects where they are, if you follow a routine, they'll attend. They'll be very honest. So use that. So this is the core strength of these adolescents. Related to that, challenges also to be combined. According to that, there will be the strategic plan. So I have some strategic plan to manage these issues. Next. Indian context, there are real world realities, high family involvement in daily care and decision making. So you know that, as I mentioned, family members are always blocking the process of decision making. Most of the time, mother is giving a prompt. They are blocking the decision making process. Then, variable access to adolescent focused autism services. Academic pressure. So I have one example. Actually, there is one high functioning kid in inclusion school. That candidate is getting high mark. Always he will be coming with top 5 ranks. But other parents are complaining that he is not capable of getting rank. How can you give? Because special things are there. They are providing a special seating arrangements. They are giving extra time for 30 minutes to complete the task. People are not ready to accept all these changes. So don't give rank. People are getting pressure like this. High functioning. IQ is excellent. But society is not ready to accept this type of adjustments. So this is also the another important thing. Then transportation, stigma, the major issues. The implication. So what to do? Occupational therapists always collaborate with family members, school teachers, provide home programs, school-based strategies to manage adolescent issues. Because they are not children. There are different psychological changes, social emotional changes, normally happens during the period of adolescence. We need to train all the teachers who are handling this adolescent with autism. And also we need to train not only the parents, all the grandparents, siblings. According to the core features of autistic, we need to provide a home program. This is the way temporarily we can manage. But we know that each individual is different. There is no common treatment strategy for all. Each individual are always different. So always set different individual based assessments, and according to that we need to plan. Next slide please. So occupation. What are all the occupational roles of adolescents? Adolescents are expected to do something, some roles like us. So that occupation to be assessed. Occupational roles are to be assessed. So there is few standardized assessments, occupational role checklist, but lot of scopes are there because all these tests are standardized for a normal peoples. So we need to conduct more research on this occupation-based assessments in occupational therapy. The OT asks, what matters to this teen? What gets in the way? What support works? Intervention targets person, task, and environment together. So we always focus on individual, but hereafter, from the adolescent onwards, we need to focus on their environment and what the task they are performing. This is also very important. Conduct a specific task analysis. Specific task analysis. Not only on school-based. If they are working, they are playing a role in the home. Task-based assessments are assessed. For example, I can give. My child is helping me. The parents are saying, my child is helping me in all the aspects. What sort of help? Only routine helps. They are not able to decide. Mothers always giving a prompt, take the bigger one. In case of they are helping in that kitchen related work, all the measurements are guided by the parents. So we need to train, because withdrawal of these supports from the parents to be addressed in the home program. More simulated activities are to be practiced in occupational therapy department. The same simulated activities can be transferred in their home settings. So this is the way we are going to address all these autistic children in our occupational therapy clinic with adolescent autism. So the transfer of training to be corrected by the parents. If transfer is challenging, then occupational therapists should work on this basic aspects like anxiety and stress, because parents always give pressure to perform. So we need to address. So this is another work area occupational therapist should focus. Next. Assessment priorities. Next. Occupational profiles, sensory processing and self-regulation areas, motor, praxis and postal control, ADL, school, leisure and social participation. So these are all the areas we need to focus, particularly for adolescent with autism. There are research possibilities, right? We don't have standardized scale to assess all these areas. How to start with now, from today or tomorrow? We need to change the research dimension in different aspects, like conducting semi-structured interviews and interviews. Because when you conduct behavior-related assessments, there are a lot of challenges in getting standardization. Because each individuals are different. We don't find a normative scales for adolescents. It's a highly challenging one. So, from today, when you conduct a research for adolescent, don't focus only on, don't search only on this standardized assessment, rating scale, checklist, questionnaires. So there are other strategies. Use that strategies and conduct research. Interviews and observation method, task analysis, and use standardization, and get the input from the parents, teachers, and other caregivers. So conduct these type of studies, then we can get solutions. Next slide. In occupation profile, begin with adolescent routines, roles, interests, and problem situations. Ask about morning schedule, school day, after school time, sleep, and community outings. And include sensory triggers, trends, motivators, and preferred supports. The profile makes assessment personally meaningful and culturally relevant. Because we cannot adapt all these standardized questionnaire from some other country. So we have to conduct based on our culture, where we are working. If you want to conduct the research in Tamil Nadu or this area, conduct this structured and semi-structured interview, then it will be more reliable. If you want to conduct the same study in North India, use according to their culture. That is very important. Next slide. Sensory profile in adolescents. Already you know, adolescent and adult sensory profile is available. You can use to identify the sensory related issues. Next slide. Then executive functions and routine management. These are all the basic interview questions related to this and executive functions. Because executive function assessments are there for neuro patients. The same cannot be addressed because lot of challenges we have identified during our research with our students. The executive function assessments for ADHD children may not be suitable for autism adolescents. So we need to move with that. Next. ADL and IADL assessments. We have developed ADL and IADL assessments for autistic children. It is available in the net. If you want to search IADL assessment for autistic children, it is available. Then next. School and community participation. Here also there is a lack of school and community participation related assessments. Already ma'am have provided school-based assessments and community-based assessments in Indian standards, particularly in this area, to be conducted. So all these areas having lot of opening to conduct the research. So all of we need to initiate with that this research process like semi-structured interview and interviews and conducting with the checklist. So the checklist should be focused on the culture sensitive. Next slide. Then emotional regulations and mental health. So here cognitive rigidity and emotional flexibility. You know that cognitive rigidity is a major factor. People often get upset. Adolescent with autism always get upset, always get irritated, always get anger. If you change your routine. So we need to assess the rigidity, cognitive rigidity. We have developed a scale on cognitive flexibility and emotional rigidity. You can use it for your research purpose also. It is interrelated. When the cognitive rigidity is there, emotional aspects also to be getting affected. So the two aspects. Whenever there is a rigidity, cognitive rigidity, it affects the emotional aspects. So emotionally, these people are getting triggered. They are not able to cooperate. Calming down is difficult. Sometimes, nowadays people are complaining. People are, till now there is no problem of self-injurious behavior, now started self-injurious behaviors because of this emotional instability. So, assess cognitive rigidity and emotional flexibility, and we need to address more. Next slide. So then next goal setting. So based on the core autistic traits and the functional areas where the lacunae are there, we need to conduct assessment. According to that, we need to set the goal. It's not like improving ADL, provide sensory integration, improving behavior problem. It's not like that. So set more functionally focused goals. Then next. Intervention aspects. Next. Sensory strategies. All the sensory strategies are focused on calming because still sensory integration is effective in adolescents, but it is not like in the inpatient, the outpatient department where we are working with children. But other sensory strategies are available and we need to focus on this area. Use movement breaks, deep pressure, oral inputs, noise reduction and environmental modifications. Teach when and how to use strategies, not only what the strategies. So this is also most important plan, where to use, when to use. So whenever there is a problem, use it. If the context is also play a major role. If it is in a home, how to manage. If it is in a social situation, how to manage. Context plays a major role in administering these sensory strategies. Then carryover matters, particularly the school, home, travel context need to be adapted. Next slide. The self-regulation toolkit. We need to teach the adolescents to identify body signals before escalation. So there are some strategies in case if you are getting these type of problems in your body, the increased palpitation or sweating or some other urge. So how to identify? We need to train them how to identify all the bodily changes or internal changes. So that we need to train. Use visual scales, choice boards, breathing, grounding, fidgets and break parts. So this is a major strategy because they can carry over all this. They can have it in the pocket. They can have it in the bag. Right? So they can learn easily and they may practice. Regulation plan should be portable, simple and acceptable to the team. So occupational therapist creativity plays a major role. So treating these people, children with autism in a OT department is different. Handling in a school setting, handling in a public area is difficult. So we use creativity to identify. What are all the calming strategies I can carry over? So that we need to plan. Then repeated coaching turns scoping because always practice. Just giving 1 day practice, 1 day training, 2 days training, 1 week training is not going to help. So train them intensively, train the parents, they may follow it up, guide them. So this is the strategy for all sensor related needs. Next. Body awareness, praxis and motor planning. So intervention to be targeted on the posture, bilateral coordination, sequencing and graded force. Use meaningful activities like kitchen tasks, sports drill, dressing and tool use. Because they are adolescents, so depends upon the environment we need to focus. So always focus on outdoor related activities, not on indoor. If the resource rooms are there, if the child age is 14 or 15 plus, so allow them to practice in the resource room. So all this sensory integration, motor planning activities can be planned in that area. Next slide. Fine motor and writing and keyboarding. The same fine motor activities to be modified. Right, using scissor activities is not socially acceptable in the classrooms. So modify this activity. Some of the fidgeting related toys can be used. It should be placed in the adolescent's handbag. So if they want to use it, just a calming strategy or simple manipulation helps to reduce their sensory needs. Next slide. Personal hygiene training. So most of the adolescents may get training during the childhood period itself. When they become adolescents, they have problem in adolescent related ADL, particularly taking care of the menstrual related needs. Then adolescent related like maintaining oral facial hygiene. Right, all adolescents nowadays, everybody is whenever you get a break, you are refreshing yourself. But adolescent with autism may not have this practice, so we need to allow them to practice. Next, dressing and grooming. So dressing sense is also important. So according to the place where they are in the school, dressing to be practiced. If they want to go to public place, if they want to go to a restaurant, different dressing styles all to be practiced. This is also practice. Next. Feeding and mealtime participation. So for adolescent, particularly eating in a public place to be trained. Public eating is the major drawback because when you take adolescents for a major family function like wedding functions, without distracting others, they cannot have a food. So this must be trained because they might have, for example, all these unwanted things, they'll keep it in the table. So table manners to be trained in childhood itself. Some other things also, social related functioning to be also trained. Next. Sleep and daily routine organization. So all sleeping strategies, people used to sleep. All our students are sleeping at 2 o'clock daily. The same complaint also there among adolescents with autistic. So we need to train them. Next. Time management and transition. Next. Communication support within OT. Next. Then social participation group. conducting group therapy in this OT department. It's different from this. So we know developmental group approach in occupational therapy. We need to modify a lot. Most is adaptive skills are applicable, particularly here, but lot of changes are there because 30 years before this theory and framework has even. Nowadays, group interaction is always differs now. You are watching mobile for more than 1 or 2 hours. Even if you are in a family, all 4 family members are watching mobile. They are not interacting, but it is socially acceptable now. If you are taking developmental group approach, it is not acceptable what we are following. So we need to have a different intervention strategies for their social skills. Parallel, projective, egocentric, all these groups we are studying now. From the projective level, we need to modify different group strategies. Next. Leisure exploration. So most of the leisure are related to artistic core traits. Otherwise they won't follow. Leisure assessment, leisure participation is always difficult because they have rigid nature. So playing with typical autistic adolescents not going to helpful. Playing with adolescent with other normal people, they won't take them inside. If you are including them, they won't take inside. They won't accept. So it's a highly challenging one. So leisure participation activities to be practiced by the therapist. Next. School participation support. Next. Next. Right. Safety, identity and transition into adulthood. Next slide. Right. From here, adolescents to be treated intensively, continuously. Otherwise, they are not fit for adulthood life. People are thinking that, nowadays, people are thinking that education is over. Not able to manage all the sexual needs, secondary sexual characteristics. People are searching homes, residential home for these children. We need to think seriously about this point. At the age of 15, 16, people are going to be placed in the home, residential home. Very serious issue. It means they are not going to perform all their role, all their routines. The routines will be within the room. If we, occupational therapists, are addressing this issue, then they'll become normal. They can live independent life. Otherwise, it is going to be a question mark. Lot of mental health challenges are going to be taken place in future. So I request all occupational therapists who are here, work on these adolescent issues and work for the bright future of all these autistic children. Thank you one and all. Thank you for listening.
Thank you, sir, for sharing your expertise with us. May I request Dr. Periyaswamy, sir, to present the memento as a token of gratitude.
I request Dr. Jagadishan sir to felicitate Dr. L. Vishnu sir, Executive Committee member of TNI IOTA, as a token of appreciation. I request Dr. L. Vishnu sir to receive the Academic Excellence Award on behalf of Dr. Abirami sir, convener of TN IOTA. I request Dr. Naresh Babu sir to present the Academic Excellence Award to Dr. Vishnu sir on behalf of Program Sir, Convener TNIOTA. As we move ahead, we'll now take lunch. Please enjoy your meal and reassemble for the next session. Students of Abirami College are requested to stay back for a quick discussion. I repeat, as we now move ahead, we'll now take a short break for lunch. Please enjoy your meal and be back in 45 minutes. Students of Abirami College are requested to stay back for a quick discussion.
statisticians, and Professor Dr. K. Naresh Babu, Principal Sree Abirami College of Occupational Therapy. எல்லாருக்கும் ஒரு டவுட் இருக்கும் ஆக்குபேஷனல் தெரப்பி என்ன ஃபிசிக்கல் தெரப்பியும் ஆக்குபேஷனல் தெரப்பியும் எந்த அளவுக்கு டிஸ்டன்ஸில் இருக்கும் ஆனால் ஆக்குபேஷனல் தெரப்பின்றது செயல்வழி மருத்துவம்னு சொல்லுவாங்க தமிழில் நிறைய விஷயங்கள் வந்து சில பேர் அடிப்பட்டதுனாலையோ இல்லை இல்லை ஆக்சிடென்ட்னாலையோ சில ஃபிசிக்கல் லிமிடேஷன்ஸ்னால சில அன்றாட வேலைகளை செய்யறதுக்கு ரொம்ப கஷ்டப்படுவாங்க அதை எவ்வளோ நேர்த்தியாக காமிக்கிட்டு இருக்கோம் இல்லை ஆக்டிவிட்டிஸ் மூலமாக அதை சரிப்படுத்தலாம் இல்லை அதை வழிப்படுத்தலாம் இல்லை அவங்க வந்து திருப்பி ரீபேக் டு நார்மல் லைஃப் கொண்டு வரலாம் இந்த ஆப்ரேஷனல் தெரப்பி எஜுகேஷன் இது வந்து நம்மளுடைய இந்தியன் மெடிக்கல் யூனிவர்சிட்டி மூலமா 4 வருஷம் கோர்ஸாக நடத்தப்படுது ஸோ இட்ஸ் ரியலி இயர்ஸ் கோர்ஸ் 4 years of theory examinations plus clinical training programs plus 6 months of internship has to be completed as a compulsory internship for the students. So இந்த 4 வருஷம் கோர்ஸ்ல ஒவ்வொரு வருஷமும் different levels of education set பண்ணியிருப்பாங்க. ஸோ ஃபர்ஸ்ட் இயர்ல பார்த்தீங்கன்னா பேசிக் சயின்ஸ் லைக் anatomy, physiology, அவங்களோட sociology, psychology and plus basic OT பற்றி சொல்லிக் கொடுப்போம். செகண்ட் இயர்ல இருந்து we start with the community medicine, general medicine, health psychology and some fundamentals of occupational therapy approaches and clinical neuro and clinical ortho சேர்த்து சொல்லிக் கொடுப்போம். And plus third yearல இருந்து we'll be having a specialized course on occupational therapy in ortho neuro as well as in pediatrics as well as in musculoskeletal disorders and biomechanics. And in fourth year onwards we'll be having a separate courses on project as well as research and group process and organization and administration. Youth wonder how to manage within the profession.
Hello.
Hello, കേക്കാണ്ട്?
Hello. 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 One second, sir. Sir, बाकी का तो वर्मा को. Hello. 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 Check.
Hello.
Hello. Hello. Check. Sound இல்ல. Hello. Hello. இதுதான் sound இருக்கு. Sound இல்ல.
Hello, hello.
അയ്യോ എന്റെ ബുക്ക്
Hello. Hello. Hello, check.
Hello. Hello. Check. Delegates are asked to assemble in the hall. I repeat, delegates are kindly requested to assemble in the hall.
We'll be starting our sessions now. Students, please be seated. I repeat, we will start the sessions now. Students, please come inside the hall and be seated.
He doesn't clinic, he works in the world of policy to ensure that no child is left behind. His tireless effort with the Para Sports Association and his work at SRM College shows a heart that beats for social justice and inclusion. We are so grateful for your presence. The stage is all yours, sir.
Check, check. Hello, check. Check, hello, check. Check, yes. Yes, good afternoon all. Everyone are, yes, last bench. Guys, give your attention here please. Kindly come forward if possible. Already you have a nice meals, right? Okay, just come forward, we can do some exercise. afternoon all. Once again, I want to start this session by thanking the management for providing this great opportunity to explore the para sports as well as what are the special kind of attention we want to provide to the autism as well as differently abled populations. Once again, I thank the entire management as well as the College of Occupational Therapy for providing this wonderful platform. In this particular occasion, the topic, the session, what we are going to deal with is the breakthrough challenges and opportunities in the schemes and policies in regards with autism as well as the differently able. Okay, it's not purely with autism because in India, the para sports, they have included the autism in the intellectual disabilities, but in Special Olympics, they have a separate kind of activities like cerebral palsy, a kind of sports events, autism, a kind of sports events like that. So I want to give a mixture of events with this particular current topic. Okay, yeah, next slide. So as everyone know, right from the morning, we should not use a term as a autism, rather we can use as a autism spectrum disorder. As everyone aware about the particular definition, it is a neurological as well as a developmental disorder that mainly focus with the people, how they are interact. Okay, so if right now I'm speaking some content, whether my content is reaching you people, the interaction is correct or not. Same way, the interaction should be proper and they're having a communication lack as well as the learning as well as the behavioral changes. Okay, so these are the factors or the components that will come under the autism spectrum disorders. Sorry. Check. Hello. Okay, audible, right? Yeah. So we have aware about the what is a particular autism spectrum disorder. So it comprises of a major of the components, that is especially the behavioral aspect, motor skills, as well as the perspective thinking, way of thinking, how they will think, whether they have a morning, the doctor have clearly mentioned about that, whether they have fixed with a certain aspect, they are focusing that, or the way of thinking is more broader. So that are the three components we have going to assess. So next slide. So in this particular thing, we want to know what are the challenges, most of the key challenges, either the autism person or the caregivers or the society, they having the barriers. What are the key challenges they are having? The first thing it will be, next it will come. Next slide. Yeah. First one, it is a policy practice gap. So whatever the policies the government they have giving for the society or the special population, always there is a lack. That means the reach out, the awareness between the caregivers or the autism affected persons along with this kind of schemes. So there are n number of gaps in between. So first thing it will be the policy practice gap. Second, it will be a delayed diagnosis. So most of the time we are not having a 100% exactly when we want to diagnose the autism. So always there is a gap between when we are diagnosing. Once if you are diagnosing, the progression will be good. No, it will be worsen. So early diagnosis is one of the key challenges we are having. Next. Fragmented services. Always there is some fight between certain professionals. No, I want to deal with this particular patient. I want to assess this. I want to give a treatment. So in that aspect, what it happening means there will be a lack. So the fragmented services that make the individual persons to get those kind of attention they also become more tired. That means if I want to go one special school is there, means the special school carries all kind of medical professionals. So on the fragmented aspect, if you are having a lack, they are having some kind of key challenges. Next. Education barriers. Again, so ma'am also have insisted the special schools.
whether they are having a proper kind of schools. The parents or the caregivers, they will ask, my child, they will go for the normal school or not. The question they arise, right? Same way, they're having the educational, this kind of barriers they have. And next, it will be the employment gaps. Nowadays, India, the Tamil Nadu government, they are giving a number of job opportunities for this kind of special population. But still, we are not aware what kind of reservation or where we want to go and approach. So these are the main key challenges the autistic caregivers as well as the autistic affected population they are having in this our society. Next. So now we are going to see about the few laws that exist for the autistic population in our society, especially in our country as well as our state. Next. Next. So 3 points will come in this. Excuse me. 3 points, yes. The first act, it will be the Rights of Person with Disability Act in the year 2016, it amended. So what it clearly emphasizes, first, it recognizes the autism spectrum disorder as a disability. Previously, they used to say as a handicap, and they have said about the disability, but now we should not use the term called disability. Again, we want to use as a differently abled. So if you want to focus someone with autistic or any kind of special population, we want to mention them as a differently abled, not also as a disability, we should not focus. So much good term as a differently able. So this particular Rights of a Person with a Disability Act, first it recognizes the autistic populations. Second thing, this ensures the right education, employment, accessibility and social participation. So you are going for a malls, you are going for even a metro stations or any kind of social inclusion areas you are going, we can easily go into the steps. But whether the inclusive population, they are having a proper accessibility? No, we are not having. But nowadays, recently, the past 5 years, the good awareness it came. Especially this 2016 Act, it emphasizes, and the population with this kind of differently abled, they are also coming forward and achieving this kind of good accessibility and social participation. And third thing, mandates reservation, non-discrimination. Again, the discrimination is there. Okay, if some autistic child, they are coming to our clinic for a treatment, okay, especially in physiotherapy as well as occupational therapy clinic club together, if an autistic child or any special population they are coming, another patient they came for the pain reduction, they will sit and they will stare what is happening to the child, and next thing they will start put a question to the parent, right? What happened to the child? So they started a discrimination in putting a questions. So that should not be there. So this particular act that will give that we should not give a discrimination to the any kind of special populations, and we want to give an inclusive environment. Next slide. And second act, it is a National Trust Act. So it is amended in 1999. In this particular act, what they have focused means, they have focused a cluster of the conditions. So first thing, it is a autism. Second, cerebral palsy, intellectual disability and multiple disabilities. Okay, so not only this 1 or 2 conditions, the participants, they are having a number of problems. Okay, so in this particular act, this promotes the independent living as well as community inclusions. Okay, as a healthcare profession, we want to know this. Most of the senior most peoples or the final year candidates, you have aware about this particular acts and policies, but the youngsters like the first years, you want to know all this for sure. Okay, next. Again, that will give a sports a godship, that means they will give a proper protections to the particular populations. Okay, in any kind of, if they are any other healthcare professions, they saw that discriminancy, this particular act that will get to that particular participants. Okay, next. And third, this is most important thing. So Khelo India scheme. So what in this particular focus is, the special populations, they are involved in the sports activities. So previously, the mothers or the caregivers, they will come to our clinic, they will say, okay, give a therapy, they will sit and they will spend some half an hour, 1 hour at the allotted times and they will go. But nowadays, we're having this particular scheme that will initiate the special populations, either the autism or cerebral palsy or whatever it may be. This particular scheme involves the populations to get involved in the sports. So it encourages the grassroots sport participation, including the persons with disabilities. So in our country, it carries off a major of 5 domains. In a college aspect, school aspect, differently, that is a para sports, and in case of youth games and university games. So these 5 domains, the particular Khelo India schemes that will amend, and in your clinic, if someone they want to get participated in this kind of para sports, the eligibility age is, it starts from 7. So you diagnose the autistic child in the age of 5 means you can clearly focus in which domain the particular candidate can get involved in the sports activity. So you have at least of 2 வருஷம் நமக்கு வந்து என்ன இருக்கு solid experience, we can train the individual candidate. So once they achieve the age of 7, we can put in the right sports. So this particular scheme that will help for the autistic childs. Next. So benefits of this existing laws and policies. What are the benefits for these policies means? The first thing, next slide, next. It gives the protection of the rights. So as we saw about the rights of person with disabilities, first that particular law that give a protection for the individual candidates. And next, it gives a recognition and inclusion. Okay, the second law, that with the National Trust Act, that will give a recognition. So first it will give the protection, and second it will give the recognition, and third one, it gives the access of education. So in our country, after this particular acts, most of the students, special populations, they are involved in the educational activities. Next. So accessibility of skilled professionals. So RCI, so in the year 1992 it get amended. With that particular act, the skilled professionals, they are getting trained. Okay, and last one, it is a opportunity of sports, that is a Khelo India. These 5 major schemes we supposed to know and involve the participants according to that. Next. So now we are going to see about what are the policy practice gap. So first thing, we are having a very good strong laws, but the gap is we don't know how to apply those laws. That is, we are not having a proper awareness. Even though we have a very good society and very good social media, till now some of the areas, the people, they are not aware of this. So even though we are having a strong laws exist, we have some kind of gaps. That is, still we didn't reach the society people. And second, there is a poor implementation. The people who knows the laws, they are implementing in a wrong ways. Okay, that is partialities. They are focusing for only this particular society, this area. So like that, again the state-wise also some kind of problem is arise. And third thing is a lack of coordination. They don't know how to implement this in a proper way. And last one is a weak monitoring system. If someone they are enter the in my particular area, some 20 candidates of autistic child is there means they have given the census and the regular monitoring, it is not happening. So not only the autistic, many kind of special abled bodies, this happening in our society. That is, weak monitoring system happens. Okay, so these are the 4 points that will for the policy and practice gap we are providing. Next. So what are the healthcare challenges? So previously we saw about the policy and practicing gap. Now the healthcare challenges are limited early screening. Okay, so we have a n number of scopes. Still we are lack in this early screening. Okay, and next one, it's a shortage of trained professionals. As you people came here, so almost some 200 to odd registration came. 200 odd registration over participants inga over resource person சொல்றத எத்தனை பேர் அப்சர்வ் பண்றீங்க? So நீங்க அப்சர்வ் பண்ணி you have learned something only, you can be a trained professionals. So உங்களை மாதிரி professionals train பண்றதுக்காக தான் இந்த மாதிரி conferences and workshops the institutions are running. So major of the places there is a shortage of trained professionals, so there is a challenges in the healthcare professions. And next one is again the urban and rural disparity. Wherever the city side more focus, they are providing a good financial aspect and getting a treatment, and some kind of village aspect, even there is no proper rehabilitation setups. So these are the three important points that exist for the healthcare challenges. Next, educational challenges. Again, the lack of trained teachers, the special workers. Okay, so many areas, the lack of trained teachers are there, and poor implementing of the system. So whatever the direct the education policies, okay, implemented education policies, that is not implemented properly. And next one is a limited inclusive infrastructures. Okay, if you go for city-based areas, very good ramp, very good accessibilities is there, but same person if they are going for another next building, okay, so this healthcare medical college or the healthcare professionals are here, how many the differently abled population they can easily access the particular institutions. Okay, so on the mari aspect we want to give a proper census and try to modify the particular barriers. So these are the three important challenges for the education aspects. And next, economical challenges. Again, certain areas there will be a charges will be high for the rehabilitation services. Okay, so next it will be the financial burden for the families. So per week they want to spend this much of amount for the therapy aspect. So they used to calculate whether we want to spend this kind of amount for the proper rehabilitation. Okay, if a trained professional they are doing a treatment, that is well and good. Same thing, the parents are caretakers, they want to do the treatment, whether they are doing the treatment in an effective way or not. We want to analyze that. And next one is a limited funding. Okay, the sponsors. Okay, that is very lack. So these are the three challenges for the economical aspects. Next. Now, rather seeing the problem, we want to focus on the opportunities what we have. So first thing is we have a rights-based policies. We want to apply to the government. In our area, this kind of populations are there. We need a fund for treatment aspect. So a lot of schemes are there to get the funds. And next one is a early intervention centers are here, and inclusive education. So third thing is most important. The inclusive education is most mandatory. Okay, next. Skill development is next slide. Okay, so now this from here I want to speak more elaborately for this particular session. So the sports and inclusion for this kind of autistic child or any kind of differently abled or special population in our country as well as our state, we are focusing very good sports involvement for those candidates. In that first thing, it's a Special Olympics. In Special Olympics, the category wise they used to involve special population, that is a cerebral palsy. They are having a cerebral palsy footballs. They are having there are different levels of sports involvement. So like that, individual sports they used to concentrate in the Special Olympics. And next one, we want to improve the social skills, that is social inclusion. They want to participate in the society. Population or special child in a house, they are getting a very good accessible devices like a wheelchairs, different types of wheelchairs. They put them in and make the special children to come out of the society. Next thing is enhance the physical health. That is our rehabilitation services. Okay, next. So what is Paralympics? So in the Paralympics, what they have said is 10 different inclusive criterias. Okay, there are 10 different inclusive criterias they used to put in a para sports. So those things are first, it is a impact passive range of motion, impact muscle power. Okay, so first it's a impact muscle power. They are having muscle weakness. Next, they should have a limited passive range of motion, either the contractures or any kind of joint related problems, and limb deficiency. Okay, that is kind of absence of limb, either a part of a limb, part of a bone, or a complete bone. And next it will be a LLD, limb length discrepancy. So if someone they having a shortage of limb, they should have 7 centimeter and above. If they are having a 7 centimeter and above only, they are eligible for the para sports. If they are having a 5 centimeter lag, they are not included in the para sports. Okay, their criteria will be different. So like that we want to analyze each and everything. In this, 8 categories will be for the locomotion, 1 category for the intellectual disability, and 1 for the visual impairment. Okay, among 10, 8 for the locomotion, 1 for the ID, and 1 for the visual thing. So these are the 10 criteria they will include in the para sports. Next slide. Yes, if you see about the history of a para sports, they didn't coin the para sports for the special population initially. So once at the end of the Second World War, okay, so almost we are in a urge of Third World War, right? So in the end of Second World War, what happened means the US militaries, okay, they got injured. So once they got injured, some 10 to 15 kind of population, they went for a more depression. So once they went for a depression, that particular healthcare sector, what they did means, they want to involve in some kind of sports activity, so we can get out of them. So like that, in the year 1948, it started. Okay. So like that, it emerged in 1952, and first Paralympics happens in 1960. In that particular year, almost 400 athletes from 23 different countries, they have participated. You know what is the recent, that is 2024 Paralympics? In that almost 170 countries they have participated. So initially only one country, the army people, then first Olympics 23 countries, and very recently 170 countries participated. In that our country got 29 of medals. Okay, so that is highest number of para medals for our country. So this is the history of a para sports. Next. And these are the various summer and winter games available for the different labeled populations. So in case of summer sports, 22 games are there, and in case of winter sports, 6 games. Okay, so these are the sports in our country. Major of the sports, they are getting involved, okay, for the para sports. Next. So already I have mentioned, these are the 10 kind of inclusive criteria. Okay, so impaired muscle power, impaired passive joint range of motion, limb deficiency, ataxia, atisosis, hypertonia, short stature. If you check about the short stature, okay, there are 2 categories. Short stature, the dwarfism category. Next, the same thing, achondroplasia. Okay, short stature means they will be more short in their structure. If you check about their limbs, upper limb and lower limb, that will be short. In case of achondroplasia candidates, the limbs, only the hand and legs, it will be short. The torso, the chest wall, full entire till abdomen, that will be like a normal adult. For short stature, that will be easier to sit in a chair. But in case of achondroplasia, limb chinada iruko, body matta perusa iruko. They are having a more problem. So like that, special populations, they are having a different kind of classification. They get involved in the para sports. And in case of visually impaired, so in case of visually impaired, again there are 2 events will be there. Completely blinded, partially blinded. Okay, so partially blinded means they have some kind of exclusion. In case of completely blinded, they will run along with a guide runner. In order they want to run, both of their eyes should be closed. Okay, so once they want to run, guide runner and the normal athlete pass panna mudiyadhu. So they will go for an exclusion. So these are the inclusive disability criteria we have. Next. So in other special populations we got assessment. We want to check about this 4 domains. So first thing it will be the range of motion, muscle strain and coordination. We want to assess whether they are autistic, whether they are a cerebral palsy, whether they are having another kind of locomotory problems. We want to analyze this particular thing. And next one, what kind of equipments they are using for a para sports. Whether they want to use a wheelchair for a wheelchair racing. We want to assess what is the weight of that particular wheelchair, or whether they are using any kind of orthotic devices. Okay. So certain sports they should not use a processes. Certain sports they want to use a blades for running aspects, for the long jump, for the high jumps. Okay, so different kind of equipments is available for the para sports. And next one, pattern of play. That is a pattern of play. How they play. Okay, so what kind of biomechanics they are using. And last thing, it will have frequency and duration of a training. How often they used to get trained? Because this is the first event I am participating in the para sports. If I secure a gold medal, there will be a query. How he is secured, whether the classification is correct or not. So those things and all we want to check. And periodization of a training, again the coaching standard. Who coaches the athletes? Who coaches? How often they get coaching sessions? So everything as a para classifier we want to assess this. In this, the healthcare professionals, we have a role. Okay, the healthcare professionals, we have a role. So ನಮ್ಮ society we are treating a patient, that is okay. Next, what we are going to do for that? Continuous treatment பண்ணிட்டு இருக்க போறோமா? No. We want to involve those kind of childs, we want to involve those kind of special populations in case of this kind of activities. Next slide. Yes. Next. Okay. So in this class 20, this is what I have mentioned. If the autistic child or if any kind of intellectual problems, okay, in para athletics, they won't separate autistic alone in a special or a separate event. So all ID and autistic, everyone they were clubbed together and they used to put in a track 20 or T20 events, T20 or F20 events. In that again they have a criteria, the IQ level will be this, and the IQ, if they are having this kind of IQ level, the onset of this IQ less will be before the age of 18. Okay. Once after the birth they are diagnosed, that is okay. If someone after the age of 18 they met an accident, they had a stroke, and the time that the IQ level get diminished means they are not considered as a intellectual impairment and they won't post in this kind of particular categories. So upon our child, autistic child, right from a 5 years, right from a 4 years, or which year we are training, okay, we want to make sure the age factors and why the IQ level is in that categories. Okay, idella paakama nama sports la anupa mudiyadu. And again, the clinical psychologists, they will give a proper certification for the IQs. Okay, so next. Okay, next. One more thing will be okay. So இப்ப பாத்தீங்கன்னா இந்த ஸ்பெஷல் பாப்புலேஷன்ஸ் இருக்காங்கல்ல, the Tamil Nadu government they are giving this kind of opportunities. Okay, first thing, they have a disability employment exchange is there, special populations, then caretaker fund. Every month the government they used to provide 10,000 rupees, and if the particular special population is there, okay, the special population they cleared a 10th standard, every month 600 rupees will be there, and they cleared a 12th standard 750 rupees, and if they complete a degree 1000 rupees. Though the amount is very less, that will be a boost for their next kind of educations. And they are providing the hostels for the special populations, that is a physical as well as the mental illness, any kind of illness, they are providing the hostel facilities for the special population. Next. Disability after marriage. So for example, one person they are disability, okay, once they involved in the marriage activities, either the husband or wife they got divorced, okay, again the ward scholarship is there. Next, disability matrimony, the government they used to provide 60,000 rupees for that particular marriage. previous slide. ஏன் இதெல்லாம் நமக்கு தெரியணும் அப்படின்னா caregivers இருக்காங்க, caregivers they are having a number of financial issues, a number of discomforts or depressions in our state. Okay, இப்போ பார்த்தீங்கன்னா இந்த மாதிரி ஸ்கீம்ஸ் எல்லாம் எக்ஸ்க்ளூசிவ் ஃபார் அவர் ஸ்டேட். மற்ற ஸ்டேட்ஸில் இருக்குது, பட் இந்த மாதிரி எக்ஸ்க்ளூசிவாக வந்து ஸ்பெஷல் பாப்புலேஷன்ஸுக்கு நிறைய இருக்கிறது நம்ம ஸ்டேட்டில் மட்டும்தான். ஒன்லி இன் தமிழ்நாடு. அகெயின் இஃப் தே ஆர் இன்வால்வ் இன் த பேரா ஸ்போர்ட்ஸ் state event, they have secured a medals. For example, gold medal 5 lakhs cash award the government will provide, and for a silver medal 3 lakhs, and for the gold medal 2 lakhs, bronze medal 2 lakhs. So 2 like that lakhs for a state event and national event. If the same athletes they have won a medals in an international event, 20 lakhs, 10 lakhs, 5 lakhs. அப்போ நீங்கள் ட்ரீட் பண்ணுற ஒரு ஸ்பெஷல் பாப்புலேஷனை ஸ்போர்ட்ஸில் இன்வால்வ் பண்ணிங்கன்னா ஈஸிலி தே கேன் ஈவன் கெட் அ வெரி குட் கேஷ் அவார்ட்ஸ் ஃப்ரம் த அவர் கவர்மெண்ட்ஸ். ஓகே, சென்ட்ரல் கவர்மெண்ட்டும் ப்ரொவைட் பண்ணுவாங்க, ஸ்டேட் கவர்மெண்ட் ஆல்சோ தே யூஸ் டு ப்ரொவைட். இப்போ சொன்னது எல்லாமே ஸ்டேட் கவர்மெண்ட். Again, along with that, if they secured a good medals in the international aspect, central government also they used to provide a money as well as they give a job opportunities. Okay, so these are the various benefits for the special population from our government. Okay, central as well as the state government. Next. Okay, here is Mr. Sree. He is the first. Okay, he is the first multiple differently abled person athlete. He swim from Sri Lanka to Tamil Nadu. Okay, he is the first person. So almost 30 kilometers. Okay, that distance, and he covered within 20 hours 20 minutes. இதில் என்ன அப்படின்னா they having a cooling phase. எவ்வளோ நேரம் வேணாலும் கொஞ்சம் ரெஸ்ட் எடுத்து they can swim. But this person he didn't take a rest at all. For 2 or 3 places, 2 or 3 minutes, that's it. But he is a differently abled person. So we want to identify their potentials, we want to identify their skills, and we want to put them in a proper sports. Okay, so that is in your hand. Whether you are going to give a long only the treatment, or we want to give their another scope of living in the society. Okay, next. So these are the things we have seen. So we saw about what are the key challenges in the particular special population in the society. Then what are the schemes provided by the government, and what are the what is the Paralympic sports history we saw. Then we saw about what are the types of Paralympic sports few things, and inclusive criteria about the 10 criteria, and what are the athletes evaluations. Okay, so if you want to make a changes for any kind of special population you are treating, just assess their different abilities and put them in right sports, so that you also get a good satisfaction that you know the special population in a proper way. Okay, thank you. Any queries regarding sports or schemes?
So many a times here, especially in Coimbatore and all, there are a lot of sports academy and all, but they refuse to take our kids. So do you have any contacts, or there are special people who are interested in dealing with special population so that we can refer them?
Yes ma'am, actually right in Coimbatore many athletes they are participating for a Tamil Nadu as well as for India they are representing. Most of the people are from spinal cord injuries. Okay, again the intellectual problems people are there. Sure, I will give a contact to you.
Thank you, sir.
Okay, so most of the people from Coimbatore, 2 candidates, whenever they are participating in any state or national event, she used to secure a gold medal. She used to participate in 3 or 4 events, and 4 events she used to get a gold medal only. Okay, so almost some 10 to 12 para athletes are there in Coimbatore. Okay, I give a contact for sure. Any other queries? Okay, so I think any queries is there? Okay, thank you so much. Thank you.
We acknowledge with gratitude Dr. V.D. Vincent Gerard, sir, for the enlightening session. May I request Dr. K. Naresh Babu, sir, to present the memento as a token of admiration.
Delegates are kindly requested to scan the QR code and fill the feedback form. I repeat, delegates are kindly requested to scan the QR code and fill the feedback forms.
For many children, technology is a toy, but for a child with autism, it can be a voice and a lifeline. Dr. Abirami M.D. Ortho, HOD and Assistant Professor, Institute of Occupational Therapy, Mangalore, Karnataka, has joined us to share her passion for how innovation can create a more inclusive world. Her dedication to enhancing participation reminds us that every child deserves a seat at the table. A very warm welcome to you, ma'am. The stage is all yours.
Delegates are kindly requested to scan the QR codes pasted in the walls and fill the feedback form. I repeat, delegates are kindly requested to scan the QR code pasted in the walls and fill the feedback form. Thank you.
Hello. Good morning. Everyone is sleeping. Get up. Good morning. Okay. Good afternoon all. I am Dr. Abhipsha. So today I am going to discuss about autism and assistive technology. Before to that, I want to know how many of you are from first years and second year? Like BOT, everyone is BOT? BPT? Speech? So only BOT students, right? Can you raise your hands who are from the first years and second years? Okay, you know autism? What is autism? You have done the presentation today also, right? So can anyone from you, from the audience, can come forward and tell me what is autism? Then we'll move forward. Anyone who raised the hands from the right side? You want me to come there? Can you pass to anyone? First year students. I have come to your college. No, you have to also speak. All are sleeping from the back side. Just right there. You give the mic to them. Just briefly tell me what idea you have for autism. From morning you have like more sessions you have already attended, right? So just briefly tell me what you understand by the word autism. Yes, your name?
In mic also it's not audible. Please introduce yourself, from which college, which year, and then explain.
Ma'am, I am Sukumar, BOT final year, Devi Institute of Autism.
Not final year, first year or second year students.
Okay.
If nearby to you any first year or second year is there, then please hand over the mic. Yes, please introduce yourself. Yes. Your name, from which year, which college, and then you explain.
Good afternoon, ma'am. I am Abirami Devi, College of Occupational Therapy, first year.
What is autism? What idea you have for autism? You have presented today also, I guess.
Yes, ma'am.
Yes, please tell. Anything, whatever idea you have.
Autism can be defined as autism spectrum disorder. Autism is a neurodevelopmental disorder, which can be, it is not a mental disorder, which cannot be cured. In this mainly it is mainly affected the people, all children, maybe for the communication and for the communication for their daily living activities, and their mental disorder and mental activities for their studies, focusing activities, but it can be corrected by occupational therapy and other treatment, madam. Initially we can diagnose it at the third year. Recent research according to third year it can be diagnosed as finally as an autism or not. That's only, ma'am.
Yes, thank you so much. Much more information she is having today in presentation also. She has performed very nicely. Okay, so what autism is now as an identity, I guess, right? Whenever someone is asking what is autism or what also, what now is we are telling, we are treating autism rather than stroke. Now we are more focused on this SI, wedding therapy, we are treating autism, ADHD, many things we are telling. So before starting, I just want to tell you about the sensory processing, because even it is autism or any parts of the sensory process someone is having difficulty, then what is the problem actually? Just one small example, then we will start. Okay. So now I will ask someone to stand. That means what you will do? You got that information, your mind processing, then the mind is giving the information to the legs. You have to use an action to make your stand, then you are standing. This is the whole process, right? But we say to you stand up, within just fraction of second, you get and you stand, right? That means how fast your brain is working. I said you took the information and you processed it, and again also you have made this an output, correct? That is what actually the sensory processing, right? Whenever like someone said me that I couldn't understand. Any information from the environment is coming to me, I couldn't understand only. Or else I am able to understand, but next what I have to do, that I am not aware. Or else I know, okay, what I have to do also know, and what I have been asked to do also I know. But how to do that one, that also I don't know. Either in the input, in the processing, or in the output is the problem is happening. That's what is your sensory processing disorders issues. So out of that one small area of autism, where it's not compulsory that all autism are having all the problems like processing or output. Okay, it can be anything. So now today, before starting for this assistive technology, we'll just briefly start about autism. What are the main areas that are there where the autism people or autism kids are having the difficulty to deal with. Then we'll start about assistive technologies. You know what is assistive technologies, right? What is technology? Technology means what? You all are using now phones, right? You all are Gen Z people, no? Now you are in like higher version of us. You all are using AI, chat GTPs, Gemini, these and many things are coming, which even like I guess we are aware about 10% and you are aware about maybe 80%, correct? That is also a part of your technology only, right? So using the technologies, how we are going to treat autism or help autism. Can you treat autism? First question. Yes or no? Who said yes? That is fine. We'll discuss. Who said yes? Can you treat autism? Treat in the sense cure. Can you cure autism? No. So as an OT or even physio or speech, what actually we are doing with autism people? Something we are doing, right? What actually we are doing? What is our goal? To help them to make everything independent, right? They should be independent either in ADL, whether in school, whether in work, or whether they are in a social gathering. Correct? So that is my topic today. So like what is autism in assistive technology as an occupational therapy or other professionals, how we are going to help them with different technologies. Is it ready? We can go to the next slide. Just a brief introduction I have given, what are the characteristics and all. So now autism we discussed, right? She has explained so deeply that what is autism. So first thing, as an autism, if someone is having autism, what is the first thing that you will observe? Like now we are around having 150 students? More than 150. Okay, so now more than 150 students is there. Like any one boy or girl will come. What you will observe in them, and you will conclude, I guess they are having autism. What is the first thing you will observe? What? Communication. Eye contact. Okay, so now whenever they will come and they will look at you straight and they will walk. They should walk. I don't think so. When I came, I didn't look and eye contact to you. That means I am having autism. So you will diagnose me as an autism? Yeah, this is the first thing, what you will observe. In any one person, how they are behaving in outside, right? Whenever they are out of the comfort zone, or when they are with people surrounding to them, how they are doing. What is a normal behavior? Or normal interaction means what? What do you understand by social skills? Social skills means what you understand? A good social skill. How you will rate? I will come, I will greet to you, maybe I will look at you. That's what you mean by eye contact, right? I will look at you. The next one? Whatever you are telling me, I will respond. It can be any kind of communication. I doesn't have to speak. I can just say yes. Or anything I can ask you what is your name or something, any kind of communication or information you are exchanging, right? So these are the basic common things you are going to observe. So now here in autism, that is what I have mentioned, basic social communications, behaviors and eye contact. These are the basic things autism child or people. It's not about only kids. Do you know that we can have 22 years of autism also? Anyone till today have seen adult autism? Anyone? I guess one 4th year student has been just now stood, right? 4th year. You have seen 22 years of autism? Any person who is diagnosed with autism and his age is 22 years. You have seen? You have seen. So how you understand what is the features you have observed? Is there anything you have observed like in communication, social and behavior? Tell me, otherwise you guys are sleeping only backside. You tell. Like a 22 years of autism, what you are expecting? How they used to look like? Is it like us, normal, a person?
Ma'am, some sensory issues are not treated in the childhood stage, will develop the adult autism.
Just now I said, right? You can't treat, you can't cure. If you diagnosed one person or one child at the age of 5, at the age of 22 also, the diagnosis is still same. Percentage, severity, that level will be reduced. But you can't do that change, right? Like autism will be stopped. Now you are fully free of autism. Like you said, you are free of cancer. Can we say that? No, right? That means autism is like something throughout the year, throughout the day, life, it will be with you. Because these skills were communications, behaviors and social skills, it will be throughout the years you need. Okay? You can tell them or you can help them with the strategies, compensation, how to deal. If you have a difficulty to look at someone, what to do? Some strategies. You can look at them, then look down or distract yourself, or else you use some aids like we are going to discuss one by one now. So like that, some strategies or some assistive devices you can give, so where these areas can be managed. Okay, next slide. Next. So now as we discuss about assistive technologies, or let's stick to the assistive device first. Technology means you understand, right? Phones, websites, whatever you are seeing as all are technology, which is invented for our betterment. Even we are using assistive technology for our betterment, right? That AI you are using. Like example, today you came to the college. Your class in charge, like example, we will take Soundarya ma'am. So Soundarya ma'am will tell you today, students, you have an assignment. Write what is autism, what is assistive technologies, and how we can help assistive technology for autism. Then what you will do? Same information now, what you are doing? Type, sent in AI. Whatever answer you are getting, you are writing. Nowadays is happening, very, very common. We have seen many times. Correct? So you are also using these assistive technologies for you, but in a different way. The same technology you are using to reduce your workload. Correct? Who will read book? Who will ask? Who will remember what has been taken in class? So instead of that, one phone you have taken, net on, then this type, answer got, answer has been submitted to ma'am. Correct? That's what is your technology. You have used any device or any technology to help yourself to reduce the workload or to simplify the workload. It can be said like that. Same for the autism. Whatever difficulties they are having from the morning, I guess 4 or 5 sessions has been taken, right? Many difficulties. Now you are loaded with what the autism kids are having difficulty. So now how we are going to help them with using the assistive technology we are going to discuss. Next slide. Okay. First thing, what is the benefit? Why we use, because we have different like sensor integration therapy, now vestibular rehabilitation, these, that, many technologies are there. So now out of that, now this assistive technology is very, very important because slowly everything is getting changed. Even parents will come to you, we heard about this technique. We heard about this therapy. Can you use it for my kid? This is the basic common question, I guess, whoever in the clinical areas and practicing in clinics, I guess ma'am can relate much because parents are more educated than you. Though that information they are gathering from different sites. If you are thinking they are coming to you only, that is not truth. They will go to a different or 10 multiple therapists, they will gather the information, then they will come to you. We heard this therapy or this technique is very important. Now it is getting like 100% chances are there. My child will talk, my child will do this, that independently. Can you use it? Or they might have seen somewhere, someone has used something for someone else. Can you use for my kid also? Very commonly they are doing these things, right? So like what is the benefits are there for the assistive technology? First thing, like we are going to promote independence. Independence in the sense, how we are going to promote independence? Let's stick to the childhood of autism, then it will be easy for you. A child in the age of 7 years to 8 years, what are the things he will do on a regular basis? A child will take that girl who is sleeping. Please tell. A child of 8 years, what are the walks are there? Regularly after getting up in the morning, what are the things they are doing? You pass the mic, that girl who is sleeping. Whoever is sleeping means I'll ask questions then. Normally a 7-year, they are not going to the office and they are doing some work, right? A 7-year-old child with autism or without autism, what is the function? What they used to do? That. With specs. Give to someone, now everyone is awake, no? Give. Yes. 7 years, this is common question. 7-year child, what will do in a whole day? 24 hours without like, rather than sleeping, what is his schedule? Give, who will answer? Ma'am will give ice cream after that. Stand up. Stand up, anyone. Don't waste time. Fast, get up and say. Or else we'll move. Or else you can give the mala to Bala. Bala, please. A 7-year child, regularly in a day, rather than sleeping, what will be the schedule? Please.
After waking up, daily routine.
Yes, ADL.
Self-care.
Yes.
Then, based upon age, he will be going school, special school.
Yes.
Then after follow-up school, he will be having any therapy classes.
Okay. Then?
Maybe evening time, maybe play.
Play, yes. Then coming back after same cleaning, dressing, everything. So these are basic things, right? So where all the occupational all the occupational performance has been used. ADL, then play, then work, correct? These are the basic things from the first year's occupational performance model we have discussed, right? Same thing, only same autism, whoever having, without autism also, they are doing the same thing. So now, if we are using this assistive technology, someone is having difficulty to hold the brush. What we are going to do? First, okay, we will give the training to hold the brush. But now the child is not cooperating, first thing, because kids and all is very difficult to handle. Correct? And that is also with autism means morning how they are getting up, whether they are in a good mood, bad mood. Next thing, whether they know the process. The cap they will open, they will put the paste on the brush, then they will do cleaning, everything. It's a whole process, right? Brushing doesn't mean like take the brush. This is not brushing. Brushing also has different steps, correct? So these all the things we can use the assistive technology to make them independent. Second thing is to build confidence. You have seen any autism case who are having speech impairment? I guess 100% you might have seen, because nowadays I guess the autism or ADHD also, ADHDs have very less the difficulty in the speech will get, but autism means they have echolalia. You understand echolalia? What is echolalia? Repetitions. Repetition in the sense a same word for a multiple times they are repeating. Whenever they need something also, multiple times they are asking. They are repeating things, right? Echolalia. So now for the speech, how we are going to use this assistive technology? We have different aids. I have added pictures also. Different aids are there. Different devices are there. It can be a simple to higher technology. We can use multiple things. Using that, we can give them, so where they will get the confidence to communicate, not speech, communication. Here communication, we can make them speech, like speech is not there, we'll give some aids, now they will speak. We are not talking about that. We are talking that communication which they don't have previously, using some extra device or additional device, they can communicate. And that can be a non-verbal communication or gesture wise also. I'll show you some devices, then you will understand. Okay. I guess this thing, that's the basic. We'll move forward. So now divided into these assistive technologies, many things are there. Out of that, please focus on these 3 terms: low tech, mid tech, high tech. Then last 2 we'll discuss later. Low, high, mid. Low means, low tech means you bought one micro oven. You don't know how to use it, right? What you did? You will remove the cover, you will open the manual. You will see that was some part of your low tech. Okay, any kind of pictures, any kind of cues, anything basic on a card, on a printing, any flashcards you are using, that is all coming under your low tech. or let's talk about low budget, that techniques, okay. Next one is your mid and higher. Mid higher is almost similar, but how we are going to differentiate? Now we are having, I guess everyone is now having iPhone, correct? iPhone, now you are busy. What you used to do? Hey Siri, call to that person. Hey Siri, open. And even I guess, I don't know whether you know or not, Instagram is having a feature, automatic scroll. Are you aware? What? Are you aware or not? Whoever is Gen X, Y, Z people generation, you are aware? If you are not aware means you are coming in our generation. Okay, so now Instagram is having its own feature. If you are tired of scrolling, there is having an option. How fast you want to scroll? You want in 1x, you want in 2x. Many features are there in Instagram. That is what is your technology. People are having who is not, doesn't know how to scroll and all, so they have an option. They'll use that even using the voice. Instagram, please open Instagram and go to there, click this button, right side, present this. You just have to give information. And whenever you might be thinking, right, autistic people, they don't know how to use, then how this assistive technology can be used for them. When I said they are going to use it, that doesn't mean they have to set up that full device. You can set up for them, let them use it. Okay, not for Instagram, for study purpose or any educational or anything like independent like phone pay, GPay, something like that. Okay, so this is all about your low tech and high tech. And whenever we are talking about high tech, I have some pictures. You just see that pictures and let me know whether you have seen in your lifetime that pictures or not. Can you send the next slide? Yes. This one you have seen? Anywhere in your whole life, these cards, this kind of tables or something? These things, flashcards, you have seen, right? Whenever, if you are going to the clinicals, then you might have seen. The first thing as an OT or as in speech language pathology or physio, if you are dealing with kids who is non-verbal, this flashcard is the first thing we used to buy for ourselves so that we can communicate with the child. Okay, this is the low-tech things or the low-tech assistive device we use for the autism. Okay, next slide. You can change. Change. Pictures, you go to the pictures. Just go to the pictures, then again we'll come back. Go to the pictures. Pictures. One more. I guess after 2 slides. Okay, just wait. So now few things are there. I have put for autism also and for not autism also, so that you will understand what is assistive technologies. This one person is you cutting something, right? So now he is cutting with the right hand. Potato is in right hand. He is using one instrument here. Can you tell me what can be the problem that that person is using this assistive device? Yes. Anything? What will be the suggested problem, or what do you think? What will be the problem that we have given these aids to them? Anyone? Any suggestion? Whatever you are thinking. Poor grasp. Yes. It can be. And hand function is. Yes, hand function or fine motor difficulties, or even we can say strength wise also. So for these kind of things means we can use these kind of assisted aids, but it's not compulsory that you have to use for the autism. Next slide. Okay. These are the basic assistive aids for the kitchen. Okay, because whenever we are discussing about autism, it's not about the kid. It's about a lady who is working in kitchen, whether maybe a male who is working in the kitchen, if they have any difficulties in the process or any steps they want to eliminate. So these are the basic things they can use in the kitchen area. Next one. Same. Next. Okay. What is this one? Normally for autism we never use, but can you tell me what is this one? This is for whom I can use. There are some bars are there. Anyone? From the back side, anyone? No need to give. They won't speak. Anyone from the back side? Pink color shirt. Yes. You are visible from here. Please get up. What is this? Shh. Let him speak.
Toilet.
Whoever is talking.
High-seated toilet.
This is for?
High-seated toilet which is used for a patient with a stroke.
Okay. Tell me the problem, not the diagnosis. Problem.
Okay, the problem is they can't able to utilize the toilet by their own, so they can use it for.
It's audible but not understandable. What you are telling?
Okay, sorry, ma'am. I'll repeat again.
Yes.
There's instrument is high-sitting toilet where a stroke patient or a bedridden patient will be using, and it's used to only because they can't able to do their toileting by their own, so they follow it.
Yes. For the, like, we are doing environmental modifications and washrooms. What is his name? Name.
I'm SenthilKumar from Radiology Institute of Occupational Therapy.
Okay. So, yeah, done. So now this is as he has explained. So this is we are going to clearly use for the stroke patient who are having high sitting position. Is that correct? Correct. But here for the transfer also they have given options. Environmental modifications they have done using assistive technologies. Now one more question. This is low tech, mid tech, high tech. What is it? And why? Where you will put this one? This category you will put into where? Low, mid, high. No, nothing? Not coming under assistive device? You are aware about adaptive devices, assistive devices? Okay, anyone else? You are aware, right? No, if you don't know means I'll tell. Yes? Yes. Okay, anyone who can say? Okay, adaptation assistive device is almost similar. Here, what has been done? Normally, one pan is there. It is situated in the washroom, right? Any person who has difficulty to transfer to this one, what bath, or if they have difficulty to sit independently, like Parkinson's, stroke, any muscular or any neurological conditions, where they are dependent on the caretakers to transfer, to sit independently for every purpose. So this one can be used for them. Is it possible to use for autism? For any type? Any chance we can use it for autism? Yes? Autism doesn't like the child or the person is only diagnosed with autism. No, it can be diagnosed with any other neurological conditions like cerebral palsy, motor neuron diseases, muscular dystrophy. It can be anything. Along with that, if any child or any person or any adult is having autism, means we can use this one. Okay, next one. Next. Okay, what is this? You have seen kids with autism, for buttoning they have problem. They used to wear up, down also sometimes. Like this button is fixed with the lower one is very common. In movies also they used to see lack of attention, they used to do like that. Or they are very severe, they used to do. Or else sequencing is the problem, where it is a part of your cognitive process. Or cognitive skills are impaired. Not difficulty, but it can be impaired. Because not everyone is having the impairment, right? So if cognitive impairment is there means, or the processing impairment, sensory processing issues are there, then for them also we can use. This is used for, what is this? Buttoning device, okay? Normally you have to put it inside, hold the button and through that hole only you just bring it back. Your buttoning is done. Next. This thing is not there. Next. Okay. Are you aware about these things? Okay, let's talk about this thing first. What is it? Wheelchair. A normal wheelchair? No. What is then? What kind of wheelchair? How many types of wheelchair you know? Eh? Anyone? What are the types of wheelchair you know? You give to a nearby, anyone, whoever is sleeping. Okay, not sleeping also we can give, right? Give to the first, second girl. Here, ma'am. Blue color dupatta. Please. Just what are the wheelchairs under, you know. We'll move forward first, tell. Okay, this is what is it? Wheelchair, right? It's used for? It is used for wheelchair. It's used for?
Mobility.
Mobility. Okay, what kind of mobility? Or a patient, like when you can give to someone? I am having pain in my ankle. You will give me this one?
No.
No. Then? Anything you know.
Unable to walk.
Unable to walk.
Can't enable to walk.
Use the mic.
Enable to walk.
Unable to walk. That's what I'm telling you. I'm not able to walk. You will give me this one? Then next person. Quick, you are sitting in the front bench and you are using phones. Tell. Anything you know. Okay, fine. So now these are the some things that you can use for the mobility purpose, and this one just a manual. It can be used with advanced technology like some switch, the joysticks where using like we don't have to propel, or else you don't have to pedal also. Using some motorized option, you can develop into an advanced person, and that person can be independent. Okay, next slide. Next. This is the very important point that I have prepared for you, because whenever we are talking about autism, and we always teach, right? Autism means we will do occupational therapy, speech therapy, and one more thing is coming, special education. From my aspects, I guess it is all a team work, right? If we give 50%, someone else is doing their 50%, then only you are doing together as a teamwork to attain something. So now, whenever you are giving therapy to any autism, using assistive devices, there are many options are there where you can use for the communication in school, in any common, like in a playground, they're communicating to other kids. There are many options are there. I have added some pictures also. Please change the slide. Okay. Did you know about this device? Let's forget the name. Just tell me what is the purpose or where you can use it. Because different company, different names will be there. So let's not stick to the name. Just function. Where we can use this one. I have just mentioned high and one something side high. That means what? There are some devices are available in the market already, but cost is little different, like little, not little, much more higher, but there are government sites are there, through government NGOs and all also you can avail this one. Here options will be there. You can change these options, you can customize this. Okay, based on the customization like hi, how are you, name, like this, some modification you can do. So whenever they are going outside, and this is the speaker. Okay. You don't have to type and use show. It is not like that. This one will be with the child. Okay? Whenever he wants to say something, means he can just click that picture. But for that, training is needed. Normally in OT, as well as in special education also, we provide this training purpose. Okay? So now whenever they will click, that sound will come. That sound has to be loaded by someone else. Okay? That will be fully customized. Then it will be prepared. Okay, for the communication purpose. Next one. Have you like seen this one somewhere in your whole life? In anywhere, keyboards, where? Whenever you are buying nowadays, I guess MacBook or something also, I guess these options are there. Now I guess Lenovo also have the options. Whenever you are having any kind of disability, if you want to use this option, then for this, whoever the deaf means, it will be coming the content. Whatever the sound, whenever you are seeing, right, some videos, whenever someone is talking, nearby one small box is there and someone is doing sign language. You have seen everywhere sign language interpreter will be there. It's not possible sometimes, right? If you are deaf, you are not able to listen that sound. So that option you can create. So you just have to click it and it can be customized. Any IT people can make this one. Okay, this is a software. You just have to install it. Okay. Once you click the options, everything will come in a writing in the side. Okay, so whatever that in video it is playing in the background noise, everything will come in a written, like writing format, it will come. Okay, the options are available in the market, but yes, cost is high. If you want means you can contact, like you can search in the websites and all, and I guess in Tamil Nadu, there are many like organizations are there. Autism, Excellence of Autism, I guess in KK Nagar it is one. You can contact, or else you can contact the Museum of Possibilities nearby to the Marina Beach. Okay, they have the contacts where you can do this all customizations. Next one. This one you know, right? Alexa, Siri, whatever features in your phone you are using, this is also a part of their assistive technologies. Next. Okay, this is you know, right? Normally how the joysticks and all has been used, color thing also they used to change for the low visions and all. Yes, next. Okay, this is very little costly, but this one now even in Amazon is also available. Okay, screen readings and all. If someone is having difficulty with the low visions or something means, you can use this one just to dictate like this, it will come. Mostly this is used for the whom? One book with tricolor thing embedded used there. Braille, yes. For them also, if the person is having difficulty to hands or something is using this instrument, we can read. Because Braille reading and all, it is time taking. For exam purpose or something is, you can use this one. Automatically the sound will also come. Okay, next. Next. This is all I discussed next. Okay. These things under you know, right? Magnifiers and all for autism, low visions, everywhere you can use it. Okay. So now for autism performance, there are many areas you discussed, right? Playground, washroom, school, classroom, whenever they are at home, living room, everywhere, or in the market, or it can be a mall. Okay, wherever they are going, some areas as an OT, we can provide different types of assistive devices and you can make them independent in every aspect of life. It can be social communication, it can be ADL independency or self-care independency or at school also. Majorly this assistive technologies now in the inclusive school and special school, the providence from the government side only they are giving the providence, but you have to go through the proper channel to get all the things. If you are running a special school, you need you are having 100 or even 10 people with these problems where this can be helpful to you. You through proper channel you can apply and you can get it also. Okay, this is the overall about the technologies. Can you just next, I guess some pictures. So now this is the Apple version that I said, using the voice and the eye tracking. The options are there. Okay, using normally your eyes, wherever your eyeball will go, the screen will move. Okay, next. Next. Yeah, next. Yeah. Next one is what are the limitation. First thing already we discussed, right? Cost, money. Second thing, manufacturing. Not everywhere it is available, neither everyone is producing this one. Very like less company are producing because of the cost based on that productivity is also less. Even if you need, you have the money, but it's not available. For that you have to wait for some times. So the availabilities and the cost is very, very higher. And the last one is your how to use properly. If you don't know, training only is not that. I said, right? If you are giving something, you have to train them, then only they can use the device, right? You are not giving any training, neither you are trained to give the training to them. Like majorly special educators used to train these things, and for that special courses are running in different national institutes also. Okay, this is the problem. The people who are training also, they are not trained or qualified enough to train the kids. So then that is the purpose of assistive device will reduce. Efficiency will be reduced. Might be they know only to use to communicate, but maybe they can use for the education purpose. But the purpose of the, like how to use a tool properly with the efficiency, that has to be there. Okay, next slide. Just one case example I put so that overall whatever you understand we'll discuss. We'll choose one person from the back side. Yes, you stand up, right? He left also. Can you give him? Yes, right side. I don't know, what black color shirt? Black, blue, green, something he is wearing. Nearby to the white. Yes. This small, you can manage, don't worry. Nothing home, like different signs that you can't tell. So now one, just example. If you can't answer also, it's fine. Okay. So one child is there who is diagnosed with autism, and the major problem is the communication. Okay. So now tell me, I have mentioned also AAC app and visual schedules. You know AAC? AAC. I have told you AAC. You know the name? Say AAC. Anyone? I have showed one blue color picture. Yes. Someone has lifted the hand in the back side. DOT final year student. Yes.
Augmentative and alternative communication division.
Yes. That is used for? That is used for? That is used for what?
By visual cues we can communicate. No?
You, just now you Google it?
No, ma'am.
No. Sure.
No.
AI?
No, ma'am.
I have asked question, you might have checked the question to the same AI? No, right? Okay, this is a communication tool. That same like the blue color thing, it is written, same that one. Okay? If one person is having a normal communication, non-verbal communication also affected, so for them we can use AAC app. If you can't buy their product, software also available. In the Play Store, you have to open, they need some, I guess, permissions and all. You can apply if you have the disability certificates and all, then you can proper channels are there. It is little lengthy process and some money. But using your normal phone, you can just have to install that app. Then normal your AAC will be in your smartphone. Okay, you can use it. So there's this much of advance now in India or outside India is already there. Assistive technology is not a small word. Now it is a very big opportunity to everyone. So as you are all coming to the profession of OT, please kindly check. Now you will be doing your research work. If possible, your college is permitting, I will like to request you, please go to the assistive devices for your research purpose also. Thank you so much. Any questions? If you don't have question means I will ask question. No question? That side, any questions? You have question? Yes. மேம் நீங்க ஒரு டிவைஸ் சொன்னீங்க மேம், அந்த ஹியரிங் எய்ட் மாதிரி அவங்க வந்து
தமிழ் கொஞ்சம் கொஞ்சம் தெரியும். சரி, கொஞ்சம் ஸ்லோவா பேசுனா நான் உங்களுக்கு தமிழ்ல ஆன்சர் பண்ணுவேன்.
When you said right that keypad have that hearing.
Yes, in Tamil, I can understand.
அப்ப படிக்க தெரியாதவங்க என்ன பண்ணுவாங்க மேம்?
Then you have to train them, no? The question is how to
sign language மட்டும் தான் தெரியும் அப்படின்னா படிக்க தெரியலைன்னா அந்த இதுல வரும்போது அவங்க எப்படி அதை புரிஞ்சுக்குவாங்க?
Yes, that's why the special education profession exists. Everything you can't teach something. That's what is a overlapping. I know something means I will teach you this. This is not going to happen. You have to something you have to hand over to the other profession. It's a rehabilitation team. You know, if you want your child to train with some basic alphabets, basic colors, which will be important for your that assistive technology, you can start with the basic flashcards, but you have to take help from your special educations. They have different more higher level assistive technologies where they can use this basic whatever requirements are there, they can run that process very easily. Okay,
thank you.
Everything we can't do. It's a team. We have to take and we have to work in a team. If autism means it is not my patient, it's our. Like means if I am working, then attention has to work from other areas. Okay? You want me to translate? You understand? Yes, thanks. Any other question? No questions? Yes. How come one physiotherapy student is here?
Okay, ma'am, the main thing is the assistive technology. How can it be reliable for the patient with autism? And it's need to be built in a specific manner. That and how reliable. It's a reliability.
Reliability, right? See, when the nice question, and I like to answer is also very like frankly. Any devices, whatever is coming to market, is not like today I have invented. Okay, let's sell. It's not work like that. Something someone has invented, it has the process, reliability, validity for your research paper. Something you are writing also, validity, reliability you are checking, right? Any instruments also you are using, like your gonimeter. Every instrument has their own reliability and validity. If you want to use anything and you want to check whether it is reliable or not, in the website, in the manual, everywhere, the reliability and validity scores along with the data is mentioned. Okay, every instrument has their own reliability and validity. On the website, on the back side of any kind of manuals, you can get it. Yes? Any other questions? This side, no question? Okay, thank you so much.
We are grateful to Dr. Abirami for sharing her valuable expertise. May I request Dr. Periyaswamy sir to present the memento as a token of gratitude. We have with us someone who helps us understand the silent language of senses.
Hello. Sorry, just last 1 minute. Thank you so much, Naresh sir. I guess sir has called me 3 months before that you are planning one program. Are you available? It's been like long process. I don't know how much you guys planned, but Dean sir and your faculties are planning for a very long time. So thank you so much, sir, for giving me this opportunity. Thank you so much.
நான் ஸ்டார்ட் பண்ணவா?
We have with us someone who helps us understand the silent language of senses. Mrs. SenthilKumar, PhD scholar, speech and language pathologist, managing director and speech and language pathologist, Satgamaya Speech Rehab Center, Coimbatore, who does this beautiful work of helping children find their place in the world that can often feel overwhelming. A holistic and sensory-led approach is a gift to speech and language community. Let's welcome her to share her valuable insights. The stage is all yours, ma'am.
Thank you. Am I audible? The last seated ones, can you hear me? Raise your hand if you can hear me. Sure? Okay. So, I think she introduced me already. I am a speech language pathologist. My name is Arya. And today, I'm very glad to be here because here I'm in front of future occupational therapists. So you people, I think will help me a lot in my future way in giving therapies for children with autism. Because whenever I come across a child with autism, the first thing I ask them is the child attending occupational therapy? Because without occupational therapy, I find it really difficult to make my children communicate. Okay, so here I am explaining you how speech and language development is important in how sensory integration is important in speech and language development. Okay, so since morning we are listening to only one word, autism, autism, autism. So I think I need not explain the definition for that. Already ma'am had made someone to explain, so you all know. But I want someone to answer me which are the areas which is affected in autism. Can someone tell? Since morning we are listening to this. So, someone. I find it first years, second years, third years, fourth years, anyone. Come on. Should I call out or you people will be answering? Which is affected in autism. Come on. Anyone? So many of you, one person can tell. Core areas which is affected in autism. Since morning we are listening to it, so I'm sure everybody should know it by now.
Yeah, hi ma'am. My name is Tabia from Devi College. So social communication, social interaction, sensory issues, behavioral issues. Next slide. So sensory issues, earlier we were not considering it very important or as a core areas in autism. Right now in diagnosis and research is giving a lot of importance to sensory integration. Now you might be thinking, she is a speech language pathologist, why is she here telling about sensory integration, that too to us OTs? So here I am not telling you the importance of sensory integration. I am just making you aware how sensory integration is actually affecting communication, so that in your future practice, you people will be able to give me a proper guideline so that I can take my session in a better way and provide speech therapy could be beneficial. Because without attending to it, the sensory needs of a child, it would be very difficult to make him communicate. Okay, so prevalence, incidence, I think since morning we have seen many a times. So again, I'm not going into the details of that. Now sensory processing, some fundamentals. I've given it in the slide. So hypersensitivity. Now can someone give me an example of a child or anyone you saw any kid you saw in your in your therapy who has hypersensitivity and what did, okay, hypersensitivity, give me an example, any one of you. I'm sure you people have seen children with autism because you have clinics. So give me one example where you see the child is hypersensitive to any size. Come on. Yes, someone. What is hypersensitivity? It is given in the slide. So, example, one single example. I think last people are chit-chatting. Are you? Okay, I'll tell someone who is keenly listening to me. The black dupatta, can you say? You. Come on. One example of hypersensitivity. Come on. Anyone else? Okay, behind her. You'll be sleeping because this is the last session. And no tea break yet. So come on. What is hypersensitivity? One example.
Gravitational insecurity.
What?
Gravitational insecurity. Vestibular hypersensitivity.
Okay, I said an example, a child having hypersensitivity, how does he react? In what sense and how is his reaction? If you are seeing a case.
The child having fear to stare up.
Having fear to?
Climb.
Okay.
Climb on something.
I'm saying hypersensitivity to senses.
Vestibular sensing.
Okay.
Vestibular hypersensitivity having the gravitational intensity.
Okay. So you feel the child is unable to?
Yes.
Okay, good. Hypersensitivity. Another. Another one. Hypersensitivity. Come on.
Hypersensitivity means reduced response to sensory input.
Okay.
Example, avoidance.
Avoidance what?
Avoidance to external stimuli.
Avoidance to an external stimuli. Give me an example, like what?
No response for name calling.
Okay.
Stares at bright lights.
Okay. Staring at it maybe. A very bright light. Next. Sensory seeking. Sensory seeking. An example of this.
They keep on running around a lot. Okay, it's on spinning of objects.
Okay. Next. So now the 7 sensory senses. Can I tell? Now you will be asking, she's asking us question because the initial few slides is about sensory integration or sensory systems, and I believe you people will know better than me. So, answer. After this, I'll take over. Come on.
Visual, olfactory, tactile, auditory, gustatory, proprioception, vestibular.
Yes. Good. Next slide. Now, auditory processing in autism. And as a speech language pathologist, this area is very important to me. I need to assess this in detail. Now, you might have come across children who have, she had told before that the child doesn't respond to name call. So why does this happen? Imagine you're going to a railway station and there is a lot of noise going around and someone is not listening to, and someone is talking to you in a very feeble voice. How tough it will be for you to concentrate. So our children with autism, they have a difficulty in discriminating a sound from the background sound. Maybe that sounds similar, all sounds equally loud, or they are finding it difficult to separate it from the foreground and background. So this is what happens. And if you see, auditory processing disorders is very common, or most children is affected with it. Now, this could lead naturally to speech delay. Now you have seen, next slide. Next slide. Back. Next. Okay, next. Now, so you have seen sensory issues, many sensory issues, but auditory processing issue is something which is directly related to language development. So before we talk about it, I need to explain to you what is language development and what is speech development. Now you might be thinking, why is language development different from speech development? Okay, so language and speech I have to categorize into two sections for you to understand in a simple way. Now, a child sees an apple, and in the environment surrounding him, maybe his mother or other caretaker is showing, okay, that's apple. Our situation was so the child watched apple. What will the child do? Child will look at it. He will keep a mental visual image of the apple in his mind, and he is listening to the mother saying apple. So he has to listen, process what the mother say, store it in his brain, and then he has got the concept that this particular object is apple. This is a part of language development. Now when a child is listening to the mother, paying attention to what she is speaking, all this will relate to a word generation in the brain. These cycles continue. Slowly, the child gets the concept that I see an object, mother or someone is telling or labeling it, and then he forms the concept that this particular thing is having a name. So once the child learned apple, second the child learned amma, third the child learned ball. So maybe till he learns 2-3 objects or 4-5 objects, slowly he is learning that concept that this particular thing is having a name. Now this is language concept. This will go hand in hand with your cognition development also. Okay, I'll come to the language acquisition theory where you know how this is learned. But for now, I think for your understanding, that's why I'm classifying this as language development. Now coming to speech development. Now speech is what verbally I speak out. I'm not telling about the processing part which is happening in the brain, but the physical sounds what we are producing. So we have different systems. One is the respiratory system, the phonatory system, the articulatory system, the resonatory system. And we have our brain and the auditory system, which is coordinating these things. Now how? Coming to respiratory system, we breathe in. Breath is the energy for producing voice. I breathe in. Someone who has difficulty, maybe you have come across stroke patients, everything. you have seen the physios working on chest physio, all this. We see the lung capacity. If the lung capacity is reduced, maybe you might have noticed the person is not able to speak for longer utterances, longer sentences. They will be very short, whatever they are speaking, because lung volume play a role. So they need to have good respiratory support. Second, the phonatory system. Phonatory system is your vocal folds. So when you have voice, voicing is nothing. If I am saying, this is my voice. Here I am not, still I articulated a sound, but still I have not formed any sounds, nothing. So this vocal folds or the phonatory system requires the support of the respiratory system to produce that particular sound. Okay, so that production, again it is interrelated. If respiratory support is good, then the phonatory system works. Now once the voice has come out, now I need to frame it into different sounds. Now we know there are different sounds which we combine together to form words. For example, if I bring my lips together, pa, ba, ma, all this, I just use my both lips. I have not used my tongue. But I am aware that both the lips came together. I produce the sound pa, ba, ma. I am producing the sounds like ta, da. If I say something from the back of my mouth where my back of the tongue moves upward and touches the back of my throat, then it becomes ka, ga. So these articulators, oral structures, are the active and there are passive articulators. The floor of the mouth, everything is passive articulators. When they come together, touch each other, we have word productions. So the sound is produced. Fourth, when I am saying this, there is a system which is telling what you produced is correct. What you produced is bat, not pat. So my auditory system is correlating all this together and then giving me a feedback. Oh, what you said is correct or wrong. And accordingly adjust. Another one system which I missed is phonatory system. Phonatory system is like, resonatory system, really sorry. Resonatory system. Resonatory system is like when you say a sound like na, you are saying it through your nose. The air you emit is coming much more from your nose and less from your mouth. But you say the sound pa, ba. The sound comes from your lips. Now why is this? Because you have something known as the resonance system and you have hyponasality in some cases. They speak through their nose. Hyponasality in some cases, they speak through their mouth and less through the nose. But again, there is some natural resonance happening because of the presence of this structure. If you see some children who has very enlarged adenoids, they are tonsillitis, very severe. You see their voice would be little muffled. They will be not able to produce nasal sounds in a good way. So all resonance system gives quality to your speech. So that is also important. So I think now you got the difference what I am categorizing as language and speech. Got it? I am sure your syllabus will have speech milestones. Okay. So after knowing this, I will tell you about the speech milestones in a short form. But more importantly, I'll focus on how language is acquired and how it varies in children with autism. Okay. Back. So here you are seeing from birth to 12 months, a newborn baby. I think at least not in your clinics, but at least in your house or some relatives, brothers' kids, sisters' kids, someone you might have seen a newborn baby. The only way the child knows to communicate with you is by crying, right? Any other opinion other than crying? No. So Slowly you'll start seeing, the parents will start understanding that the child is crying differently for different needs. Like if the child is hungry, the cry is different. The child is having some pain, the cry is different. The child needs something or some uncomfortableness is there, cry is different. So slowly we'll start having differential crying. After that, the child starts making pleasure sounds, cooing, all this. By 6 months of age, much before that, some children actually starts making babbling sounds. Slowly, this babbling also starts having patterns. Like initially, the child will say only one syllable repeatedly. Ba 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 ba. Slow or pa 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 pa, ta 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 ta, kind of. Slowly you see that even that is having patterns. The child will start saying pa ba, ta da ta da ta da, different combinations of sound. So this is how we call vocal play, how children play by themselves. They are exploring their articulators, they are getting all the sensory input themselves, and they are learning by this vocal play. Next, early words. So by 12 to 24 months, by 1 year, the child will actually start saying his first word, most probably mama. Okay. Now, when the child says mama, we can make sure, okay, the child has started understanding maybe the language concept. Slowly you see there's a burst of vocabulary. The child starts picking up new words in drastic speed. By 24 months, till the child is 2 years old, the child will actually start combining 2 words. Amava, Tanita, all this. Maybe the clarity is compromised because at this age, we do not expect the child to say all sounds clearly. Pa, ba, ma, such sounds may be clear, but I don't expect a 2-year-old to always say ka, ga, da to be correct. So even that has a milestone, like clarity of a milestone. So it is okay. By 3 years, the child is able to say ka, ga. It's fine. Some children takes time. Now, coming to 2 years to 3 years, the child will start making simple sentences. Amma, enakku juice venum. Appa, ice cream. Vangi. Maybe kodute or all that they won't be able to say. Sorry for my Tamil isn't very perfect. Okay. And so, the sentence lengths are increasing. By 4 years, you could see they start asking questions. Why? Why do you want this? And the sentence length actually increases. They will tell you experience of the past. I went out today. I went to the park. All these things. By 5 years, they are able to make small narrations, little stories, all this. Believe me, some children are really faster than this. They achieve this before they are 3 years nowadays. Okay. Next slide. Now, why do you think in children with autism, if you have seen, you might have all come across, or from today morning, we are all saying communication difficulties. The child is not speaking. If you have seen children coming to you, you might have seen that there is communication difficulty. This is the main thing parents complain and come to us. I don't know what is occupational therapy complaint, but usually it is same. They identify the problem because the child is not talking. So why do you think the child is not talking when the child is having autism? Anyone guess? Why the child is not talking when the child is having autism? Only because we mentioned it, okay, that is the characteristic of autism. But why? Can anyone think more than why? Why is the child not talking? Why the child is finding it difficult to talk? What could be the reason? I'll guess. Yes. True, ma'am. So, for speech and language development, we say we require certain prerequisite. One is cognition. The child needs to have good cognition to develop proper speech and language development. Second, as I said, when a child is speaking and he developed his first word, everybody thinks that is the beginning of his speech development. Actually, speech development starts in the womb. That's what we say. Leave about the womb. In a sensory aspect, if we talk, for speech to develop, I need the child to listen to us first. Child should get little bit regulated, at least listen to us, attention, joint attention, has that thing to interact with us, to build some connection with us. Then only the child will speak. We lack all these things when the child is having autism. Naturally, it is very difficult for the child to develop speech or language. So this is what is happening. So I request all the OTs to please make the child little regulated so that we can proceed further and teach them something. Okay, so we'll come to that more in detail. So the child is not talking because we say we need some pre-linguistic skills, as I explained. So more importantly, what we consider the pre-linguistic skills is, one is attention, eye contact, sitting tolerance, and turn-taking skills. So this needs to be focused well if the child has to come to us in a therapy and sit. I know maybe as I say, it's not easy to get all these things. Okay, next slide. Now, how is it happening? As I said, when we are producing speech, the articulators come together. Now, a child who is having tactile aggressiveness or in the oral levels, or he is not getting a proper feedback to the brain, will he able to have a proper vocal play in the beginning stages? He won't explore. Later on, if we are asking the child to say tata, say bye-bye, the child doesn't like the touch of the tongue in the roof. Child doesn't like the touch of the lips together. He will refuse to do that. So identifying the child's problem in the sensory part is also important for us as speech therapists. Next. Don't change, huh? Don't change. Okay. So when a child is not attending and to the mother, how will the language develop? The child has not seen the mother talk anything. You call his name, he is not responding and he is not paying attention to you. So this thing will not make the child to look at his environment in a patient way. So what we do, when a patient comes to us, we speech therapists has to make the child sit first. So we focus on some attention activities. We ask the child to play something with us. Slowly we introduce speech. And we have to give assessment accordingly, and then we do. We'll come to this next. Now, language acquisition theories. I think this would be very Greek and Latin to you, maybe. Is it? I have heard about it. Has anyone heard about this? Okay. So, see, actually there are many theories. I have put down few theories which I felt was a little important. So, we'll discuss how this, according to these theories also, how our children with autism, it is difficult for them to have normal speech development. So, coming to the first theory, this theory was given by B.F. Skinner in the year 1957. He said, language is developed by imitation and repetition and reinforcement. So he says, for example, if the mother is giving the child a ball and the child likes to play with the ball, the mother keeps saying ball and shows the ball and says ball, the child starts imitating the mother and the child says ball, mother says very good, get reinforced and the mother starts giving the ball. So the ball itself acted as the reinforcer. Child says ball, mother gives the ball. Repeatedly this keeps happening. Slowly the child picks up the word ball. This will happen with many different things in different complexities, and thus language developed. Now, after some time, someone felt only this theory couldn't prove speech development. So they said, then they formed the nativist theory, which was developed in 1959 by Noam Chomsky. So he said, language is an innate ability. We human beings has an innate ability to produce speech. For example, his argument was, if I give an imitation, I give something, I give a stimulus, keep reinforcing, even dogs or cats couldn't speak, right? Only we human beings are speaking. So why? That is because we have a brain which has certain systems in it or certain capability which is able to produce speech. He labeled this as language acquisition device. Okay, and this language acquisition device is innate. We are born with it, and because of this ability, we are able to relate to the environment and produce speech. Now, in 1964, Jean Piaget, he said, language happens along with cognitive growth. Now, in my first slide, I had explained a child looks at an apple, make a mental image of apple, and then when the mother, when someone says, he recalls, he keeps it in the mind, and thus he formed a concept saying that this particular thing is apple, and a concept development also happened. So cognitive theories, cognition is the key. So along with cognition, your language develops. So the more complex the child learns concept, the complexity of language also improves, and the child's language development goes hand in hand. Okay, next is social interactionist theory by Jerome Bruner. He says language develops because of caregiver and the social environment of the child. Now, this theory we can relate. Many times, if the child has the innate ability, the child is not getting any environment for communication. Right now, because of mobile phones, we have seen many parents just looking and scrolling at the mobile phone and hardly interacting with the child. Now, these children are not getting proper stimulation from the environment, and naturally, they are having speech delays. Many cases are reported nowadays. So, this can be related. Caregivers' interaction and environment's interaction is a must for child's language development. Next is socio-cultural theory by Vygotsky. In this theory, social interaction and guidance from knowledgeable individuals is said. It's similar, but here they say that how a child interacts with the persons around, like how knowledgeable the person around is, how much knowledge they have, how much they share with the kid, that much the child's language and other abilities improves. And last is connectionist theory. According to this theory, it says through different experiences, sensory experiences or experience around the world, the child forms a neural network in the brain. Every new experience is creating a new neural network in the brain, and that neural network is stored, and that is forming different developments, language developments. So see, I've made it really short because if I keep explaining, this would be like for an hour. Okay, so this is what is happening in language development. Now, next slide. Now, according to these theories, what is happening in children with autism? Now, you see, okay, before that, all these theories, we couldn't say that this one particular theory is right. It's like we have to see to all these theories, take a combined message from it, and then think together. That's how language develops. Not a single theory is right or a single theory is wrong. Everything is being proved, and that's why it's called theory. But everything has its part which explains us language development. So, together everything we have to consider how language develops. Now, when according to Bihari's theory, what happens is, children with autism As I said, they have lack of eye contact. They don't look at our face. They don't sit in a place. So, naturally, they find it difficult to imitate also. Now, imitation difficulty could be because of one more reason. I guess you might have heard of apraxia. So, oral apraxia is still there. But in many cases, there is non-verbal apraxia. Structurally, we won't be able to see that their child is having apraxia. But when we ask them to repeat words, we could see apraxic component in them. So, they may mispronounce. So, usually we find it out by seeing that the errors are very inconsistent. If the child is saying pat one time, bat one time, other time he might be saying pat. Or something totally different. But a child or he has difficulty to produce the sound itself. And this is very commonly seen in children with autism. So again, because they have such issues or their brain process in a different way, they find it difficult to imitate. Again, if imitation is not there, speech development gets delayed. Next, according to nativist theory, what happens is, we know our children are neurodivergent, their brain process differently. Again, the nativist theory doesn't work because brain is different. Similarly, the language acquisition device would also be affected. Again, high chances language development gets delayed. Next, cognitive theory. Here, they are saying the cognitive language development is difficult because the child has less attention. Play will be different. Flexibility of thinking is different. The cognitive theory also, according to that also, children with autism will have issues in developing speech and language. Interaction theory. We know our children is behind in social communication. Some are very rigid, they don't want to communicate. So again, this theory fails because again, they don't give joint attention. They have very less interaction with the caregiver and the environment around. So again, that is affected. So again, to talk with knowledgeable individuals and learn from them, our children again has problem. They doesn't communicate, they doesn't open up or start interact or they doesn't connect to such people. So naturally, a normal pace of development gets affected because of sensory issues too. Next. Now assessment. First I'll tell what we do in assessment and then I'll tell where I need yours help for assessment so that I can make my skills better. As a SLP, when a child comes to us, first thing we do is we listen to the parents' complaint. And most of the time it will be like, he is not speaking or he speaks very less. And they highlight the thing is that he doesn't have any other problem. So, we have to look at the child. We assess using language scales. Most commonly, the areas we assess is receptive language and expressive language. Now, receptive language is how much language does the child understand. This includes your comments. Is the child following one stage commands, two stage commands, three stage commands? All this, we have questionnaires for that. We do check with the child directly. Is the child able to follow particular thing? Is the child understanding body parts? Is the child understanding labeling? All this. And we score the child accordingly and put them in a particular age group. If a 3 years old child comes, we'll see at what level his reception is. Is he able to at least functioning at what level? Expression, similar way, we see how much the child is talking, how much he is able to do according to his age. Usually, children with autism falls behind. Most of them has a delay, at least a year or two. If you see a 3-year-old, he might be usually functioning at 1.5-year-old when we start sessions. Rarely some milder autism or some verbal autistic cases, we do get better. Now what happens is, when the child is totally verbal, Many times what we see is there is a discrepancy between the receptive skill and expressive skill. So, a little before, ma'am had told about echolalia. So, anyone remembers what is echolalia? Everyone remembers? She said that it is repetition. Okay, the child repeats whatever we listen, we say. So, why is echolalia happening? No, sometimes it is totally sensory. They seek whatever they hear and keep repeating. But some children, it is because of the discrepancy between receptive and expressive language. Normally, when a child is having language delay, what we see usually is reception language is much ahead than expressive language. Very simple to understand. If I want to say something, if I want to talk about suppose autism, I need to first understand or listen to someone's class and myself have an idea what autism is, then only I can talk about it. So first I am developing my receptive skill about it, then I start expressing, then only I can tell someone, okay, this is autism. So first I need to read up, have an understanding about it, and then start talking about it. Similarly, when a child is developing language, first reception comes, and then slowly you will be able to produce speech. So, but in children with autism, what we usually see is they are saying big phrases. Some even say the whole story which is heard before and keep narrating it back. But these are parrot speech. They don't even understand meaning of anything from that. I have seen cases where the child comes to us and the mother says, if you ask him the name in a particular way, he'll answer. He says big thing. School ku pone time agumbodhu, he'll say bag edutittu va. Why? Because that is the I hardly believe the child actually understands bag. Child actually doesn't understand the word idle. Child doesn't understand the word va also. But he will keep simply parrot speech, bag edutittu va. So that is not language development. Child has developed some speech, but meaningless. It has no functional use. So this is what is seen in children with autism. Now, sensory processing, why we need to assess. As SLPs, we are not taught to assess sensory processing. We do not assess also. But I know as OTs, you do. So, but we need the reports of sensory processing because we need to arrange a session accordingly. Now the child has come with all the sensory problem. Welcome the child. I made him sit in the session and the child ran away. Actually, this happened with me when I was a student. I was a second year student. Maybe if you people are interested, I can share my experience. I was a second year student, very new. My teacher asked me, Arya, go take this patient. I was so happy. I thought I'll do this, I'll do that with the child. The child entered the therapy session. Sadly, the mother had not come. And someone else got in, dropped in and went off. I was the only one with the child. Child entered the room. I took it there in my college. We used to make them sit on a high chair. So I was just opening the thing of the table. It has a lock. So I ran away from the session. I had to run behind him the whole college to catch hold of the child and make him sit. Now, why do you think the child might have run? Because many reasons, I was new therapist for him, he might have not liked the change. He might have had a lot of proprioceptive issues, but this was not addressed. And the child, I don't think so, had gone to OT. But if I had got an input from an OT, how to make the child sit, how to make him aware about it, maybe I would have done better. So similarly, I need the OT part because I need them regulated. So when a child comes to me for assessment, I ask them at least to go for a month of occupational therapy and then come for speech therapy. Because I want a minimum sitting tolerance to be there, minimum look at my face, minimum have some basic eye contact. I'm not saying the child should sit for my whole half an hour session looking at me. No, I need the child to be a bit regulated, but I need strategies for this. Who can help me have the strategies? You people. Oh, come on, next. So we need sensory-based sensory-based intervention strategies. So, for example, I used to have a child. He used to come for my session, and he was again very hyper. He was seeking movements always. He used to not sit. At that time, the mother used to be very upset because the child's age was higher, so I couldn't tell them that you can't come for speech therapy because more delay will cause him not. But I want somehow the child need to attend to me. So I spoke with the occupational therapist. She suggested me to make the child swing for some time because he was liking it, and I started using swinging for him. So, and one more thing what I did is I always took his session once he finishes his occupational therapy, and immediately I get him for speech therapy so that he sits for some time. Slowly I was able to make him sit, attend to me. I made his activity also a little playful. Slowly he started picking up words. So this was possible because I discussed this with his OT, and she gave me her input, and that's how that child developed few words. At least, I think after a month or two, he started speaking a little bit. Okay, so this is what I expect. Next. As the sensory integration, I think you people need to help me in this. Then we can have targeted communication strategies. Now, communication, what we do in speech therapy might be your question. We have again types of children. You people also know verbal and non-verbal. Will all children be able to speak is a question. No, all children cannot speak. Some children doesn't has one thing, maybe the age has gone really up. We can't keep trying for speech, but what we need to facilitate is communication. So we actually try and provide communication more than focused on speech. But what is happening practically is, especially here, the moment you say your child needs picture exchange communication system or your child needs AAC systems, parents run away from the session. They don't want their child to be non-verbal. They bring their thought is, I brought the child to you only because I want my child to talk. They don't allow me to do AAC or picture exchange communication system. PEX is also a type of AAC, but they don't allow me to do any alternative or argumentative communication. Now this is very common among our Indian population, so we need to make aware. I think as OTs, you people also will help to, because what happens is, once we give communication, many of the children calms down because they have a mode to express themselves. And we have seen them doing good in other areas also. But family acceptance is very important. Another thing what is, once a child gets an opportunity to communicate, like through AAC and all, slowly the communication pathway opens up. Many times children starts developing few words once we have introduced them to AAC. So right now, being very practical, I don't want parents being away from the sessions also. I do both, hand in hand for few days. Once the parents themselves start experiencing, my child is doing better with it, slowly I switch to AAC. Slowly once they feel the child is again back, is able to be verbal, we start back the verbal communication. But we have to give communication first. Third, combined approach. As I explained, when someone OT intervened in my session, helped me how to regulate the child, how to reduce his sensory issues, I got out. Another example I'll give is, I had a child who used to smell a lot. So and he was behind the, soap smell, perfume bottle smell. So his mother used to, how I included it in my session is, I gave him activities and this smells so, and I started using visual cueing. I think Sucharitha ma'am helped how we should give cues. So another practical thing what I have experienced this children gets more hyper or doesn't listen to us if they don't know where a particular activity ends. So if we tell them, you do this, you do this, you do this, and you are done, they are ready to listen to us more. So like visual charts actually help us, gives them visual cues, helps them, and once they are done with it, we tell, okay, this is done, this is done, this is done, the child sits better. Again, the smells were used as reinforcement because he loved it, he was seeking it, and he could do. And another thing what we started using is giving sensory breaks. So similar sensory issues many kids had. So we used to, between our sessions, we used to give the sensory break for whatever sensory seekings they have, or if they wanted moments or something, we used to discuss it and then we incorporate it in our session. Next slide. So now environmental factors. Again, I think we have to discuss it with you. Bright lights, all these things many a times affect environment. This environment affects children with autism. So many a times what happens? We have to adjust the environment. Many of you, I always felt the OT setups looks very fancy and ours looks very boring. One reason to it is that we have to make the children sit and focus to whatever we are giving. We do play-based activity. But sometimes, because he has to listen and looking at our face is more important than around. So we have to keep our settings very simple. Less distractions, not looking around, bright pictures, we have to avoid it. And other thing is like, maybe I would love to add, as I said, swings or something in a separate section where we could give some sensory activities to the child in breaks. So in breaks in therapies, so that the children listen to us in a better way. So I expect all OTs next time even consider us and tell the parents what are their sensory seeking or reinforcers, sensory reinforcers which can be used at home and during other sessions. Okay. Next. Okay. Next, another thing what I have come across is, we have, as Indians, we are very blessed in a way. When we have a child with autism or any other problem, what I have seen is like we have an extended family supporting us. But if you see in other nations, we are very nuclear family. We have no one supporting us. So for us Indians, joint family setup or our culture itself is a boon that we can actually help these children. So if you see, many times what I see is parents are always kept outside the session, and especially, I don't know about OT, but when we see speech therapy, I always feel parents outside the session is no use of the therapy, because you have at least some physical activities, or you can tell the parents, okay, do this, do that, but we can't do that. We have to make the parents experience. A child getting up in the morning till he sleeps at night, there is lot of opportunity for him to communicate. So we as therapists, what we do is, we change the way how the parents talk to the child. So for example, I can tell you is, we give language stimulation technique, which is the basic technique which we give when a child comes to us for therapy. So first thing we do is self-talk and parallel talk. We tell the mother, whenever you do anything, tell this to the child. But again, will a child listen if the mother keeps simply telling, okay, I'm going to cut vegetables, I'm washing vegetables, I'm going to cut the tomato, I'm going to make a chutney for you. If I talk in this tone, do you feel the child will listen when the child is having already so many issues? No. For this, the child needs to be there, the mother needs to be there with us in the session. See how we talk to the child. I usually say, make the child sometimes little forcefully looking at my face, looking at my oral movements, and then talking like this. So again, I talk to the child. Maybe you people find it funny in a sing-song manner. I have lot of intonation. Okay, for example, if I am doing something, I say, பாரு என்னோட கையில ஒரு ball இருக்கு இது என்ன ball. This is the pattern I talk to the child. I don't talk to a normal. I feel you people might have found funny, but this is the only option to grab their attention. No other way. Repeatedly I say a word. So sometimes I stress the word ball, and repeatedly I give attention falls on that. Slowly the child starts picking it up. So we give this. Second thing, we ask the parents to say whatever the child is doing. Like if the child is playing so same going to talk in a sing-song manner, even though it sounds funny. This is the only way I can grab the attention. So this is how we put language into their brain. And many times, if parents are not with us, if I don't make the mother do this with me, I'm sure this will not happen at home. A child spending just half an hour with me or to 45 minutes, a child with lot of time from that is a question. So I need to put this technique to the mother from morning to evening. What is happening? She needs to bring this communication into life. Like she need to make the child communicate. Excuse me, I can hear a lot of chit chat behind. Are you finding it very boring? Yes? Is it? Should I need to stop? Okay. So this is something we have to do. So I always feel mothers inside the session, at least the caregivers inside the session is a must when it is for speech therapy. Only in rare cases, sometimes children with lot of behavioral issues, craving for the mother, doesn't listen. Few session, that too I don't throw the mother out for a whole session, maybe few minutes or sometimes for 1 or 2 sessions. Later, I always incorporate the parents inside the session. I think for speech therapy, this is a must. Parents outside the session is not going to bring any changes in speech in a child, because we alone working for half an hour will not work. Next. So, same thing, next. So here I told about how sensory integration is important for speech development. I hope you people have understood how different senses is responsible for your speech development. So if that is not well regulated, we'll have issues in speech and language development. So there are some case studies. I had shared few cases with you, my experience, but these are some published cases. Here we are talking about a 4-year-old kid who had problem, hypersensitive to everyday sounds. So he was avoiding verbal avoidance behavior and limited verbal interaction was there. So through systematic auditory desensitization activity, he improved his sound tolerance and his participation and expressive language was improved. I have put the references if anyone is interested to read it, he can take it from me. And next, they are talking about a 6-year-old girl with autism. So she had poor sentence formation, difficulty in social communication, multidisciplinary intervention combining sensory integration therapy and speech therapy. She got good improvement in body regulation and expressive language as well. So these are some evidences when we work together, we can achieve better. Next. So what is the current research showing? Ma'am had told about lot of AAC devices, assistive listening devices, assistive devices, etc. So now AI-based AAC systems has come. She had told if we type text-to-speech conversion and all these things, under research is much more. Recently, I had come across a conferences from IIT Madras, and they are actually researching on if a child is making errors, or some adult with stroke or child with autism and has errors while speaking, or the speech is not at all clear, and the person in front is not able to understand what they are saying. So what they were developing is the errors in the person's speech is being detected, that is corrected, and the device will emit a clearer speech output. So the person will have better communication. So similarly, technology has advanced a lot. Many new things are coming up. Again, in sensory integration, VR systems, people and all are, no, they are bringing up systems which will help in sensory integration. Such researches are also there. I don't know if it is market available and when it will be available and all, but such systems are coming. Another thing that we saw is like when the child is going to have a breakdown or something, they are providing a system where it will, like a watch, it will see what is happening to the child. I don't know how practical this will be, but these are all under research. Come, next. So again, we have to work in a multidisciplinary team because, as I said, for us to get output, I have to take the help of occupational therapists. Not only in speech, I think even when it is feeding, I don't know if you people work on feeding difficulties, okay, even we do work on feeding difficulties. So many times we clash. What he does, you does. Instead of keeping an ego, it's my job, it's your job, better let us work together. You are part, I do this, you do this, and share the experiences so that I can put my own information. Now coming to the feeding part, I think OT, I don't know, that's my thought, OT has to help me when it is oral sensory issues, then causing feeding issues. Because I always tell the OTs, please work and give me on the oral sensory part so that the child feeds well. There are other issues. We work on dysphagia, where the child has difficulty in swallowing. Mostly children with autism has this less, but when it comes to children with cerebral palsy and other issues, dysphagia and other thing, where the swallow itself is not initiated. So we have to work on those exercises, and then I think then a speech therapist plays more role. We are more into swallowing difficulties than feeding difficulties. If people are more into feeding difficulties and sensory issues of the oral structure, so that the person is. So that's it. We have to share our knowledge. We have to share our experiences. We have to see the child as a whole, not like, okay, this is OT part, this is speech part, this is special educators part. Because I have seen some special educators, sadly I worked, sadly not in Coimbatore, some other places who used to do a wonderful work. I I have to tell about her because she was a wonderful special educator who I have come across in my life, because she used to even work for speech better than me. I had no problem in accepting it because I learned a lot from her. She has an experience of 30, 40, like she's very old. And what she has taught me has actually brought a lot of changes in me as a clinician. So ego of saying that I am OT, I am ST, I am special educator doesn't work. Many times we also have to depend on behavioral therapists because some behaviors many times doesn't stay in our hand. We know ABS come into Coimbatore, lot of contradictions happening, lot of issues happening, but sometimes we can approach a psychologist. We need sometimes behavioral therapy support also. We need pediatrician support because we might miss out some severe problems in children because, and when something tragically happens, that's when we feel okay. Because I have come across cases where severe metabolic disorders and passed away. I had two cases. I always felt if someone would have sent the children to some pediatrician for a detailed checkup and understood the child's problem, maybe this would have stopped or this would have not happened. So again, we need pediatricians in our team, we need special educators, we need OTs, we need SLPs, and if anyone, and parents. In the section for us in speech therapist, are the key players in autism therapy because more than as therapists, they are with the child, it's their child, they know the child better than us and better than us also. So we have to train the parents, which is more important. Next. So practical tips for us SLPs is actually we have to consider a little bit of sensory processing assessment also in our therapies daily. I hope you OTs will help us with it. Next slide. I think I spoke about it. AI powered tools. Next. So here what I'm trying to focus is sensory processing found the foundation for us for speech development, and individualized assessment is required because what I see in one child is not what I see in another child. A particular technique used for one particular child will be not effective in another. So individualized assessment plays a key role. Next. So these are my references. If anyone wants, I can share. Whatever I spoke here is mostly from these. Next. And thank you. So I hope we'll see again in our practices, and hope we'll collaborate, work together so that we can build a better future for the children who comes to us. Okay? I hope I was, like you people understood whatever I said, because my domain was totally different from what you are learning. I hope you understood little bit of language acquisition theories, little bit of speech milestones. Sure? Understood? Or it was very boring? Okay. Okay, so thank you so much. I would like to thank the board members of Abirami College. I would like to thank the organizing committee, especially Shekaran sir and Harini ma'am. Thank you so much for inviting me today. It was coming in Coimbatore. I never gave a public talk. It's a long time. I am in a stage giving a presentation. So maybe I had a lot of flaws because of that. So I'm sorry for that. And thank you so much once again to everyone, and whoever has attended patiently, again thank you for all of you. Okay, any questions? Any questions? No?
Everything was understood. Okay, someone raising the hand. Yeah.
Before that, Arya, I would like to congratulate, like you have extended your speech was very nice and it was very heart touching. You mentioned about multidisciplinary approach, but actually our expectation is for transdisciplinary approach with all the faculties.
Yes.
Hopefully we'll be having the Varam project in our Sree Abirami College.
Okay.
So it will be having all the specialities, even the rehabilitation psychologists, as well as the speech therapist and special educators with physiotherapists as well as occupational therapists for autism children.
I think Coimbatore lacks such a setup.
But definitely not the ABA, because even I think Abhiksha will accept this, because in our NIPMAT, we never, even homeopathy we will be interviewing in NIPMAT, but not the ABA. Even I am very fond of Dr. Smita Avasthi ma'am. I did some of the ABA techniques. Even I am one of the certified member for PECS, which I think only the speech language pathologists will do that. But to understand about what is PECS and what is ABA, so I did my certification. I am one of the certified in India. But the phases of 6 phases of PECS, the only 3 phases which we always do it in the mainstream school. But mostly from the 4th phase, it becomes monotabous. So which might affect some verbal communication of the child, but it's a myth. But still we don't get into it because it needs a lot of science into it. So I just want to have one more explanation. I know that most of them are bored and waiting for the valedictory function. Can you just tell about what you believe about teletherapy in our profession? Not only speech therapy, it's in rehabilitation profession, so that they will get an idea of
This would be my personal opinion, sir. Personally, I always feel one-to-one therapy is the best. Teletherapy, during COVID times, children were at home doing nothing. It is actually very difficult because we are the ones, we always preach, no screen, no screen, no screen. But we keep saying, and we ourselves are bringing screens in front of them. I cannot digest it personally, so I always say, if you have no options, okay, come to me. Again, if teletherapy practice is there during COVID also, I never made children to sit in front of the screens. I guided the parents, showed some activities to the parents, asked them to do it at home. But nothing works like
professionals.
One-to-one therapy. I don't know about OT, again I feel it's the same. I never. But again, teletherapy and speech therapy works. Voice therapy for adults or even children who is actually that attentive. Stuttering therapy. That given the child should not have any other issues like autism. In case of issues like ADHD and autism, I'll hardly recommend teletherapy. But in voice cases, in stammering or stuttering cases, okay. In dysarthria, where we have to give oral exercises, works. Adult also to an extent. Again, a patient with aphasia, very difficult to have teletherapy. But certain type of aphasia, maybe we can. So it varies patient to patient.
Yeah, thank you, Arya.
Thank you, sir.
Thank you, all the students. Actually,
one person was asking a question, had raised the hand.
First of all, thank you so much for your clear explanation about the interdisciplinary approach of speech-language pathologists in occupational therapies. And here I have a doubt that you explained about your therapy voice with the child and how does it impact in the home where the speaker of the home will follow the voice in the conversation.
Actually, you are not very audible to me. Second, you have some accent. Being an Indian, I find very difficult. Can you come little forward and speak little slowly so that I follow?
Okay, now I'll just repeat it again. And you have said about your therapy voice with the children. Now, the children that you follow.
He has some accent. He was abroad or somewhere, I guess. Huh?
Monotonous voice. In home therapy, monotonous voice.
Ma'am, you said about your therapy voice where you'll be...
Voice modulations I made, how it is.
Yeah, and in home where there'll be a monotonous voice.
Okay, I'll give you a practical example. You talk to a child something like, hello, your name, everything. A child with autism. Huh? Will he look at you? Do you feel he'll look at you?
No, ma'am.
Sing something little loudly. Will he look at you?
There may be a chance.
Same thing. So, your brain process differently. If you go into theory, the right brain process melodies and intonations, and it is proved in certain studies that these children find it easier to process melodies and tones. So once we talk in a little bit sing-song manner, it grabs their attention. We use that to grab their attention and give language stimulation. That's it.
Okay, thank you.
I hope you understood.
Okay, actually what I'm trying to ask is, voice modulation in therapy is okay, but after the therapy session, they'll be leaving to their home where the parents won't use that sort of voice modulation. And again, they'll again come to
I train the parents who come to me to speak in a similar way. Again, I don't keep, once the child has started picking up basic language, some words, or he starts following us, this is not kept like parents don't have to keep talking to them like that. Initially, few sessions, maybe few months, they have to do this. We train the parents do it so that they listen to us. It's not like, it is not like we have to sing or something. It's like the stress is given to different. So we say intonations to it. And for example, one word. You follow Tamil?
Yes, ma'am.
Okay. தண்ணின்னு ஒரு வேர்ட் சொல்லி கொடுக்கணும். இப்போ எப்பவுமே நான் சும்மா ஒரு இதுல தண்ணி சொல்லிட்டு இருந்தேன்னா ஒரு ஃபிளாஷ் கார்டு வச்சுட்டு தண்ணின்னு சொல்லிட்டு இருந்தேன்னா ஐம் ஷுர் த சைல்ட் வில் நாட் லேர்ன் தண்ணி பிகாஸ் த சைல்ட் ஹார்ட்லி ரியலா அவனுக்கு ஒரு கிளாஸ் தண்ணி கொடுத்துட்டு இப்போ நான் அவன்கிட்ட சொல்றது ஓகே பாரு உன்கிட்ட என்ன இருக்கு உன் கையில தண்ணி இருக்கு இந்த தண்ணி மேல ஊத்த போறேன் இந்த கிளாஸ் ஊத்த போறேன் இந்த தண்ணி இருக்குது 10 times I say the word தண்ணி in different intonation and stressing the word தண்ணி somewhere it will go into his head. Sure, this is what happens. Okay, but maybe if I take 10 flashcards and show me தண்ணி ball, no, but in the madri if we do, he may register it. Okay,
thank you.
How do you have an accent? You are abroad somewhere.
Not like that, ma'am. In my school, we just used to speak like that.
Your school teacher?
It's ALM Vidyalayam near to Pondicherry.
Near Pondicherry. Okay, maybe you have that Portuguese school or something.
No, I like.
You found it very amusing to know. Okay. Okay. Anyone else? Any questions? We express our appreciation to Mrs. V. Abirami ma'am for our enlightening session. May I now request our director, Dr. Sucharitha ma'am, to present a memento as token of appreciation. I request Dr. Sucharitha ma'am to share a few words. I request our director, Dr. Sucharitha ma'am, to share a few words. Hello. Good evening, everyone. I think all of us have come to the end of the session. Hope all of you would have been benefited from the national program that has been conducted today. Thank you to all the Abirami College staffs, the convener, Dr. K. Naresh Babu sir, organizing secretary, Mr. Jnanasekaran, and all other occupational therapy staffs. We all had a very good speakers today, and also the questions that you had asked at the end of each session would have been benefited, I think so. So I congratulate and I also encourage the college staffs to conduct similar sessions continuously every year. Keep it up and thank you. Next, I call upon Mrs. Anita Manoharan ma'am, PBG College. Next, I call upon Dr. Vincent Jairaj sir. Next, I call upon Dr. Vincent Jairaj sir. Next, I call upon Dr. Abhiksha Bishwal ma'am. I'm honored to call upon Dr. Naresh Babu sir to present the Academic Excellence Award. First, I call upon the faculty of KMCH College to receive the award on behalf of Dr. S. V. Praveen sir, Principal of KMCH College. I call upon the faculty of KMCH College. Next, I call upon the faculty of PPG College to receive the award on behalf of SenthilKumar sir, Principal of PPG College of Occupational Therapy. Next, I call upon faculty of Krishna College to receive the award for student representation.
Next.